Thank you very much for being here today, and welcome. This is the sixth hearing of the committee's inquiry into the equity, accessibility and appropriate delivery of outpatient and community mental health care in New South Wales. And of course we all acknowledge that we are here on the lands of the Gadigal people of the Eora Nation, who are the traditional custodians of this land, and we pay our respects to those people and acknowledge any Aboriginal and Torres Strait Islanders who may be joining us today. My name is Susan Carter. I'm the Deputy Chair of this committee, and a reminder that everybody in the room should have their mobile phones turned off or on silent. Parliamentary privilege applies to witnesses in relation to the evidence they give today. It does not apply to what witnesses say outside of the hearing, so I urge witnesses to be careful about making comments to the media or to others after completing their evidence. In addition, the Legislative Council has adopted rules to provide procedural fairness for inquiry participants, and I encourage committee members and witnesses to be mindful of these procedures. I wonder, could each witness, starting from my left, please state their name and position title and swear either the oath or take the affirmation. Perhaps Ms Hunter, starting with you.
Okay. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you. And just for the record, could you state your name and your position title, please?
My name is Tara Hunter and I'm the Director of Clinical and Client Services at Full Stop Australia.
Thank you.
I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
And your name and position title, just for the record, please.
I'm Karen Williams, Medical Superintendent of Ramsay Clinic, Thurrool.
Thank you.
Thank you, Mrs. Connor. Would each of you like to start by making a short opening statement?
Yes, I would. So thank you very much for having me along today. I would also like to acknowledge that we're meeting on Aboriginal land today, pay my respects to Elders past, present and emerging and any Aboriginal colleagues that are joining us today. I'd also like to acknowledge that in this space, the overrepresentation of the impacts of trauma, intergenerational trauma, racism, and how that impacts on Aboriginal populations and their mental health and well-being. So I think that's very, very much linked with what we're talking about today. So as an introduction, my name's Tara Hunter. I'm the Director of Clinical and Client Services at Full Stop Australia. We have history in 50 years of delivering counselling and trauma specialist services to people impacted by mostly sexual violence. That's where we started actually 50 years ago in October, but today we provide a range of services to all people impacted by sexual, domestic and family violence. In addition, our organisation provides a whole range of training and support, and we run a national survivor advocate program that was established around 2.5 years ago. We have now over 600 people with lived experience that engage with our survivor advocate program. We do a whole range of advocacy across federal and state governments and in other settings, and the work that we do is informed by the lived experience. So today the information that I will be referring to will be based on the clinical experience of our organisation, but also that lived experience in terms of some of the consultations we've undertaken in this space. I'd like to thank you for undertaking this kind of inquiry. I have been a social worker for over 25 years, and I have to say I've found the mental health system left wanting for much of my career. And in the space of when we're talking about people impacted by domestic and family and sexual violence, we know there's a huge overrepresentation of people impacted by violence in terms of the mental health outcomes, but also the potential vulnerabilities for people that are living with a mental illness. So it is very difficult to talk about mental health services and accessibility without addressing trauma and interpersonal trauma. That said, in my experience in trying to refer and work alongside mental health services, often I find that the services themselves are not well versed in screening or working with people impacted by trauma and complex trauma, and that the workers, and that's not about taking away their professionalism and the absolute demand that they have to work with. Also, there's not always that specialist skills around acknowledging and working with people's trauma. So in thinking about today, I guess what we would really like to see is a service system that actually is much better resourced from a very practical sense of having better availability of services. We'd like to see services that are not just one issue focused, that it actually takes in people's whole of life experience, including a very clear lens on the impacts of sexual, domestic and family violence and trauma and how that might present in a mental health context. From a perspective of the organisation I work from, where we're an intersectional feminist organisation, so part of what we see here when we talk more broadly about mental health services, there are accessibility issues, but when we look at populations such as Aboriginal people, people who identify in the LGBTQ plus communities, people living with a disability, people from non-English speaking backgrounds, and migrants and refugees, all experience significant barriers to access mainstream services. So part of what we would like to see is looking at cultural safety more broadly, understandings of trauma and trauma-informed care in mainstream services, but a consideration of some of the specialist services that might be more accessible to populations that often remain hidden in this space. And thank you again for having me along, and look forward to answering whatever questions.
Thank you. Dr. Williams.
Thank you. Thanks, Tara. And I'd like to also thank you for conducting this inquiry. If I sit here today before this panel and say that women who are currently being abused or assaulted have poor mental health, that would seem pretty logical. And if I said that, women who have been abused or assaulted in the past 5 years have poor mental health, and that too would also seem pretty logical. In fact, about 50% of women who have been abused or assaulted will receive a mental health diagnosis by a mental health professional. So when a quarter of Australian women have experienced family violence and another fifth of women have experienced sexual violence, there's a lot of poor mental health and a lot of diagnoses, but unfortunately that has not translated to a lot of treatment. So I'm here today because I think it's less logical, less believable to comprehend that within our public health service, with all the money being spent on mental health, there is currently only one publicly funded psychiatric bed dedicated to treating these survivors. That if any one of these women are to feel acutely suicidal, there is no public service I can send them to safely. That the only unit completely dedicated to treating abuse survivors, providing evidence-based holistic model of care, is a small private hospital that I opened over a year ago, and that the government at the time agreed to fund one public bed. Would it be believable if I told you that there are so many referrals from GPs and from women themselves that we don't have the time to read them all, or let alone see them all? About a quarter of mental health presentations to the emergency department are trauma survivors, and about 80% of them will be turned away without any treatment at all. In the psychiatric wards, 70% of the women have experienced sexual abuse in the past, and another 45% of those women will be assaulted whilst on the wards themselves. Every week, a GP will see at least 5 women who are currently being abused. females attending the GP for any condition at all are 580% more likely to have experienced physical, emotional or sexual abuse in the past. And all of these health services that these women are being seen in, the acute wards, the GPs, the patients are not receiving any trauma therapy, trauma education, or any diversional therapies that we already know are needed for PTSD treatment to be effective. So I'm here because I believe that if we want equitable access to healthcare, we have to do more than throw money at this system, a system that's not designed to recognise and address the underlying causes of these symptoms. So we do need funding for the development of trauma-informed services, but we also need to demand that the current service providers demonstrate how their services are, one, actually effective, and two, not harmful to survivors. There must be accountability on services and providers to follow through with the available research and the recommendations that the government has already funded in obtaining how to best treat this currently completely neglected population. Thank you.
Thank you so much, both of you, for being here today to share your experiences and your expertise. I've got a couple of questions, and I'll go to questions from other members of the committee. My first question is about the current community mental health system in New South Wales as it stands. We've had a lot of evidence already in this inquiry about the fragmentation, the difficulty for people navigating that system, that a lot of services have really strict inclusion or exclusion criteria. And I'm interested particularly in the impact that has on people who have experienced chronic or complex trauma, and if you could speak to that.
I mean, I think that the community mental health services as they stand, as you mentioned, they've fractured, and they've got such an overwhelming amount of people and that are trying to get in and utilise the service. And what their current service delivery model is based on research that has actually already been proven not to work. So we've rolled out this Project AIR strategy, and all the research has been conducted on demonstrated that although there was a reduction in patients turning up to ED, it didn't actually improve their health outcomes, and it didn't help the patient's symptoms reduce at all. And despite that, that's still the program that is being rolled out throughout the state. The program consists of 3 sessions with a psychologist, and I don't know anyone that can fix mental health with 3 sessions with a psychologist. But that funding continues, and so we're still using the same model despite knowing it's not working. And so for people that are going through the service and utilising it and not succeeding and not getting any better, there's a sense of hopelessness. You go in and you do what they say and you're not getting any better. And you have no other alternatives, especially this group of people that often don't have the funding to try different things, because there are some private services out there, you know, my hospital included, but if you don't have the money, you can't access it. So when a person is repeatedly experiencing that the treatment doesn't work, their trauma actually gets worse because it increases the sense of hopelessness. I'm broken, I can't be fixed, nothing I do works. And there's a frustration from those clinicians who, you know, say, we can't offer you anything more. We've done this with you already. And so the service providers themselves are impatient and overworked, and that, you know, makes these patients feel even more worthless than they already feel. So it's certainly re-traumatising to have a system that is blinded to what the patients actually need and sort of not offering any alternative or even an apology for, well, actually this isn't the service for you because it's not designed to help you.
So in my experience, again, you know, inaccessible services, more generally, I find that it's actually really difficult for people to even get in the door to get those 3 sessions. So the processes in which are used to intake and assess people have to be at a very acute stage. And when I think about community mental health, for me, acute should be actually through a hospital setting rather than having, community mental health should be around some of those notions around healing and recovery. But even when people are acutely unwell, it's quite difficult to get an appointment. I'd like to reflect on, in terms of the service that we provide 24-hour phone and online counselling in the New South Wales context for people impacted by sexual violence. So we often provide a significant safety net to people impacted that aren't able to access community mental health services. I'd also like to reflect in particular on young people, and when we look at the impacts of domestic and family violence, some really good recent data that says that children who are living in domestic and family violence from the age of 6 are requiring mental health services. It takes them to the age of 12 to even get access. And in my experience of working in a space where we're referring young people to child, youth and mental health services, again, the criteria is really challenging. There's a requirement often to work with family members, so there's a lack of privacy and safety for young people, particularly if they're having issues within their family setting. So the community mental health services, to me, are not, they're kind of the end of the road, and then we look at the other cohort of services that might be delivered through, say, the mental health care plans, and the wait lists are extraordinary. So what happens in terms of the impacts for people, and I think Karen's, outlined them really very clearly, but the other bit is that people are not seeking support at all. They may be at significant risk in terms of suicidality and self-harm, and they do feel helpless and a bit lost about where to go for support.
I mean, I'd like to add too to that, and just an example is I had a patient who, was on my waiting list. The intake for the community team had told them that, and I know this because I used to work there, if you have a psychologist or a psychiatry appointment coming up, you can't access us at all. You've already got someone. So she had gone in acutely suicidal. It took her 9 months to see someone because they had to wait for their private person, which was myself, but they'd also been referred to an organisation that was a step down from the acute unit and said, well, you can try there, but they said you're too suicidal for us to be involved. So she was shut down on every angle and was holding out, to see me, but it was a 9-month wait. She could have died in that time. And that's just completely unacceptable, whether people are being told you're not suicidal enough or you're too suicidal or you've got someone else. Having a psychologist in the outside of the hospital doesn't prevent suicidality, and the appointment times, as Tara said, it's so far away that you're waiting for. You get in front of somebody who's a psychologist or a counsellor and you say you're suicidal, they will often say, I can't manage this, the risk is too much for me to take medico-legally, you better get to ED. And with that, like I said, 80% of the people that turn up going to ED saying they're suicidal are going to be turned back. And you think of all of the people and all the money spent, they'll be seeing their GP, they'll try and see the psychologist, they'll see the triage nurse, they'll see the mental health nurse, they'll see the ED doctor, the psych reg, and they'll sometimes see the psychiatrist. They might get through 7 professionals, and in that time, which you're all paying for, they don't actually get any treatment in that time at all. You'd rather see that there's a direct service for them to go to where that same money can be pooled, because it's not like we're not spending the money anyway, but where they're actually having interactions that are therapeutic, not interactions which are essentially, I don't know if you're really mine, I think you should go to somebody else, and that's what I found at the community mental health team. We had meetings, and they still do them every morning. We'll have 12 or to 15 clinicians sitting around in a room going through hundreds of referrals going, yeah, let's not see that one, they've got a psychologist. Let's not see that one, they've been here too many times, we can't help them. And it's so much funding going into just rejecting people when you think of all of those people could actually be out there doing stuff. But because we're trying to tick boxes and fill out paperwork, meet legal requirements, we're actually not getting out there on the ground and helping people.
Thank you. I've got one last question, which is there have been a lot of calls for improving the level of training for the workers in the health sector and the mental health sector to provide more trauma-informed or trauma-sensitive care. I'm also wary that health workers really can't stand any more mandatory online modules. What would meaningful and effective training look like for the broader sector to provide better trauma-sensitive care?
That's a really, really good question, and it's really hard when there aren't clinicians doing that work a lot, so you don't have a lot of range for people to go and actually get the experience in watching what trauma-informed care looks like. So like I said, ours is the first inpatient unit. You could get the medical students coming through, you could get the psych registrars also coming through, and there needs to be funding, because as I said, we can't even see all the patients that are trying to get through this hospital to get us to then also train other people. The burden on that, and I'm talking about the time burden, is too much. So there are some organisations, Blue Knot is one of them, that has developed modules. I think that they must be compulsory modules. You would have spoken to the chair of psychiatry, and you'll speak to the chief psychiatrist. There has to be a demand on us as professionals that it's up to us to do it. It's not your problem. If you're going to pay them and they're going to get rebates, we have to prove that we're doing a good job and we're responding to that need. And I think that because we're not asked to do it, we don't do it. I would like to see, myself be audited on this stuff, and all my colleagues be audited, that we have to go, and we can't just choose not to do it because it's inconvenient and that we don't like doing the modules. We're not allowed to do that with any other condition. I can't say I don't want to learn about depression because I don't want to do a module. They have to learn about PTSD in women. They have to, and children. It can't be something we refuse to do.
And further to that, I think from an allied health perspective and a broader workforce perspective, there's a whole range of things that we can do. I think from a university perspective, and specialist course, we are left wanting in terms of there are an increasing number of courses around domestic and family violence and impacts of trauma, but we are absolutely left wanting even for people that come through undergraduate courses. So I think that, let's be systemic and actually highlight this as an issue for anyone that's going into a health or allied health profession that's going to be working on the front line. When we look at the prevalence of sexual, domestic and family violence and the impacts of that, it doesn't matter where you work, this is going to be an issue. If we're looking at mental health, then it could be very much part of the orientation process. We, as an organisation, we run 2-day training on complex trauma. But for me, it's also not just, the online module or the, even a 2-day training course. It's also about clinical support and clinical supervision within organisations, because it's all well and good to sit in a 2-day course, but when you're actually working with people on the front line, it's about having access to the appropriate clinical support and advice around some of the complexities that might arise. And I guess for me, it's also around the management and, again, doesn't matter where you're working, the impacts of things like vicarious trauma, where we are as frontline workers bearing witness to people's trauma and their stories, and actually having the appropriate acknowledgement around how that might impact on workforce as well. Because all those things, if we have people that are in our workforce that are already distressed, then they're not able to, they have a shutdown when they're hearing someone else's story. So it's not, I think it's absolutely not another online module. And I think Karen spoke to that very beautifully in terms of this is an important issue, and it's about time we actually acknowledge it's not just an extraneous part of mental health care. It's integral to any of the health care that we're providing for anyone that walks in the door when we talk about trauma-informed care, it is a universal precaution. So that it's about having a very systemic commitment to embedding that, including having a trained workforce.
Thank you. Mrs. Connor?
Thank you both for being here today. You've outlined, your evidence sits with evidence we've heard from other witnesses, especially the difficulty of pillar to post, if we might call it. One of the ideas that has been suggested that may be useful is if there were people who could assist to navigate through the system. Do you think this would be useful, or do you think the resources really aren't there to be navigating people towards?
It depends where they... I mean, I think there are significant gaps in the system, so it's about where they're getting navigated to, and I again would probably concur with some of the things that Karen's talked about, where people might, they'll attend a service or they'll present to ED and they don't get sent to reasonable follow-up care. So I think that would be a great option for people. But we need to actually have the scaffolding around where people actually have a good referral pathway to be navigated towards, because then again you've got more resourcing into something where you could where you could actually be bolstering up some of the frontline service delivery.
Dr. Williams?
So what I would like to say about that is I am absolutely in favour of sort of that peer support, because even if the services at the moment are not where they should be, and they're really not, and even if there are no places to navigate, having another human being that you can connect with is incredibly important to healing. We're just animals at the end of the day. We're not, some extraordinary beings. We're humans that are very social, and our bodies do calm down and relax a lot more in the presence of another person. So in terms of therapeutically and what we know for trauma, if you have another human being next to you that supports you and cares for you, your anxiety levels do reduce. Just like if you're patting a baby and if you're a comforting person, the baby stops crying. And it's the same with the traumatised person. If there is someone there to talk to, acknowledge the difficulties even to say, yeah, there isn't anything for you right now. Oh, yes, there is, a long wait to see your doctor. And that validation and feeling like, no, that I'm not crazy. I have hope. I have a place to go, and even if it's waiting, and an acknowledgement that the services are wanting, I have found that has been in our hospital one of the most therapeutic things that has happened, when you've got all of these women together, being next to each other, talking about how hard it's been, being diagnosed with 4 or 5 different mental illnesses and told that they're the problem and they'll get better if they take this 1 tablet or this 2 or even this 7 tablets. Having them talk about how hard that's been, and then being the joys of finding a place that's different and having just hope, just a little bit of hope, makes such a difference. And in terms of the acuity, I think it would, that definitely, I've not been able to cure the PTSD in the short time we've been opened, but there's been absolute reduction in people turning up in acute distress to the emergency department, because they know, and they've by the service and by the people that they've met, that's not the place to go when you're traumatised. Let's wait and see what we can get and try and find the things that are appropriate. But you've got much more empowered women that are saying, well, I know that's not going to be trauma-informed for me. I'm not going to go there and waste my time and be told, we can't help you, go home. They are at least waiting for the things that are going to be helpful and able to make more autonomous decisions. So I'm very much for peer support, as long as those people are themselves trauma-informed, because sometimes you have seen, really inappropriate commentary from the peer supports as well.
And the treatment gaps, in your observation, is it because we don't have enough of a sufficiently trained workforce in this area, or is it because there's perhaps an over-specialisation, so people feel, well, this isn't what I do, and it has to be somebody else who deals with that?
I think we can't ignore the social and cultural aspects of trauma. When we, as a profession, I'm talking about psychiatrists and other mental health professions, took us a long time as a profession to acknowledge that veterans, soldiers, and that they would come out of these traumatic environments and have mental health symptoms. And then it was only in the 60s that we agreed it even happened, and then we had to spend time developing programs to respond to that trauma. What we did was write definitions that said the person had to have gone to war, the person had to have almost died to actually even get that diagnosis. So the translation of using that diagnosis and the idea of a mental health disorder or syndrome or illness, whatever you want to describe it, that has not been used at all for the female population who have been traumatised on a day-to-day basis, even though the symptoms are exactly the same. So you've got a profession that is really far behind, and then, so I'm just acknowledging that. And then we're the ones that inform where the money gets spent, and so, it's those same professionals that are coming forward and saying, this is what I need funding for. I need funding for the veterans, I need funding for depression, or I need funding for borderline personality disorder, but they're not asking even, they're not asking government for health spending to be put towards PTSD caused from domestic violence. So it is not just the responsibility of any one person, it is a cultural shift that needs to happen, and an acknowledgement, and I think, like I said, a demand for accountability here.
And just picking up on the vicarious trauma that you've both been discussing, do you have any comments on the Royal Australian and New Zealand College of Psychiatry report about staffing shortages and burnout reaching crisis levels in New South Wales?
Yeah, look, I think when you have so many patients with these social issues that we're told we've got to note them, we've got to ask a question about poverty, and but then when you see that you've got a person who is homeless, or is currently living in an unsafe environment, and you've got nowhere to send them, but that's a different organisation, it's a different ministry. You do feel really frustrated and depressed and anxious about the fact that you're sending people that you've developed a bond with and you care about. You've got nowhere to send them, and you kind of can't. They're saying, well, I don't feel good, I want to die, or all of the things that they're coming forward to, and you're the only weaponry you have at your disposal is a medication, and that's not the thing that's going to help them. And it's not. So I do think that it takes such a long time to spend with these patients and get them to trust you and open up to you. The rebates are far less when you're doing that. You're actually financially penalised to spend a long time with people. You're better off seeing patients every 15 minutes and writing a script than you are to see 4 patients in an hour and charge a big gap on each one, or you see one person who can't afford to see you and don't charge any gap. The remuneration is there, and there are so many other options too, where people are getting lots of money to write medico-legal reports or work for workers' comp, and if you're going to get thousands of dollars to write reports there, or you're going to get a lot less and then have no way of fixing the system, you get a shift away from the things that are actually meaningful, and you do the shallow work that actually doesn't provide that sort of satisfaction. So I think, that all of these systems things are definitely contributing to burnout.
And so you'd agree with the college that in New South Wales we have a major issue with retention of psychiatrists in the public health system, and that we're reaching crisis levels and it has to be addressed urgently?
Absolutely, and I think vicarious trauma and burnout often live together. It's quite hard. They have similar kind of presentations, and we know, and I'll just talk and I do quite a lot of training around vicarious trauma, and I just talking generally to frontline workforces, we know that part of what people experience at that front line is the frustration around the system. So not having enough time, not having good referral pathways, and not being, appropriately compensated for their time. So there is an absolute sense of overwhelm, and it goes back to the question you asked before about training and support, so it's all well and good to train people up, but we also do have to have the appropriate recognition in the workforce. If we're not actually providing trauma-informed systems, trauma specialist care, then there's no acknowledgement of the fact that actually clinicians are actually being overwhelmed with people's stories of trauma, but none of it's visible. So that is absolutely part of it, is about creating systems. When we create trauma-informed or trauma specialist systems, it creates some visibility around numbers and what are some of the issues, so that you can go from there. But, one would argue we don't have a good baseline around that.
Can I just on some of that evidence, which is basically what you're saying is the economic incentives aren't set up to deliver the quality outcomes because it's a function of time rather than quality. Is that because the government or whoever's making these decisions in the health service is not informed by data which presumably would show that the longer you spend with someone and the more care you give them in terms of quality, the better the health outcomes? Because I think if the metrics were there for the decision makers to say it's about quality, not quantity, then maybe we could shift that. But I'm just interested to hear what your thoughts are on that.
So the way it's designed is you get to charge per item that you bill, sort of thing. And if you are, especially for GPs, they're sort of governed by a manager who wants to see more, you bring in more income because they take a proportion of each one of those patients' fees that you see. So if you're seeing one person, you can charge one gap, and then you spend the same amount of time and you'll get, $37 an hour, is it, I think, for a GP. And if you're there for an hour with them, or if you're there for them, less than that, that's obviously going to be not as financially, good for you if you see someone every 6 minutes and charge a gap for every one of those. And so that's why even the manager is going to be pushing those GPs to see more people quickly and encourage those short consults, and they're going to, because they're going to get less. And then so even if you are a doctor that would like to spend that time with the patient and you get the job satisfaction, and you say, okay, I don't care if I don't get paid as much, my manager doesn't want me to do that and will push you out.
So this is a fairly fundamental perverse economic incentive, right? It's like affecting the whole. This is fairly major systemic problem, I think.
100%.
It sounds like we have to rethink the way that we provide the economic incentive for the consultation.
Yes, I absolutely agree with that. That needs to happen, because it should never cost the clinician to actually give a shit. That's really, it shouldn't happen like that. It shouldn't be where if I want to spend time talking to them, calling up, say if I need to call the police, I won't be able to charge for that. I won't be if I want to try and ring an organisation and say, can anyone provide an emergency accommodation? I'm not going to be able to charge for any of that. So for me to actually pay the attention that is needed for these really complex cases, it shouldn't. I'm okay, I'm not dying, I'm not on the poverty line, but if my income is so much less doing that, you are going to generate.
Yeah, of course.
And so it's been really hard to recruit people to come and work at the hospital that I'm working at, because there isn't the income. You're not going to get that income that you would get if you worked for workers' comp or for the Defence Force. The income's nowhere near it. And the other thing that is happening is that all that happens on the public unit, so the acute inpatient units, there's not enough money in that either. And so all the patients get is sit around like animals in a pen. There's no therapy given to them. There's no activities. There's no exercise. There's no whole of body care for them. So if you're a doctor and you walk, all you've got to offer is, watching these people get put on a locked unit, and they're all pulling their hair out they're bored and they're sort of uncomfortable and arguing about why they should go home, and that's all you see, then who wants to do that work? There's nothing at all interesting about that work. So you've got people going, I'm nothing more than a jailer here. I'm not able to provide any therapy. I'm not even able to say, oh, okay, I need you to go see the psychologist. I want you to go into the art room and do some art. I want you to then go and do yoga. This is what I get to do. I love my job because I can, watch people get better and empower them, and the patients actually get better and get excited about their future and they get into a routine. You've got to have something that shows that the work you're doing is making a difference, and that makes you want to do the job. And so in psych training, nothing is inspiring in the system. It's people going in and out, saying how much they hate it, how terrible you are, how little you've done to help them. It's the same faces. They even get, they get called, oh, they're a frequent flyer, is back again. One of yours is back again. And that lack of, seeing that your work is effective, makes people feel good. What's the point? You go into medicine because you want to see people get better. That's not happening in the mental health system the way it stands, and so it's not inspiring new people to do it at all.
Yeah. And I suppose you can sort of, it's probably let the consequences, whilst they'd be similar, they're less acute at the traditional medicine spectrum, because you're seeing people, you're giving them a prescription or whatever, there's some sort of utility gain. But in this field, where you actually need quality time and investment in the therapy, it's obviously the consequences are more acute. So they're pretty much just a one-size-fits-all model, get as many through as you can. And, yeah.
But even with the medications, I mean, if you want to get down to the nitty-gritty, they're not that effective.
No.
And we actually know that the research isn't showing really great gains with our medications either.
Thanks.
Thank you so much again for being here today, for sharing your expertise and your experiences. The Secretary will be in touch with you if we have any questions on notice. And unfortunately, we're out of time. I think we could probably talk about this issue all day, but we really appreciate it.
Thank you.
Thank you.
Thank you for coming. Thank you for your good work.
Welcome. You too. Thank you for making the time to give evidence today. Could you please state your name and title for the record and take either the oath or the affirmation?
Sure. My name's Sharon Grocott. I'm the Chief Executive Officer of Way Ahead, the Mental Health Association of New South Wales. I'll just take the oath. I swear that the evidence about to be given by me shall be the truth, the whole truth, and nothing but the truth. So help me God.
Thank you. Would you like to start by making a short opening statement?
Sure. So I work for one of the oldest organisations in mental health in Australia. So we were established back in 1932 during the year of the Great Depression. And our purpose really was around improving understanding of mental ill health and also reducing stigma and discrimination and increasing help seeking. So we still do that work today. Unfortunately, our purpose hasn't shifted. There's still a lot of stigma, as you would have discovered, and a lot of discrimination in the community. And we were established back then really to improve understanding. Mental health promotion is still sort of what we do today. But we also work across, we're an association, so we have members, so we're a peak body, and I represent our members today as well. But we also provide a range of services across the lifespan, so from early intervention in schools through to our anxiety programs, support groups, our forums. We provide really important work in workplaces around wellbeing. And most importantly also, I know you've been talking about service navigation, and we've been helping people navigate the system since the 60s. We were formerly funded by New South Wales Health in the 1980s to provide an information service. So we help people through a phone line. We also have a directory. And most importantly, our staff, our volunteers, our board, we have lived experience. So I'm also here today representing, like I said, our members, and some have contributed to my understanding and hopefully what feedback I can provide. But I also have myself professional experience. So I started back in the early 90s as a social worker. I've worked over many decades in mental health, really grassroots service delivery across peer programs, family support. I've worked in programs that are recovery focused. Like I've had quite a broad experience, and particularly work with families with really complex mental health challenges. And so I bring my professional experience, but also my lived experience. So I've been myself a person who's experienced the public system. And my two daughters both have mental health challenges, but my older daughter particularly has a chronic complex mental illness, so she has schizophrenia. So I also come with a bit of that carer hat on as well.
Thanks very much. I've got a couple of questions and then we'll go to other committee members for questions. My first one is about the navigation service that Way Ahead provides. I know you've been following, we've had a huge volume of evidence about the challenges navigating the system and the need for navigation support. So I was hoping you could explain in more detail how the navigation support works that Way Ahead provides.
Sure. So we provide an information directory. So it's very current, up to date. We have almost 6,000 services listed, not just in mental health, but across community services, so housing, employment, education. So it's quite a broad database. We also provide a phone service, so we have the mental health carer line, we run a phone service, and we also operate the official visitor phone line. But for me, the system, as you would have heard, is extremely fragmented, very disjointed. I had come with, many years of experience myself in mental health, and I found it extremely difficult to navigate when you have a family member with a more complex illness. It's really complicated. I think it took me 2.5 years to work out how things work. So despite our best efforts at Way Ahead, what we do is not enough. We're not resourced enough. So funny enough, hearing what you've been saying about service navigation, Honourable Mark Butler did put out at a briefing just before Christmas, he welcomed proposals for early intervention. So I'm about to submit a pilot project for a statewide navigation service. In both Queensland, we have a partner, Raising Minds, and New South Wales. So I'm about to submit a proposal for a model that's very much trauma-informed, very important, as you've been talking, culturally informed, but utilising peer workers, people with lived experience, to not just support parents with children 4 to 17 to navigate the system, but also to provide what we've talked about, that emotional support, practical support, but also future planning support, what to do in a crisis, how does the system work, what are psychiatrists, what do psychologists do, basic things that parents really struggle with. How does the hospital system work? How do the early intervention psychosis teams work compared to when your child then becomes an adult? All these challenges that we all find that are extremely difficult to navigate. And through my own lived experience, talking to so many parent carers, for years I've connected with parent carers even through a parent body. I'm really passionate about actually doing something around this. So we're about to put a proposal in to the Minister.
Thank you. Noting that that's the federal government, not the state government, would it be possible to share that proposal with us
yes,
as well?
I will
Confidentially?
definitely. My plan is to send a copy also to our Minister, who's wonderful, Rose Jackson, and I'm very happy to share that with the committee.
Thank you very much. Might go to the government.
Thank you, Chair. And can I commence by saying welcome back.
Thanks,
as we were
Greg.
chatting before we come back after morning tea. You're not a first timer, so to speak, in terms of your contribution to parliamentary inquiries. I think this is the third one.
That's right. Yeah. Actually, fourth.
Fourth.
Actually also did had a bit to say at the family law
great,
inquiry.
okay.
So yes.
So you've become very experienced at presenting and preparing very helpful submissions. And thank you for your submission. It's been received to the inquiry and stands as submission 84. I've got some specific questions, but perhaps if I lead in from what I've just said and say this to you. Over the period of time, because obviously the organisation has a very long and distinguished history, but for the time that you've been involved, what's your sense of the way in which mental health is being understood in society? And with respect to how we are dealing with mental health, and I make that in the broadest sense, from perhaps mild through to very serious, which you have direct family experience with. Where do you see really falling down in the biggest sense? In other words, the biggest fall. There's many other issues, but the biggest fall. And in terms of what are goals that may be being kicked.
Sure.
The best and the worst. What have you observed over that time?
Well, we're really well known at Way Ahead for our work in mental health promotion. So we do a lot of work around stigma reduction. So each year we run Mental Health Month in New South Wales. And it's wonderful. I think last year we had 45,000 of our resources downloaded. So a lot of workplaces, a lot of not just workplaces, but even mental health teams and schools. We had 3,000 packs roll out into schools. So I think education awareness is really critical. It's only one, we need a multi-pronged approach, but I think having that approach does help. And we do hear some wonderful feedback about the difference that it makes for people, even as individuals, and feeling less stigmatised. There's a lot of self-stigma, as you know. But I also think that there is still a lot of stigma, and we polled 2,000 people last year across the country. We just did a survey. I aligned it with the national survey that was undertaken by the National Mental Health Commission, so we had some similar questions. And I was shocked, I was stunned to see how much discrimination is still in workplaces, for example. So I think 78% of people said they wouldn't disclose to an employer. And one of the main concerns I had was GPs were named as one of the main, places where going to their GP where they felt stigma and felt ashamed to talk about mental illness. So I think we still have a lot of work to do across society. And I feel that particularly certain mental illnesses, and we found the same, illnesses I hate to talk about, like schizophrenia, which, I've disclosed that my daughter lives with, but people have this fear of they're going to be dangerous, that they need to be forced into treatment, for example. I was really shocked at some of the views and some of the just really misunderstanding about the condition. There's not a lot of knowledge about psychosis out there, so people are very fearful of people in psychosis. And conditions like bipolar, for example, that was another condition that there's a lot of discrimination. So I think as a society, we are organisationally kicking some goals. We see some really positive outcomes, and we talk to communities and we go out and see what's happening, but I think we still have a long way to go.
And then focusing, if I could, on those, dare I say, the darkest corners, where with things, one would argue if this is the worst of it, so to speak, there should be some almost urgent attention in terms of policy and ultimately funding if necessary. What would you identify in that category? The sort of, dare I say, the worst of the worst?
I think, Greg, I know you and I were just chatting on the break about education. And I think, and I just heard, I'm so pleased that trauma-informed practice was talked about, because having worked with families that have really complex challenges, trauma always underpins what's happening. And you can't look at a person with a mental illness without having a trauma lens. So I think particularly we need to change how society views mental illness. I think there's not a trauma lens across things. I think that we have, my experience personally, and even our members have talked to me about a very medical model, not one that sees a person as part of a wider system, where a person's part of a community, a neighbourhood, they have extended family and kinship, they're part of a workplace, perhaps even an educational institution. We often in the system see a person as an individual, isolated, and this sort of medical sort of model. And I think we really need to shift that. We could learn a lot actually from First Nations practice and around culture and connection, and around really understanding that a person sits within a system. They're not just in isolation. So I think our whole medical model needs to shift, and that starts with education early on, as you've talked about. Training, how psychologists, social workers, doctors, training them. There's some really good models around contact, so for GPs to actually have contact in their training with people with a mental illness and to build empathy. And empathy is a huge thing, so I think having more of an understanding and empathy for people would go a long way.
Sorry, half of my colleague might have.
Thanks, Greg. So nice to see you again, Sharon, and thanks for all the work that you're doing, and that obviously your organisation also is doing. Whilst we're on the topic of trauma-informed care, would you say that our state services at the moment are providing trauma-informed care, and what does that look like, or what improvements could be made?
No, thanks, Emily. That's a really important question. Just from, I guess, my experience, just to start with, I was a bit surprised actually. Amber, about 3 years ago, her symptoms started. So she was under the early psychosis team through the community mental health team. And I was really surprised, I guess, at that sort of lack of understanding. She has a disability, so she's had a lot of trauma through her life. And she's very proud that I'm talking today, actually, and getting some of her experiences across. But I was surprised that there was no sort of understanding or insight about other conditions, other experiences that she had. It also, even I have heard from families often talk about the lack of cultural understanding, and I've just been talking to 200 low-income families across New South Wales, learning under 50,000 about their experience of the mental health system. And a lot have talked about their lack of, their experience that it's a one-size-fits-all, that it's not a flexible model, it's not individualised, it doesn't understand their cultural, their religious, their community experiences. And I hear that a lot. It's not the first time, having worked with families for many decades, I hear similar things. So I think the system we have at the moment needs to be more flexible, more individualised. I think that quality of care really doesn't consider, and staff aren't trained necessarily in having that trauma lens. But I was also surprised with the public system, that lack of carer family inclusion. I think it was about 6 months in when they actually asked us how we were going as a family. And that surprised me. I just assumed the system would think about inclusion of family and carer and what impact that might have, but it just didn't.
Why do you... Sorry to interrupt you, but why do you think that is? Is there, a reason for that, do you think, or do you think it's just...
I think part of it is the high turnover. So there's a really
High
high
turnover
turnover of staff. So I
yep.
think we went through 4 case managers within 6 months. And every time we went in, we had a different psychiatrist. I actually ran out of fingers to count how many we had. So part of it was that lack of continuity of care. So the next person didn't know if that previous professional had asked or looked into how a family support was working, or, you know, how the family was functioning. Or so I think the high turnover rate, the burnout, you've talked about the crisis point that we're at with psychiatrists. That is a real issue. I know myself. I think I went through 12 different ones on the phone, and all had 2-year wait lists privately, because we just couldn't continue with the lack of continuity in the public system. We decided to go private, and we've already sort of experienced 3 different private ones, because none of the professionals quite understood disability and how that disability is impacted by schizophrenia. So they didn't quite understand the functionality aspects or how the two interplay together. So it's particularly hard to find a psychiatrist with a specialisation. It's very rare to find one. And I think for families, the cost as well is prohibitive, but the public system, just that lack of continuity of care and the turnover, that really impacts having that sort of family-informed, trauma-informed, you know, being able to sort of really have that support of a family's holistic needs. And even that recovery focus was lacking. It was just really a medical model.
Thank you. Look to my colleagues.
Thank you very much for being here today and taking the time. I'm interested in your comments in your submission and in evidence in relation to continuity of care and the effect of the difficulties in retaining psychiatrists in the public system, and I'm aware of the comments made by the college. So your experience sounds as if the burnout of psychiatrists isn't just an issue for the workforce, it's a real issue to do with patient safety, it's a real issue to do with the ability of people to recover well and build a strong recovery path because of the difficulty of public hospitals in retaining psychiatric staff.
That's absolutely spot on, really, with what you've said. And I think building trust, I know that's been talked about earlier, that is a key. So if the patient's able to build trust with the psychiatrist, really build that engagement, have that continuity of care. We've talked about, funny enough, medications, and to be frank, I think I saw some evidence from the New South Wales Mental Health Commission that only 49% of patients have efficacy, and that they're pretty much not effective for many people. Not saying that, you know, they're not important, and don't get me wrong. My daughter, I think we're on the 9th antipsychotic medication, and we've got 3 more options before clozapine. But I think that, you know, that importance of care, that it's not just about medication and treatment, that the person, the psychiatrist, really needs to be involved in that recovery planning. And I know for my daughter, for example, equine therapy probably has more positive outcomes than what some days of what a medication's having. You know, having art therapy, having social interaction and inclusion and feeling like you belong to a community has a huge outcome for people. So the problem with the current situation is just trying to find a psychiatrist is near impossible, yet alone retaining one and seeing the same person. The other challenge too for people is that I've discovered for us, because, you know, we live with a chronic condition with Amber, that unless we have a psychiatrist in a hospital, it's near impossible to get hospital beds. At times we've waited 2 weeks for a hospital bed. We've been managing her in quite an acute state. And by acute, I mean, you know, she hasn't been able to shut her eyelids for weeks. She can't sleep. It causes her to be distressed pacing up and down the house. Amber would have hallucinations, visual ones, delusions, where she thinks that the neighbours are going to come in, that there's someone going to assault the family, like really frightening, very scary, at times self-harming, suicidal. And families are left to manage that because there's just not either hospital beds available. The experience of the emergency system is traumatising. We've stood there for 12 hours at a time where Amber's in an acute distressed state, waiting to be seen. And then I've been told by the staff that she'd be safer in the psychiatric emergency care unit because the adult ward is frightening for someone with an intellectual disability. And even the staff have advised me I'm better off going home. So that's sort of what carers and families are living with. And I think, I'm a person with clinical experience and we're struggling. How are other families going that don't have that clinical basis, they don't have that knowledge? And, I've worked with people with extreme behavioural challenges, and I'm not saying, people like Amber are not dangerous. If anything, it's more fear of danger to themselves, not to others. But it is really challenging to manage with the current way the hospital system works.
Well, so what I'm hearing from you is that the burnout of psychiatrists affects the workforce, it affects the patients, but
Yes.
it's also having a very big impact on families. How do you get supported to keep on caring for your daughter?
Yeah, sure. So my husband is amazing. He's never had he's come from a finance background. He worked in sort of a whole different industry, and he's been sort of forced to leave his job. One of us had to stop working, so he's now her 24/7 carer. And at times, look, he manages extremely well. He has a respite group. He goes to a carers group on a Friday and talks to other parents, which is really important. But at times, like last night, for example, he was at crisis point because she'd been sick with a bit of a vomiting bug for a couple of days, hadn't been able to take her medication. So her mental illness was spiralling the last couple of days, and he was sort of at breaking point. So carers are constantly having to manage these situations, often with little support, without respite. Even the NDIS, I'm told, won't cover things like 24-hour respite. So we're fortunate that we have a daughter who also is a young carer who steps in at times, and she's an amazing young woman. But for families that don't have that, I don't know how they manage. It must be extremely difficult.
And I'm interested in the comments in your submission and earlier in relation to the family as being seen as part of the support system. And be interesting to explore your experience of why the family perhaps hasn't been brought in as a support system, or do you feel that you've been adequately listened to by medical professionals in the care of your daughter?
No. On the whole, no. And it's interesting, the Productivity Commission talked about this back 2020, the report came out about the exclusion of carer families in the system. And look, on the whole, don't get me wrong, I have worked with families with really complex challenges, and occasionally a family might not be the best support mechanism, but on the whole, families very much are. And we're there to provide practical support. We can see when our loved one is becoming more unwell, we can see the signs, the red flags, we can identify early. We can support their treatment, their medication, make sure that they're taking their medication. We can support them going to appointments, medical appointments. We can help them facilitate recovery with other ways that someone can recover that are non-medical, having more of a holistic care plan in place. Families are so pivotal, and yet they seem to be excluded and not have a voice. And often it's at the point where my daughter's an adult, so now I can't even go into a hospital ward. When she's admitted, I have to get guardianship now so that I have a right and a say in her personal care. So we're very much excluded.
Could your daughter adequately access medical care to support her without your active support as a family?
No. If we weren't there, to be frank, her personal care, her medical care, that would all be at jeopardy, and she would probably end up back in a hospital.
Yet you're not directly included as somebody with insight and able to provide support for her recovery?
No. And even with the community mental health team, we attended every session, either Rowan or myself. We were very engaged in making sure she got to those appointments, and yet we were not really included. So I think training of professionals to understand the role of carers, understanding that we can have that really pivotal role in in overseeing and seeing those red flags with our loved ones, but also providing all those practical, emotional and other supports is really important.
So if you see the red flags and you can identify early that difficulties are emerging, are you listened to by the medical professionals?
At the moment, we have a new psychiatrist, so we've had to go through the private system with a psychiatrist attached to a hospital, and she very much listens. We've found gold, like we've found someone, like I said, I'd hate to count, I'm sure there's over 20 psychiatrists now that Amber's seen over her last 3.5 years. But we've now sort of struck gold with someone who does listen more and is very engaged. Having said that, for the average family affording that, I don't know how they'd afford it. We're pretty much using our retirement funds. And the cost of even a hospital bed, for example, Amber was in Gordon Private for a number of weeks. I was shocked and stunned to see the real cost was $16,000 a week. We were lucky that Medibank would pick up apart from an excess. So I don't know how families can afford to pay even Medibank Gold, for example. It's extremely expensive to access the private system. But for us, we didn't have an alternative. I mean, we were, as I said, pretty much told by the staff themselves in the community mental health team, they were fearful of her going back into the adult ward. And they were actually advising her that it wasn't a good choice for her.
Okay, thank you very much.
Thank you. I had one last quick question, which is in your written submission, you touched briefly on a conversation that you'd had with the community mental health team about outreach, about being able to actually receive care somewhere other than a clinical setting. What difference would that have made for your family, for Amber?
I think it would have made a huge difference. And I know myself, having come from an organisation that provided counselling before I started at Way Ahead, we were providing counselling in a park or in a school, or even for example, First Nations, we were going out to community places that were, comfortable for people. I think being able to provide care out of a clinical setting would actually break down barriers. It would increase engagement. It would actually take away the medical model and the perspective that it's a medical model that we currently operate in. I think people would feel more comfortable. Culturally, it would be more appropriate for many people. I think that it would change up how what currently is happening with this sort of, and not just medical model, I have to say quite a patriarchal system at times, where, you're told, I'm the expert, this is what you need to be doing, and this is a plan, and there's no sort of inclusion or holistic view of, what the family might think or what the young person themselves thinks is best for their care. There's no inclusion of that. It's a very much patriarchal medical model.
Thanks so much, Sharon. I'm just looking at the time. We're out of time, but thank you so much again for sharing your personal experiences and your professional expertise with us. It's really valuable.
Yeah, no, thank you for having me. I really appreciate it.
Thank you. And the Secretariat will be in touch if there's any questions or notice.
Okay, thanks.
Welcome. Thank you so much for taking the time to give evidence today. Could you please start with your name and position title and the oath or the affirmation?
Sure. My name is William or Bill Campos. I'm currently the Chief Executive Officer of an organisation called ICLA, which is Independent Community Living Australia. I've been there for just under 3 years. I am going to be taking an oath. I swear that the evidence now about the given by me shall be the truth, the whole truth, and nothing but the truth. So help me God.
Thank you. Would you like to start by making a short opening statement?
Yeah. Thank you. My background is I've been in the sector for about 25 years, both as a clinician, carer, executive, and also did some work around research in the area. So I've got lots of different wide range of, I suppose, exposure to the sector. My principal kind of work at the moment is an executive as a service provider, but in the past I have actually taken on commissioning roles for those community sectors and working at a primary health network as well as transcultural mental health services at New South Wales Health. I'm currently registered as a clinical psychologist. I have been practicing a number of years as a clinical psychologist in private practice as well previously, not so much now. Currently I'm representing both as a personal or as a carer through personal experience. I also have some experience provided with advocacy for the services that I provide. The focus of my work has been around 4 key areas. So at the moment with my organisation, we're very much focusing on developing a lived experience peer workforce. We also focus very highly on the ability to provide services at what they call the prevention recovery services. We also do, part of my work at the moment is we're a housing provider, so we do a lot of transitional housing and supporting the homelessness sector. And lastly, we're also a disability service provider, so we do a lot of work intersection with the psychosocial disability services, particularly around long-term care in terms of supported independent living. I very much have numerous ideas a little bit about what the government could do. Contrary to, I think, a lot of things that have been said in the past, my opinion is that things have progressed over the last 25 years since I've first been interacting with hospitals and mental health services. But I think there's a lot more that can be done, and there are different areas I think that the government should look at to try and leverage to have those services much more consistently coordinated.
Thank you very much. I've got one question and then I'll go to questions from other committee members.
Sure.
In your written submission, you talked about psychiatry liaison services, and you mentioned one from New Zealand and then another one that was trialled in Western Sydney. Could you explain that in a bit more detail?
Sure. So when I was working at the primary health network, one of the concerns that we had a lot of GP practices who were, particularly in Western Sydney, were disadvantaged areas. They had enormous amount of workload associated with mental health, and we can see by the Medicare billing items that they were struggling, I suppose, in some ways to provide quality care with the volume of people. One of the things that we were fortunate enough, we had some ability to commission some services and look at innovative services that can help, and part of that consultation process is going to the GPs and understand what they think they would need. What we did at that time, we did a bit of research and we found that in New Zealand they do have what they call a psychiatric liaison service. We went down to South Auckland to do a bit of research around a particular area where they employed a psychiatrist predominantly that would work in a hospital setting maybe 1 or 2 days a fortnight or a week, and then the rest of that days they would be going around to GP practices and supporting the GP practices either with the people who have been discharged from those hospitals, or there are in managed maintenance supporting those supporting those patients who had some severe mental illness but needed to actually be supported at the community level. And there was another element to that psychiatric liaison service too, which I thought was really interesting, was that there was also a component of training psychiatrists. So that particular, it was a very senior psychiatrist who was, obviously anchored to a hospital setting, but then he had about 10 GP practices that he would be liaising with to support both the GP nurses and the GP practice team, to be better informed, to educate them, and also offer some sessions within the GP services around those complex needs. And then a part of that was that part of his training of new psychiatrists was that he'd not only get in the hospital but also within the GP services. We saw this model as something that we could be trialling it in Western Sydney. It was something that I think was well received, particularly with some of the GP practices that we highlighted were a very big need. So we highlighted 10 GP practices that potentially had a very large volume of demand. And we hired a psychiatrist through a not-for-profit organisation because we didn't have the mechanisms to actually hire through the New South Wales Health or the local health district. But we hired a psychiatrist who had previously worked in the Western Sydney local health district hospitals, who were then able to coordinate care across the GP practices. And that service, I think, from memory, went for about 4 or 5 years until the funding ran out. But the experience was that once a GP practice was well supported and had the skills to understand how to support people with complex mental health needs, that psychiatrists would then also be able to move to other GP practices in the region that had also pressing demands.
Thanks. Mrs. Carter?
Thank you. Thank you very much for being here. I'm very interested in your comments in your submission in relation to navigation, and I note your recommendation in relation to the app, which seems like a good way of information sharing. Just wondering if you have any thoughts about the other side of navigation, which is really finding and locating the right services and also the available services. If you have any comments about whether someone who's mentally ill is able to manage that navigation themselves, whether family should be directly and explicitly involved, or a support person, if you have any thoughts around that.
I probably have a lot of thoughts around that. I guess the first point that I would say is the navigation system, it is very convoluted. There's various different informations out there, and there is an element, in my experience, that you do need to do a little bit effort in terms of understanding what the services are available before you actually buy into the service and engage with the service. So I think there's always an element of try before you buy with services until you feel as if you're comfortable enough and the person and the service that you're engaging with meet the needs of the person that you're supporting. With navigation, if I could break it down to thinking around what I see as problematic, I think the first one is that there is a commissioning cycle of services that are both by state and federal government that often put money into the community, and services, they promote a particular sort of service, and 2 or 3 years' time you often find that either that service is not able to meet the demands or not able to continue because of lack of funding. And so every 3 years there's a evolutionary of services coming in and out of the communities because of the way the commissioning cycles happened. So there's an element there that is always changing, the sector's always changing, which makes it difficult. The second thing about navigation is that in order to support some navigation, the navigator needs to be well informed. And because of the plethora of services out there, sometimes a lot of navigators don't have the capacity to really know and understand all the service availabilities and what the service offers related to a particular individual. I think the previous person who was here talked about that it is good to have a person on the side who you can connect with, because I think navigation, part of navigation is to do with supporting someone to walk through and discover, I guess, the services that are available to you. But I often find that particular service or that navigation type of service is better done by usually peer workers or lived experience or a group of support workers that have some experience. I mean, I'm a big fan of a service called recovery colleges, where people go in there and they learn about the condition, but they also get to interact with other like-minded people who are also going through similar services. So it almost becomes like a support group through that sort of mechanisms. So navigation role for me is very not professionally based services. It's more to do with a community based support, I guess. And the last thing I'd say about the navigation is that it's also very unique, because every individual with a different mental health need has a very specific, unique need, and that in order to navigate, you probably do need to go with someone you can trust, and often that person is usually family or someone very close to the family before they can actually navigate with someone who's a caseworker or a community peer worker.
Do we need to do some more work to ensure that services are happy making appointments via a nominated navigator rather than with the patient themselves?
Yes, I think the ease of engaging with services and trying is really important. I think one of the suggestions I made in my submission was with the app is there's visibility and transparency about availability and when things can be connected. So it allows the consumer who's navigating through the system to have the ability to organise and coordinate the services that they feel as if they need to attempt to engage with. But I guess the key question then becomes, is that person well informed about the services that's available to them?
And thank you also for your very careful discussion of telehealth and the benefits and the limitations. I'm very interested in the reference that you've made to research indicating a lack of adherence to treatment over the long term when we're talking about telehealth, because we don't want to go down a path and find that it's ultimately not successful. Could you maybe talk a little bit more about that research and issues of adherence to treatment over the longer term?
The research that we found in terms of what I'm referring to is there is some really good evidence that technology allows access, almost immediate access to services or connection with someone who can probably provide help. So it's quite reflective of the need to respond to a need, whether it's an acute presentation or some sort of immediate assistance. But what we found is over time, and this is going back to some of the work I've done many years ago with helplines, is that there is a tendency also people not to go from an engagement of an online platform to a face-to-face service. So sometimes there is that element where people will just either continue to engage with an online or a helpline and never go to the process of what they call recovery, where they're addressing some of their needs. And the other thing too is that there's an element of when you go to a face-to-face service, people usually invest their time and resources and energy to go and engage and test and develop a relationship with the service. With some of the online services, there's the anonymity and often there's the ability for people to test those services but potentially not invest in their recovery. And so there's a need, in my discussion here is around, there's a need to actually try and collaborate both of those, the online environment with a face-to-face service that eases those transitions of care much more holistically. And I think there's quite a few evidence where you can actually combine a few online tools that can coordinate that quite easily. So we have a prescribing system where the doctor can have some access to understanding where the person's interacting with an app, understand a little bit about checkpoints about how the recovery is. There's some checkpoints about how the person's navigating through the recovery. And then having, if acute levels of need happens, they can actually engage with a helpline. And with a closed system of an app, I suppose, you can assist people to actually easily navigate between their services. And an important point about the digital platform is to also support with families' involvement. So when a person can't actually engage for services for themselves, where there's a nominated person who can actually look and support that sort of navigation as well.
And my last question is in relation to your discussion about the psychiatric liaison service, which was trialled in Western Sydney, and it's discussed as perhaps a measure of dealing with the shortage of psychiatrists in rural and regional areas. Given the difficulties we have of retaining psychiatrists in the public health system, do we have sufficient psychiatrists to provide a liaison service to regional and rural GPs so that there can be an outreach service to the very underserviced regional and rural areas?
If you're asking me in terms of enough bodies of psychiatrists to do that, I'd probably say no. There wouldn't be. I think that's where the online environment, and I do know that there are some online psychiatric support for GPs that are currently developed. But I guess it goes to the point that was raised earlier about it's the fulfilment that the psychiatrist needs to have in their role. I often find when you're talking to hospitals, if you have a psychiatrist in a hospital setting, they are constantly looking at the acuity levels and a very short-term intervention. And often they're working at their very high level of qualifications, which is to do with managing a crisis or a psychotic episode or something along the nature of the emergency department. If you have a psychiatrist who's working there 5 days a week, 365 days of the year, you often find that there's not a fulfilment associated with that role. And I think one of the things that psychiatric liaison officers looking at is the ability to enhance the psychiatric profession of not just supporting the acuity levels of distress, but also the continuity of care and the community liaison, where potentially you can actually see the whole life cycle of journey of care for the psychiatrist who's treated that person maybe in the hospital, but has also got touch points in the community with the GP and other areas in the community. And so if you can actually get a restructure about how you engage with psychiatrists in the hospital setting, you find that there's more incentive for them to actually start delivering services in the hospital. Most of the interactions I have with psychiatrists, it's not all about money, because I know there were some discussions about economic incentives. I think there's also fulfilment in their role and the ability for them to see that recovery process and journey of care. And I think that's what the hospital setting doesn't provide psychiatrists, and that disincentive, I can't say it.
Yeah. No, thank you. I understand what
Yes.
you're saying. Thank you very much.
Ms. Bell?
Thanks, Chair. Thanks so much, Bill, for attending today and for your evidence and your submission. I might start with somewhat of a rhetorical question, if I may, and just invite you to comment on how important is community-based care.
Well, it's a very big discussion around community care, but I think the central part of community care is the family. I think what my experience has been, often we talk about treating the individual who has the condition, but often professionals and services don't really engage well with the family. I think there's a comment here that potentially there may be at times where engaging with the family is not appropriate, but I think on a whole, majority of the families are the ones that actually have the best knowledge and support. The community-based services I also think is really important, because it's the one place where I think you can actually ease some of the traumatic experience of people going in and out of hospitals, or the intersection between when they're going to high levels of acuity, where potentially that leads to police involvement, ambulance, and potentially other sort of hospital admissions. If you have a strong enough and areas of visibility and the ability to provide respite for family at that early levels, you often find that they will alleviate that traumatic experience into the hospitals. And I think that's particularly important for the younger cohort. So in answer to your question about the community, it has an enormous important part to play, but it's a matter of that coordination of care between hospital, community and the primary sector that needs to happen.
So just on that that note of integration, is there a need for greater investment to improve the current integration between systems to ensure a more meaningful care journey or outcome for people?
Definitely, yes. I mean, if I could show you the example, and this is one of the, I suppose, parts of the services that we provide. We deliver a service called Prevention Recovery Centre, which is a short day residential service, which are often known as step up or step down. And so that service for us, we find it's important, and the way we designed it, we found it was really important, is we design it in a way that it's a community-based service away from hospital, so it's a home. People can stay there for up to 30 days overnight, whether they're stepping down from hospital and transitioning back to home, or whether they're known to the local health district and they're starting to have high levels of acuity, and prior to them get to extreme acuities and be called to hospital, they could potentially be self-referred back into the step-up park service before they get to hospital. Now, what I wanted to highlight about that particular service is it was really important for us to be based in the community, away from the hospital and a house setting, and also be predominantly supported by lived experience peer workers. What we found was that if you take away some of the treatment focus of the medical model and focus a little bit on the personal narrative and understanding how they can actually navigate their own personal circumstances and be better informed about the care that they need to take for their condition, you often find that there's a better outcome for them longer term. And I think we've been running this particular service here in New South Wales for the last 3 years, but we're particularly proud of the fact that there are some good evidence to say that those people who've gone into hospital for the first time, usually younger cohort, 18 to 25, who then go through a step-down process, are able to much better engage and be informed about their service. Because what we do is, at the Prevention Recovery Centre, is support them up to 30 days. It's a voluntary service. And in that 30 days, we can actually engage with family give them some referrals to a recovery college or community-based services in that setting. And when they transition back to home, potentially they are much better informed. The families has much better awareness about the condition, and already there's a lot of referrals through to other community services within their home. So I think that to me, and I do know they have a lot of these services in Victoria.
So this model that you're talking about, because the committee did a visit yesterday to a Hazzy Plus
Yes.
In Western Sydney, and obviously that has a different staffing model. But I'm quite interested to hear about this, because as you say, it was people are predominantly supported by peer workers.
Yes.
And so how this is different, and whether this would be appropriate for all people, if that.
I mean, there's different levels of. For this particular case, it's more of a step up, a step down. Hazzy is usually for a longer term.
Yep.
So at Hazzy, we offer services which is supported independent living under NDIS, which is 24-hour care. There's a different need, I guess, in some ways for people with a chronic mental health condition where they need to be supported over long term. And that has elements of an intersection between clinical services, the touch points between family, and also what we focus on is recovery, to try and get the person back involved into either employment or back into connection with community or families. With the Prevention Recovery Centre, the peer workers, I think it's more to do with, particularly with a younger person who's gone through the first time, is giving that personal narrative of understanding that you've gone through a psychosis, you may actually have a condition that you need to be aware of. And also then to navigate that person is, how do I go back home and talk to my mum and dad or my girlfriend or my employer? You know, I need to have some understanding of how I can re-engage back into the community without necessarily being stigmatised by certain, understandings of that episode.
So you have one of these services, say, connected in an LHD.
Yes.
I'd be interested to know what the demand was like for the service, and whether there is a need for more of these services elsewhere.
Yeah, I'm being biased here because obviously I support one of these but I do see this as a cornerstone, because I think one of the key things, once a person is known to the local health district as a person who has a chronic or complex needs, what you want to do is support them in the home as much as possible. And so one of the things that families often do is they'll pick up symptoms quite early, and often they have to manage that at home without necessarily much support. And it's not until an acute episode or something happens, and often the default position is sending straight to hospital, either through ambulance or police. If these services are available where the family is known to the hospital and known to the community, they can actually refer into a 30-day respite care, which gives the family some respite, but also give, hopefully, the consumer an understanding of working in a non-clinical environment to understand, better support their needs with lived experience peer workers who have been through that sort of scenarios. And in some ways, it just destigmatises the need for treatment, which is sometimes very traumatic, and also alleviates some of the concerns that the person might have with a family in terms of giving them respite as well, so that when they go back to the family, there is that respite and that engagement process that happens.
So why is it that people are still falling through the cracks then? Because it sounds like a great service, and, obviously having the option to then self-refer back into the service.
Yeah.
Why is it that, we've heard other evidence about people still falling through the cracks and still having difficulties in accessing the care that they need when they need it?
It's a bigger question, and in my experience, there's a lot of services out there. I think one of the key things is that people are not aware of the services. So often when people say they miss the gaps, is because people are not aware of
So how do
what
we
services are
improve
available.
that, I suppose, as government? How do we improve that?
I'm going off on a tangent here, but I think it's worthwhile for this discussion. One of the things that I think the government should focus on, when I was part of the Western Sydney PHE when you're commissioning, I think we approached the community as a region, a commissioning approach as a regional community. And then if you look at it, getting housing, Department of Community Services, the GPs or primary health networks, the local health districts, and you look at managing and supporting a community or that regional level, you often find that you can accelerate the demands. Sorry, you can accelerate the ability to engage with services at a community level and get the cohorts that you need to address and support much better, but also you get visibility on different services in different communities. One of the things we did at Western Sydney, which I think it probably wasn't praised enough, was that we got the Education Department, the Health Department, Department of Juvenile Justice, got together and say, not only we commission services, but are we able to actually be responsible for regions and look at, data-informed care, a little bit about where are the hotspots in that region that needs to have better care. And when you start doing that, you either get visibility, but also you get an understanding that services get to where it needs it most, and that's where the funding level should go. So I think there is a real way the government should focus on understanding how they regionally commission services and bringing services together. That might be a much better return of investment in terms of your funding and commissioning processes.
Thank you. Thanks, Chair.
In the last couple of minutes,
Sure.
I've got one last question. In your written submission, you made a passing comment about the effectiveness of community treatment orders, and I suspect we'll be having an in-depth discussion later today.
Okay.
You made a comment that they were generally effective, but that you had seen them used based on deficiencies in resourcing, follow-up and assertive outreach. Could you expand that comment?
Yeah, I think it is a good tool to use, particularly when we have people who are really unwell, and as a family member, I think that's one of the things that's been really useful, is to actually engage with a care treatment order and then go through the process. But I have witnessed, and I won't say names or which regions, but I have witnessed there are times when you have different health departments or community mental health departments where they just don't have the resources, and you can see them struggling with just being able to actually get some appointments, 2 or 3 appointments after, telephone appointments after someone's discharged. And often, depending on the acuity levels or the risk associated with that individual going back into the community, I think sometimes there is a default position to say, okay, one way of capturing that risk is to put someone in a care treatment order, to at least that way there is some formal processes in place that go outside the community. And they may not necessarily be the most appropriate way of managing continuity of care after they're discharged from hospital. But I think the mechanisms are good if they're used well, if that makes sense.
Thank you. Thanks, that's helpful. Thank you so much for your time today, and for the time you've taken to prepare your written submission. We really appreciate it. And the Secretary will be in touch if there's any questions on notice.
Thank you for your time.
Thank you.
Thanks.
Good morning. Welcome. Thank you for making the time to appear today. Could you both each please state your name and title and take either the oath or the affirmation?
I'm Claire Skinner. I'm the immediate past president of the Australasian College for Emergency Medicine, and I also work as a senior staff specialist in emergency medicine at Hornsby Ku-ring-gai Hospital. And I'll take an affirmation.
Go ahead.
Yep. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you.
I'm Trevor Chan. I'm the acting faculty chair for the New South Wales faculty for the Australasian College for Emergency Medicine. Clinically, I work out at St George Hospital, and I'm the clinical director for the Emergency Care Institute, which is part of the Agency for Clinical Innovation, and I'm going to take an oath. I swear that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth, so help me God.
Thank you. Would you like to start by making a short opening statement?
Yes, I'll do that, thank you. ACEM is the peak body for emergency medicine in Australasia and has a vital interest in ensuring the highest standards of emergency care for all patients. ACEM is responsible for ensuring the advancement of emergency medicine in emergency departments across Australia and Aotearoa, New Zealand. All persons seeking mental health care have the right to access timely care when and where they need it. ACEM is committed to advocating for a mental health system that has entry points to meet people where they are on their mental health journey. Thank you.
Do you have a
Well,
statement,
I
Dr.
just,
Skinner?
just having listened to the evidence already in this session, I just want to acknowledge that we know the care provided in emergency departments isn't perfect, but we're deeply committed to trauma-informed therapeutic care in emergency departments and also working with other stakeholders across the system to make sure people get that care. And the points that have already been made about navigation and integration and fragmentation across the system bear out in emergency departments, which often serve as a safety net for the rest of the health and social service systems when other elements of it fail.
Thank you. I've got a couple of questions myself, and then we'll go to questions from the committee. I'm most interested to read in your quite detailed written submission a recommendation around emergency department staff having pathways for referral into community-based services, and you mentioned things like housing and drug and alcohol services. What might that look like in practice?
So just, I hope you don't mind if I open, Trevor. I think the thing that's really tricky in emergency departments is people don't come with a diagnosis, and people come in varying states across the spectrum. So I tend to refer, I've been very heavily involved in mental health and emergency departments now for a number of years, and I would tend to refer to psychological distress or psychological crisis or acute severe behavioural disturbance, and those might be due to a mental health issue, but they might also be due to a number of other medical issues. So it's really, or social crisis. So it's a really complicated space. Like the previous witness said, I do believe that this has improved over the time that I've been working in emergency departments in New South Wales. There are now more services available. There's more of a spotlight on addressing stigma and bias. We've seen some, attempts to educate around trauma-informed care, and we have seen improvements in the emergency department environment too. So we form better linkages with psychiatric and mental health care services. But we've also seen increasing fragmentation of those services. So that's what I would refer to as a lot of wrong doors. So I observe in my clinical practice, from the emergency department perspective, people ricocheting around the system where they sort of aim for one service and they might get told, no, that's the wrong place, and then they get fired off to another service, that's the wrong place. And we are not very patient-centred in the way they do that. So we tend to set up all these services, whether they be physical services or virtual services, but they focus more on managing risk and the exclusion criteria than they do on receiving the whole person who comes with not only their mental health issues, but also a whole range of social and other physical issues that aren't addressed by that particular service. And I think from the emergency department perspective, and we are proud acute generalists in the system, we see a lack of focus on the whole person and a system that's increasingly difficult to navigate despite a proliferation of services that have happened in the space.
Probably add the comment also in the context of up-to-date and available knowledge for both the carers and from the families and the patient that are provided for people at different parts of their journey. Often in the emergency department, you may be meeting the patient for the first time, for the carer for the first time, the family for the first time, and really trying to both establish a relationship with the family and the carers and the patient in that context can be difficult. So the availability of knowledge that helps from all aspects, the clinical side and the family side, is imperative, and keeping that up to date. And that doesn't just include the medications they're on or what treatment they have, but includes those other aspects that previous speakers have talked about in terms of family and carer and difficulties and access, and that also adds to the ability to help navigate, I think.
There's another critical aspect here, which is the way our health systems are governed. So mental health services sit outside the way that, so often within the LHDs, the acute hospital services are governed in one stream and the mental health services sit outside that. And that, from the patient perspective, that hopefully shouldn't create a barrier, but it creates a major governance barrier when there are two systems with different recruitment methods, different KPIs, different reporting lines. And that means when someone's in the emergency department and you're trying to navigate them across services, you've got services that sit in the community sector run by the federal government, you've got community services run by local government, and then also even within the acute hospital system, the mental health side will be governed separately. It's not under the control of the general manager of the hospital, so it's really complex from a government's perspective as well, and that, I believe, is something we haven't addressed enough and potentially is some low-hanging fruit.
Thank you. We've also had a huge volume of evidence sent to this inquiry about the value of peer workers. People with lived experience have told us that they really value that contribution. Also noting the extraordinary wait times that people often face for mental health assessment in emergency departments. Do you think there's a role for peer workers in emergency departments, or how might that work?
Yeah, I think there is a role. I think it's really based on how that best integrates and the availability of those peer workers. Because often it's a case of are they there at the times of days that the people come seeking help. I think it all adds to the ability to then offer the best treatment plan for the person and help them understand the system that we've already talked about as being difficult to navigate.
Just adding, I've really enjoyed working with peer workers, and I find them valuable, and I think they understand the system from a perspective that's really important. And I found them very useful in emergency department settings. If I reflect on the difference between the way we might manage a more physical condition and a more mental health condition in the emergency department, the pathway to senior decision making is much longer on the mental health side. And I worry about adding a peer worker in who then speaks to a clinical nurse consultant, who then speaks to a psychiatry registrar, who then speaks to a psychiatrist, and lengthening that pathway. So my plea here is I think multidisciplinary approaches and a lot of people with experience, and particularly lived experience, are really important, but we need to make sure they're empowered in the decision-making hierarchy in an adequate way.
Thank you. That's really useful feedback. And my last question, coming from your written submission as well, was about the vicarious trauma to ED staff that arises from not actually being able to provide people with the care that they deserve. I acknowledge that that's a significant issue for recruitment and retention as well. Other than the broader work we're going to do to try to get people mental health care where and when they need it, what do ED staff need to help address their vicarious trauma?
I think, as we've described in our written submission, a lot of what we see in emergency departments in the mental health space reflects a failure of community services. There is always going to be a role for emergency departments managing acute, severe psychological crisis or behavioural disturbance. That's what we do. It's the right environment to do that. That requires resuscitation level skills and senior emergency physician training. But we see a lot of stuff increasingly that's not quite that acute, but there's literally nowhere else to go. That becomes distressing because we don't have the right therapeutic spaces. We don't have the right skills. Yes, we could learn skills, but we're generalist. There's a limit to where you can maintain skills, but we also feel those referral pathways are lacking. When we refer someone for a psychiatric assessment, the person remains accommodated in the emergency department. We know that the longer you wait in the emergency department, the more likely you are for your distress to heighten, the more likely you are to abscond from the emergency department, which is high risk because you might come to harm after you leave. And unfortunately, the more likely you are to require seclusion or restraint to keep you safe. It is highly distressing as a clinician who has chosen to train because we want to help people to be having to administer restrictive practice like seclusion and restraint within the emergency department, or have police in the emergency department have episodes of occupational violence, when what we want to do is provide a therapeutic environment, use our skills and help people. I just want to make sure as well that we don't equate mental health with occupational violence in the emergency department. The vast majority of consumers who seek care in emergency departments with mental health problems behave well, and occupational violence comes from a broader spectrum. So I think that's been a big part of stigma in emergency departments, is that fear of violence, but it is not this group necessarily who commit it.
Thank you.
I'll probably just add a comment also in regards to patients who do come, often and repeatedly to emergency departments. They can be hard on staff as well, because you're not always seeing a progression in the patient's care and health outcomes that help prevent them coming. And so I think if there's ways that help address that, then that certainly helps support staff to know that when they've helped provide some acute care, there's still the ongoing community care that is helping the patient's longer term journey.
So particularly the silos we see, when I'm trying to refer a whole person and we hit a silo around particularly alcohol and other drug care, social supports with social work, and addressing other social conditions like NDIS support, etc. That's really, and also neglect and child at risk issues. There's a lot that plays out in this space, and we are just inadequately supported to address all of that, both with time and space and senior staffing.
Thank you. The government, Ms. Bell?
Yeah, thanks. Emily. Thank you both for coming along today, and thank you for the very helpful submission. Can I, first of all, ask some questions around the matter, Doctor, around the issue of fragmentation that you specifically raised. It just seems to me that, I'll sort of use the phrase, it's a bit of a wicked problem in that, and mothers might disagree, but we have this, what appears to be a tension between, it might be more than one group, but put it in these terms, that we have some manifest shortcomings in the way in which we deal with mental health in our state, in our communities. Therefore, we need to see what we can do to lift the boat up across the state of New South Wales, because mental health has no geographic restrictions. And that clearly has a cost for government, or a cost for the state to do that, to increase, at least on the face of it. There is then the set of arguments that I do understand. I do understand the impulse for these arguments and the arguments themselves, that we need to deal with mental health in the context of specific population cohorts, that there are identified cohorts that we all know, we know for some time, and we need to provide some specific attention to those and treat them as a cohort that requires that particular type of, dare I say, tailor-made attention. Is that the fragmentation that you're talking about, or your fragmentation is a much larger melee?
Yeah, thank you. That's a fantastic question. And look, there are groups that require special attention, and I would like to acknowledge that First Nations people have worse outcomes in emergency departments and have worse outcomes when it comes to interacting with mental health services, and that intergenerational trauma is not addressed. A large part of this is socioeconomic. So if I had a magic wand, I would address the socioeconomic determinants of mental ill health. That's just acknowledging that. I think the trouble from the emergency department perspective is the services are based around a particular diagnosis, or around a particular age group, and increasingly are private. So there's issues of who can pay and referral pathways as well. I don't have great visibility. I'm someone who's deeply interested in this and has done a lot of additional learning over my specialist qualification in emergency medicine in this space. I couldn't outline the services available to people who come to my emergency department. It's not visible to me, and it's not available to me to learn about that. There are a number of people who I think come to the emergency department.
Can you just pause there for a moment? I mean, that just seems to me to be, for someone who's so well qualified and has just said that they've done and made a deliberate attempt to inform themselves and become more clear about what's possible. You're saying you don't.
Well, so if I take, for example, if someone presented to the emergency department with chest pain, I wouldn't have to refer every patient into a mental health service. I would be able to deal with a lot of that myself. I'd feel confident in my decision making. I would have tools and education available to me to support my skills in that space. But I would also be able to refer that person for follow-up testing, outpatient cardiology referral, or a chest pain clinic without having to seek, a specialist opinion, wait for a specialist opinion to do that, because I have visibility and I'm empowered to refer to those services.
Yep.
Because the mental health system sits outside the acute hospital system,
Right.
I don't have access to that in the same way as an emergency clinician. I think that's solvable, but I also note that a lot of the mental health services have wrong doors. So we've seen some really good things happen in their models that we support as a college. So things like the rise of safe haven cafes, the PACER system, etc. There's been a lot of good things. But they've been designed to support people and be a form of early intervention. But if there's nowhere to go from those systems and they come into the emergency department, we become a catch-all, and then we're having to navigate a lot of wrong doors on the way out, which becomes really frustrating, but also really damaging for patients who are anxious and in crisis, and we can't navigate it either.
You made the, I thought, very interesting point in your opening comments, Doctor, about the whole person, so what comes through the emergency department entrance. They've, upon the diagnosis and the treatment, identified that there's a mental health element to their circumstances, but then the other. I'm just wondering, would you mind, based on your experience and study, and maybe Dr. Chan might like to add to this, is there any way of actually easily summarising what the other is, or the other in fact is in fact so large that it's almost a universe into itself and very hard to sort of break down.
Yeah, it is. It is very large, and we know that those people with mental health conditions also can suffer other physical conditions and present later and present sicker, and it's really important in that focus to ensure that when assessment occurs, it covers all those aspects. And the ability to communicate, for example, otherwise symptoms that Claire talked about, chest pain and other things, may not be as obvious. So there's the additional effort that needs to be taken in order to try and find out that information. Someone's distress may actually have a physical cause to it, and that actually needs to be worked up in conjunction with the mental health background, because it may not be the mental health background that's causing the symptoms at the time. The preference obviously is that assessments in both spaces occurs concurrently. And so that the emergency department in its aspects to look at some of the physical and medical treatment aspects occur in conjunction with the mental health aspects of assessment. Sometimes some aspects take a greater priority, sometimes they take other, but that's worked out between the clinicians, and so that the patient has the best outcome in the shortest possible time.
So Trevor's made an excellent point, which is we know that people who live with chronic mental illness are politically marginalised and they don't have good access to other health services, and there's a significant health gap there. In terms of the emergency department, there is a major crossover between people who present with mental illness who also have issues such as homelessness, drug and alcohol issues. They're self-medicating because they can't access or afford mental health care, so they self-medicate with drugs and alcohol. Also disability, unfortunately, and also chronic pain. But that becomes very hard to navigate. All of those services are very specialised, they're all under pressure, and trying to navigate all of that from the position of the emergency department. We're working on a model that was designed for people to be under our care for less than 4 hours. That's just impossible, and it must be impossible from the position of a general practitioner working in the community as well.
And just one final one quickly. With respect to a witness earlier today, it was put to the witness that the intrinsic framework that GPs operate under in terms of the way in which they bill agitates against, dare I say, I think this is no reflection to GPs, but the actual gearing of it in terms of charging obviates against the sorts of treatment that such individuals who are or do have an acute mental health problem actually do need, and the question, it was a rhetorical question of if that proposition's accepted, is there anything that can be done about it?
Oh, I have no doubt that episodic fee-for-service care doesn't work for chronic longitudinal conditions. We know that a multidisciplinary longitudinal care pathway is the best for anybody with a chronic condition, and that's not the way our current system is set up, either in the acute hospital system or in in private community-based general practice. I would look to the ARCHO model for a good model where you have...
Sorry, which model?
The Aboriginal Controlled Health Organisations.
Okay.
Community Controlled, sorry,
Yep.
I left out community, ACCHO.
I think.
Where you have salaried practitioners, admittedly working against targets and KPIs, but working holistically together in a multidisciplinary team, but paid a salary so they can actually develop longitudinal relationships and don't have to work on that episodic basis. That's also true of psychiatry, I believe, as well. But another factor here is being a generalist is really hard. It's hard in general practice.
Yeah.
It's hard in emergency departments. It would be hard in general psychiatry. As people feel under pressure, their tendency is to specialise, to find a niche and expertise and get really good at that. And that's a way of controlling your workload and feeling, I guess, safer with what you're doing. And we've seen that happen as the systems come under more and more pressure. So we need generalists, but I think we need to recognise that general psychiatry will be very hard. Emergency medicine's very hard. We're seeing fragmentation and diversification with our workforce. And I think that's something that, in general, the New South Wales government needs to bear in mind is people working in generalist positions need to be judged as generalists, not as subspecialists. And increasingly we're seeing subspecialist frameworks applied to generalist models, and that is very, very hard to do. It doesn't make money, and it means people are subject to burnout when the expectations of their services are too great.
Thank you.
Mrs. Connor?
Thank you both for being here today, and thank you for your submission. I note from the evidence you've already given, and it's reinforced by your submission, the difficulties of the intersection, if we can say, between the psychiatric care model and the medical model in ED. And you've highlighted the fact that the ED is a 24-hour environment, but psychiatric services may only be available during business hours. So are staff in emergency medicine adequately supported by access to skilled mental health staff so that they're supported to do their job well and they can provide the best care for the patients who come to see them?
I think it could be better in that space. There is definitely support. It will vary across the state because of the different size and scope and availability. It will vary depending on the hour of the day as well. And when people come to the emergency department, whilst you can average out the numbers, for a day or a week or a year, the timing when they do arrive may be more clustered. And so it's mechanisms that help manage the clusters where the resourcing at that particular time may not actually match up. And that makes it tricky because then if you're waiting on an individual to help you with your assessment, for example, but there's 3 or 4 people all waiting, then inevitably there are going to be delays. So it's a question then about how the individual services develop strategies to help minimise that risk.
I'm interested in your comment about differences, different time of day and difference through the regions. How much support is available in an ED from psychiatric staff in country and regional hospitals?
I can give a general comment in that space.
And perhaps you could also explore how that compares to the support available in city hospitals.
Yeah, I think there's probably no doubt that some of the city hospitals have more access in terms of physical people. We're dealing with workforce shortages in general, and so that makes it more difficult. I think aspects there where there is a component and use of some of the telehealth virtual side, and I know there have been comments before about the risks and benefits, and that's acknowledged in different spaces as well. But it's an option that is available to a certain degree and does need to be utilised as the system tries to improve the workforce side.
Would telehealth be an adequate support in EDs in regional and rural hospitals for patients who present exhibiting acute symptoms, potentially creating risk for themselves and others? It's not a substitute for face-to-face care. I think that's probably important to note. It's an adjunct in that space, and it also looks at what's the alternative in the current environment that you're able to be able to provide. So there's no doubt you have what you prefer and like in terms of face-to-face care, and I think that's still the preference, particularly in mental health assessments, because so much more can be added there. But it does probably have a role, I think, in the adjunct space, and I think that's really where you would be looking at how do you do it. It adds benefits in the context sometimes when patients themselves have to move around the system in order to get perhaps the face-to-face, and making So just picking up on that comment, patients moving around the system, does that indicate that patients who present in a rural or regional setting may have to move to the city to get adequate psychiatric support?
Maybe not the city, but to other aspects, depending on how remote your presentation is and what's available within the regional space.
So the services wouldn't be the same offered to every patient in New South Wales?
I'd probably have to look at that more generally in the context of what each individual local health district has, and it's probably more a question to the system as a whole in that space as to what they have offered, depending on where you present and when you present.
So taking that on a little bit further, I think, so just to give you an example, if you were landed in Nyngan with an acute psychosis, you probably have to get into Dubbo. Where I see the telehealth as useful is to help support that decision making around who needs to be transferred for definitive care and who doesn't, because you don't want to be transporting people across vast distances away from family and country unless you have to. But we also know that a warm referral is really important, particularly in the drug and alcohol.
What's a warm referral?
A warm referral is where you meet someone who will be involved in your ongoing care. So instead of something we do often in emergency departments is send someone home with nothing but a business card and a number for a crisis. But we know that if you've met someone and talked to someone who's reassuring and is a presence, you're more likely to follow through and seek further care with that service.
So I guess what I'm trying to explore is the experience likely different for patients in regional hospitals than in city hospitals? So what deficits might regional patients experience compared to their counterparts in larger towns and cities?
They're less likely to have a trained mental health clinician on the ground.
So less likely to have a trained mental health clinician on the ground in country hospitals?
Yep. They're also, there's an issue of gazetted facilities. So, for example, someone who's under the Mental Health Act can only be assessed in a gazetted facility. That's fairly easy across Sydney. Not every emergency department is gazetted. You might be surprised to learn that. But if you look at rural New South Wales, it could be vast distances to a gazetted facility. So someone who, for example, is experiencing psychosis, police might be called, would need to be transported often hundreds of kilometres to get to a gazetted facility if they're under the Mental Health Act.
And who manages that transfer?
It's a combination of police and ambulance, depending on which service is initiated first, and that's another big cause of inequity, which is depending probably on, the knowledge of mental health issues and also probably their socioeconomic status of the person who calls the emergency services. Some will define an acute severe behavioural disturbance as a medical issue and call an ambulance, and others will define it as a criminal issue and call the police, and that can label you for the rest of your journey in the system.
And just going back to the role of the ED physician, an ED physician in a regional hospital, are they likely to have adequate human support from a clinically trained psychiatrist to help them?
Workforce is incredibly difficult in rural emergency departments. The range of people employed in rural emergency departments in the medical space is very varied. So some of them will be fully trained specialist emergency physicians like Trevor and I. Some others will be GPs with an interest in emergency medicine. Usually they've done additional qualifications as well. Some of them might be locums. And
will they be adequately supported by access to a psychiatrist?
I haven't worked in that environment enough, but from what I have seen, the little I have worked, is it's incredibly variable, and there's a lot of fly-in, fly-out psychiatry that happens, and it happens much more in the longitudinal outpatient space than it does in the addressing and supporting an acute crisis space.
Okay, thank you.
Thank you. Thank you very much. That brings us to the end of our session. Thank you again for all the work that you're doing day to day, the time you've taken to prepare the submission, and for taking the time to share your expertise with us. It's really valuable.
Thanks for the opportunity to speak with you.
Thanks for having us.
And the Secretariat will be in touch if there's any questions on notice. Welcome. Thank you for coming today. Could we please start with each of your name, position, title, and either the oath or the affirmation?
Brooks. I'm the Chief Research Officer at Lifeline Australia. And the affirmation, I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Apologies. Hi, I'm Tara Hunt. I am the Deputy Chief Research Officer at the Lifeline Research Office, and I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you. Would you like to start by making a short opening statement?
We would. Thank you very much. Thank you, Chair, for the opportunity to speak with you today. My colleague, Dr. Hunt, and I are pleased to represent Lifeline Australia in this important discussion about equity of access to outpatient community services in New South Wales. By way of a little bit of context about Lifeline, our network has 16 centres located across the state. A number are based in the Greater Sydney area, and the network ranges south to Lifeline Albury Wodonga, west out to Lifeline Central West in Dubbo and Lifeline Broken Hill, north through Lifeline Mid Coast at Port Macquarie Kempsey, up through Lifeline North Coast at Coffs Harbour and to Lifeline Direct in Lismore. Our centres deliver a mix of digital mental health services, including our helplines, for which we're best known, and our 13 11 14 voice service is probably the one that most people know Lifeline for, as well as face-to-face community services, including suicide bereavement support groups, aftercare for people who've attempted suicide, and financial counselling services for those experiencing financial distress. Lifeline's a not-for-profit with the vision of an Australia free of suicide. Day to day, when we're designing and delivering service, our fundamental approach is to keep the help seeker at the centre of all that we do. And from people with lived and living experience, and consistent with the recommendations from a number of inquiries, we've heard loud and clear that ease of access to services is a key issue. Knowing where to go and how to navigate the system once there is incredibly challenging for people at the best of times, and even more so when they're experiencing distress. It's because of this that Lifeline's role as a front door to ongoing or additional service access is a key issue of focus for us. And to support us in that, and as you'll have read in our submission, we recommend system enhancements including prioritising a mix of services, both digital and face-to-face, supporting additional services tailored to priority groups, enhancing connections between support lines and the broader mental health system, and workforce planning that includes volunteers. And we look forward to the opportunity to discussing some or all of these issues and challenges with you today. Thank you.
Thank you. I've got a question coming out of your very detailed written submission. Thank you for the time you've taken to prepare that. You mentioned that Lifeline had a new system to provide seamless, appropriate and tailored referrals. As you probably know, we've had a huge amount of evidence about the need for that sort of system in various contexts. So I'm keen to understand more if you're able to share with us how that system works, how you're using it in some more detail.
Sure. Thank you. So in terms of providing referrals, and I'll speak now to the helpline, so our call, chat and text services, we have what's called a service finder. So the crisis supporter, who's the person on the end of the phone when people call in, is able to, based on the content of the engagement with the help seeker, is able to, if and when appropriate, look up additional services that might be fit for purpose pending the issues that the help seeker has raised. And that can be, obviously the crisis supporters looking not only for services that are actually, subject matter relevant, but also they can look at what's geographically, sort of proximal to the help seeker. So the crisis supporter uses that to I guess, help navigate the system with the individual who's called in for help. In that helpline context. And an additional and new sort of aspect to how we provide referrals to people reaching out to us for support is via our self-support toolkit, which is available on our website. The self-support toolkit's designed so that people can self-navigate, they can find information based on how they're feeling, rather than trying to self-diagnose. They can just talk about what's going on for them, and the self-support toolkit guides them to information that's going to be helpful to that individual, and also provides referral points that are relevant to the presenting issues that the person has engaged in with us. So the sort of exciting part of that self-support toolkit referral system is that we can actually then track whether people use that referral that we've provided to them. So that's sort of given us an additional capability to look at whether the referrals that we're providing are actually accessed, and and by virtue of whether they're accessed, we get a gauge on what's helpful and what's not helpful in terms of our onwards referrals.
And just to add to that, so that system is constantly being developed and refined, particularly with the support of a lived experience advisory group. They have given the very firm and clear guidance that it's really important for referrals to be provided in a range of different ways that are appropriate for the needs of the person. While one person writing down a number as has been for a long time the case, is the preferred way. Other ways are receiving that SMS message. And using this system, about 65% of calls to Lifeline do end up in a referral to a range of services, as Anna has said.
Thank you. I'm also interested in your experience managing a significant volunteer workforce. I think that's fairly unique in the sector. There's obviously really broad workforce challenges in the mental health sector generally. I suppose, could you speak to some of the benefits and also the challenges of working with volunteers?
Sure. So starting with benefits, I think that the Lifeline approach of being, of the community and for the community really helps in terms of the trust that people place in the Lifeline service. So when you speak to a Lifeline crisis supporter, typically it's going to be someone who, the person doesn't have to be trained specifically in mental health. It's not necessarily a clinician that you're speaking to, in most cases it's not. It's someone who has decided that they want to make a difference to their fellow community members and has put their hand up to do, it's a rigorous training process that we provide, but it's a training process that's not dependent upon having qualifications in mental health in particular. So I think that the fact that people are talking to just other folks who are regular community members across the country who, albeit are well trained, they're not necessarily mental health clinicians, is a really powerful part of the value proposition of Lifeline. It's a non-clinical service. It's regular people helping out other people who are in distress. And again, I think that the huge advantage of that is that it really, we're very visible in communities, and people know that there are people within their hometowns who are Lifeline crisis supporters. So there's good awareness of, the community roots that our service has. That's some of the key benefits to our volunteer workforce. In terms of challenges, as you'll know, recruiting and retaining volunteers, particularly in the current climate where cost of living is a real issue for many people, is super tough. We're like other volunteering organisations. We're really having to look at how we bring people in to become crisis supporters, and then how we, if we can get them to join us, then how we keep them as part of the Lifeline workforce. It's challenging. We're looking at a number of different ways that we could possibly try and adjust, given that it is such a challenging environment, but that's sort of a bit of a work in progress for us. One of the things that we have raised in we did raise in the submission was that we would like to have seen the volunteer workforce considered in the National Mental Health Workforce Strategy. Unfortunately, that's not quite the way it worked out. But we are looking at ways that we can try to rethink how it is that we structure our training, make it easier, more accessible for people to become volunteers. Just noting that it is really tough to get people to when they're having to do paid work in order to pay the bills. How is it that we encourage people to actually put up their hand to invest the time in being a volunteer at the moment?
Thank you. That was really comprehensive.
Yeah, I think the thing that I would add is that over the 60-year trajectory that Lifeline has had so far, we've come a long way, and we're quite responsive to developing technology. So for a long time, the telephone was that modality, and that required a person to be in the room at a centre. With the emergence of text-based technologies, that formula is a lot more flexible to the time and capacity and geographic location of the person. So while a person might really want to give back to their local communities by being a volunteer for Lifeline and talking to people like them who are in crisis and experiencing distress, being on the phone in a centre might not be an option for them, but using the text service, which is a remote service, might be more accessible for them. So, working within those challenges with the use of technology has definitely been one of the ongoing pieces of development for Lifeline.
Thanks. Ms. Connor?
Thank you very much for being here, and thank you for your submission. I'm very interested in the figures that you provided under the heading of equity of access to outpatient, and you look at the Medicare benefit scheme. Underutilisation people living in very remote areas, 3% relative to 11%. Do you have any more thoughts about that? Is that simply because services are not available to people living in regional and remote areas, or does it indicate robust levels of mental health in those areas?
I think that there's probably a number of factors at play. I think the availability of services is probably one of them. But we know that people in regional and remote areas, that in terms of mental health, there are particular challenges. Greater levels of distress, and indeed in rates of suicide. That's something that has, it's a robust, unfortunately, it's a robust sort of phenomenon in the data. There's a number of reasons, like evidence-based reasons, for that being the case. Some of the protective factors for rural and regional people, community, people that, often know their neighbours, engage with their neighbours, will help their neighbours out. So that's one of the things that can be really protective. But some of the things that can be particularly challenging for mental health for people living in outside of metropolitan areas are things like, access to means is an issue, familiarity with means, particular stressors around, socioeconomic disadvantage, and of course, in that mix is access to services as well. So it's multifactorial, I would say, but yes, being able to, I think the previous representatives the previous people were talking about, face-to-face services being, in many cases the preferred approach to supporting people. But we also, one of our key services is delivered via the telephone. There are opportunities, I think, to use, as Tara mentioned, digital services to do some of the heavy lifting around supporting people's mental health. In some cases, the anonymity that's provided by being able to do it from a distance is an advantage. Farmers, for example, who, in which a community in which stigma around mental health is a significant factor, sometimes will express, that they prefer to be able to engage in ways where they don't necessarily have to front up and present them, say who they are amongst, in a community where, people, they're known. So there are contexts in which digital service provision as a complement and, as a way of, providing a universal broad level of support can be incredibly useful. So there are opportunities that I think certainly the Lifeline network provides, both via face-to-face and digital service provision to reach rural and regional communities, but certainly those challenges remain for those people. Yeah,
and I note in that respect your comments at paragraph G, and I respect your opinion because you're probably the pioneers in the provision of telehealth in a sense, but the idea that it needs to be part of a mix and that we can't just say to people in regional areas, well, you've got a telephone, what else do you want?
Yes.
No, thank you for that. And I wanted to follow up the experiences that you're having in relation to the referral system that you've developed and the tracking facility that has. And I understand that you may not have the data available, but I would be very interested in receiving updates on this, because from the witness evidence and the submissions that we've been receiving, part of the navigation problem is finding the service, but part of it is also making the appointment, which if somebody isn't well can be quite a barrier. It can be getting the appointment, and I wondered the extent to which your service was able to facilitate that, or whether that was even from the follow-up data that you are gathering, whether that's perceived as an important part of any navigation service.
So it's definitely a challenge, and I think the previous speakers noted that warm referrals are always better than than giving someone a telephone number or the name of a contact. It's challenging though. So Lifeline, we have a number of services under our banner, and within underneath our service, like within our service ecosystem, we can do a lot more in terms of trying to make it a seamless transition from people. They might ring 13, 11, 14, and then, pending how they present, we might feel that the crisis supporter might decide that perhaps Men's Line is a service that will meet their needs. In addition to being able to speak to 13, 11, 14, Men's Line is going to add value to the service provision to this person. Within those services under our control, that's it's still challenging, but that's something that we can do a lot more easily than we can to warmly transfer someone to a service that sits outside the Lifeline umbrella. It has forever been a challenge. It remains one. We're working on it, but technically it's quite tricky. I mean, even the fact that, 13, 11, 14 is open 24 hours a day, 7 days a week. Many, many, many other services, as you'll be well aware, are business hours services. So, when you have someone who calls in at 2 a.m. and would benefit from support from another service, it's well nigh impossible a lot of the time to actually do a warm transfer at that time. So, it is a significant challenge.
Yeah. Thank you very much.
Thank you. Mr. Bell?
Appearing today. Just wanted to start, if I can, with a question about your call centres or text service. Who operates these?
So the Lifeline network, so it's spread across the nation, but we'll focus on New South Wales. We have we have 16 centres across New South Wales. Not all of the centres deliver the helpline services. Okay. Most of them do, and most of them will deliver not only the helplines but also, as I mentioned earlier, community programs, things like suicide bereavement support groups, financial counselling. So Tara and I both sit within the national office, which is based here in Sydney, and where it's the role of our organisation, Lifeline Australia, to enable and facilitate the centres located across New South Wales to provide service to people.
And with those 16 centres, does Lifeline run them all, or are they various?
So they're members of our organisation. The Lifeline network, broadly speaking, comprises Lifeline Australia as the national office, and then we have members who are the centres who sit across the different jurisdictions. So we have a federated model, and they're members within our federated model.
Okay, but yep. Lifeline is responsible for running them, so it's not outsourced to another sort of not-for-profit in the area or anything like that.
That's right. I mean, we form partnerships with other organisations. Like we have one with Headspace where we'll deliver a program, the Community Collaborative program. Yep. So we do service provision in partnership with other organisations from time to time, and as needs demand. But we, the services that we deliver through our network are Lifeline services. We don't outsource.
Okay, beautiful. Thank you. That helps. In terms of the 65% of calls that you said end up in a referral to a service, I'd be interested to know if you have any information around what happens to that 65%. Indeed, you provide a referral, but we've heard about the limitations when it's not a warm referral. What happens from there?
Yeah, so as we were saying earlier, it's at the moment it's a challenge to know what exactly happens at the conclusion of a call. We can provide the referral, but at the moment our ability to track the impact and the uptake of that is limited. So the crisis supporter works with the help seeker to empower them to make the next steps that they need, and that may be a referral. And we are definitely working on our capability to be able to have more of an understanding of what exactly happens at the end of the call. But one of the limitations inherent within a one-off crisis support service where the benefit is anonymity and confidentiality, that adds a significant challenge to us in terms of continuity and knowing what happens at the end of the call.
And do you measure distress score, like levels of distress with people, ask them at the start, ask them at the finish? Do you have any data around that?
So not consistently. Outcomes measurement is one of the areas we're looking at the moment, but it's one of the challenges in providing a crisis support helpline is that expectation, and one of the things that is advantageous is that people know it's a low barrier to access service. You don't have to say who you are, you don't have to provide any information about yourself. So we're always very conscious of sort of adding in surveys and data capture points because we don't want that to serve as a barrier to people using service. And the other, the other consideration is that we're essentially an ambulance service. Where a lot of people ring us in a state of extreme distress. And we try to get them to a crisis supporter as quickly as possible. So again, having in our, in the process of getting to a crisis supporter, adding in sort of points where we capture data is something we're very careful about. Just with a view to not making it adding any time in between someone making that call and someone speaking to a crisis supporter. So it's something we're looking at, but there's some reasons that we've been sort of very cautious in our approach to applying an outcomes measurement framework.
Sure, thank you. That's helpful. How have you found the availability of safe havens and the ability to refer to them, if there's anything you want to talk about there?
So, look, I think, broadly speaking, I think safe havens are a fantastic development. I think the amount of lived experience sort of consultation, or the work that went into devising the approach is very encouraging. I think it's wonderful to have. I think you've probably heard at length some of the challenges around trying to support people in the emergency department environment. It's noisy, it's busy. It's probably one of the worst environments that you can have for someone who's experiencing significant psychological distress. So I think having safe havens as a physical option, somewhere people can go, where there's peers available who can support them in when they're doing it tough, is a positive development. It's in some ways it's sort of a physical manifestation of the sorts of things that Lifeline does. So it's it's essentially peers that you're talking to, people who have training in the Lifeline context but are not clinicians. You can just check in when you feel like you need to in order to try and support your mental health if you're experiencing distress. So I think broadly speaking, safe havens are a terrific development. I don't think we can speak to specifically how often we refer to them, but they are part of our service finder, our referral database. Yep.
Sure. Thank you. Thanks, Chair.
Thank you. I was interested in your written report. You talked about a project underway with the University of New South Wales on how to support people in acute distress in public places.
Yes.
I'm very interested in that work. Are you able to speak to it at all in any more detail?
I can. So not to the results. It's still sort of in train, but broad brushstrokes, if that's okay.
Please.
So look, we're partnered up with the Big Data Centre at UNSW. We've got a great team we collaborate with there. That project is related to, is focused on attempting to identify, people in distress in public places, and as part of that consideration, we have built into that project a very specific sort of set of ways to devise what a best practice intervention looks like. So if you do identify that someone's in distress in a public place, what does it look like in terms of the best possible way to actually intervene? It's a challenging one, as I'm sure you're aware. A lot of people have had traumatic experiences with being intervened with by the police in the past. So what does it look like to actually be able to approach people and intervene if they're in distress or considering suicide in a way that has positive outcomes for that person, or maximises the positive outcomes for that person? I don't know what the answers are going to be yet, but that's certainly the research approach is very heavily based on a deep engagement with people with lived experience of that particular circumstance. So I think it's going to be very interesting to see where that goes.
Absolutely. I think that's of great interest to the work that the committee's doing. Do you have a sense of the time frame?
I think within this next 6 months I'll be able to give you some answers. So if it would be very helpful, if it would be helpful, I'm very happy to share as we as the data emerge what that project tells us.
Thank you. I'd be really interested.
Sure.
I've got one last question, which was you mentioned in your written submission some of the challenges posed by short-term contracts, particularly from government or through government. What's the ideal length of a contract?
I think that's sort of what's, how long's a piece of string in a way. Longer is better. Longer is better. It's hard to, I think, centres that aren't based in metropolitan areas all tell us that attracting workforce, to those areas is particularly challenging when the contracts that they can offer are, sometimes a year, sometimes 18 months. For people to uproot and move to different, and move to a town where they're not sure if they'll have employment on an ongoing basis, it's challenging. So I think I would just say the longer the better. It does present a significant challenges to our centres being able to attract the staff that they would love to have.
Can I just jump in with one final question? You may have been here earlier, and welcome. Thank you very much for your attendance and submission. Previous witness and others have spoken about the challenge about fragmentation of services, and being able to even locate a domain to go to find services.
Yep.
Is that an experience that Lifeline's had, a challenge to just know what's out there? And dare I say, this is a New South Wales parliamentary inquiry. So, I mean, for the state of New South Wales, is there anywhere where there is a repository of this information about services for New South Wales, or is it ad hoc and spread out by local health district? What's your observations?
There is I can't remember what it's called, but so our service finder is based, there is a repository that we access to support that service finder function I was talking about before. But it's challenging, right? Because a clinician can be there one day and then not be there the next. So it's a challenging thing to collate the data, but even more so to keep it up to date.
Yeah.
So we do, as I said, there's a service that we access, and I might take that on notice and let you know what it's called. But I think it's imperfect, and it really is one of those issues. It's a tricky one to solve just because it is a constantly shifting environment. So it needs to be updated very frequently.
Doctor.
And I think the thing that I would add is from coming to this from a community and non-clinical perspective is an issue of language about the words we use to describe our own personal experiences and whether they actually match up to what the services that the services say they offer. So what exactly is that? We know that about 54% of our callers call with more than one presenting issue impacting them in their lives. So where to even start? They often contact Lifeline before they have really even a conceptualisation about what that primary issue is, or they've actually expended all of their other options and they don't know where else to go. So that's one, and that again is one of the real challenges in terms of trying to find the services as well. Is how do I conceptualise and communicate what I need to be able to find that referral? And that service that we use is, I believe it's called Ask Izzy.
Thank you. Thank you, Tara.
Thank you, that's very helpful. Thank you.
Thank you. Thank you so much again for the time you've taken to prepare your submission and appear today, and also for all the wonderful work that Lifeline's doing every day.
Thank you very much.
We really appreciate
Thanks
it.
for having
And
us.
the Secretary will be in touch if there's any questions or notice.
Thank you.
Thank you. For the information of those in the gallery and anyone watching online, we're now going to have a break until 1:30. Welcome back, everyone. Thank you so much for being here today. Could each witness please, starting from my left, state your name and position title and then take either the oath or the affirmation.
Yes, my name is Brett Collins. I'm the Coordinator for Justice Action. I take the affirmation. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
My name is Lily Malin. I'm the mental health spokesperson for Justice Action, and I take the affirmation. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
My name's Todd Davis. I'm the Solicitor in charge of the Mental Health Advocacy Service at Legal Aid New South Wales. I solemnly and sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
And I'm Callum Hare, Senior Solicitor with the Mental Health Advocacy Service at Legal Aid. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you very much. Is there a short opening statement from Justice Action?
Yes, first of all, I acknowledge the traditional owners of the land, elders past, present and emerging. We're particularly addressing issues, terms of reference, C, F, G and I, and the police, the intervention, crisis intervention will be addressed particularly by my colleague Lily. We've come to the stage, we are hopeful that this inquiry will offer something fresh in an area which is actually a place which is quite negative. And for us, actually, for our people, and I'm talking about our people who are actually the ones who are subject to psychosocial challenges, that they've been treated very harshly by the health system, contrary to what one would expect. They're left feeling damaged, feeling fearful, and in fact, there's no question that it's worse to be mad than bad. There's no question about that. We've done many cases over the last few decades. In fact, we had 7 people who are for whom we're primary carer. We've been at least 60 times before the Mental Health Review Tribunal. We've been 4 times to the Supreme Court. We feel like in despair that there has been no change in the space, because these are our people who are being directly affected. We've put together before the committee a number of documents which have quite a significant amount of research has gone into those documents. Additionally to that, and we have also included a letter from the Friends of Cannon Park in support of the Cannon Park proposal. Now, what I'd like to point out is that there's a document which we launched. It's called the outpatient report, and it proposed, and it says it was launched in 2010, and it's referred to in the documents that we've offered to you. And at the heading of it, it's actually, this document was launched in Belfast and also at the Forensic Hospital in 2010. And it says at the beginning, it says the outpatient report accuses the Australian health industry of corruption and proposes the empowerment of mental health patients and prisoners to achieve effective delivery of services. And the first proposal is that a fixed percentage of 0.1% of the mental health budget be set aside as mandatory funding for independent consumer groups. So what we're saying, we're finding consistently, is there's no one who is prepared to defend the consumers and not be fearful in that process. We've had to run the case, as I say, 4 times before the Supreme Court, and in the last occasion we were actually able to achieve then agreements with the Mental Health Review Tribunal and come up with this particular document, which has been created with the Mental Health Review Tribunal, called the Mental Health Consumer Information Sheet, to which a number of benefits go to the consumers. But when it comes to actually presenting before the Mental Health Review Tribunal, the benefits of those agreements are never carried out in place. They actually, now before this hearing today, we have prepared. We had 2 meetings with the legal aid, with whom we're sharing this presentation, and we had 2 meetings in preparation to try to come to some agreements about the things that we believe are important, where we think that the people who come before the tribunal can be better presented and can better respond to the community treatment orders applications that are before them.
Two things we said was, could we expect at least that the chief psychiatrist's communique, which is contrary to the law, and which is direction to the clinicians, that we get support from them, that it actually be withdrawn, one. And two, we've said, can we adhere to procedures which have been agreed to and which are on the website for the tribunal, which allows the consumer, the person before the tribunal, to see what is said against them in order that the order should be created. So we're talking at the front line, where the actual decisions about community treatment orders should then be considered. And we're saying, can that person see that document as they're entitled to, which is a part of the procedures that is up on the website of the Mental Health Review Tribunal, and be given a chance to respond to the issues that are raised in the document, normally a 3-page document, and can they see that, please, as has been agreed, and which we had won back in the year 2014, with the case of Said Disfordy against in the Supreme Court. The Lindsay judgment laid that down. In fact, we had an agreement for 2 weeks' notice for all the information that comes before the tribunal to be given to the person who is affected by the order. In fact, what happens is the person who's affected by the order never sees the document. And we asked, can we make sure that that is actually available to the person, because after all, that is the document which affects their future. We didn't get an agreement. We're asking that there be enough time for that document to be shown, as is the entitlement which we fought for before the Supreme Court. We didn't get agreement on that. So therefore we're looking for support, at least for the law to be maintained, and the procedures that have been agreed to, they should be adhered to. Thank you.
So, opening statement from Legal Aid.
Thank you very much. We are on Gadigal land. We acknowledge the Gadi people, the traditional custodians of this land, and pay respects to their elders and extend that respect to all Aboriginal and Torres Strait Islander people present. The Mental Health Advocacy Service is a specialist service within the Civil Division of Legal Aid New South Wales. Through a combination of in-house MHAS and legal aid solicitors and members of the private profession, we provide representation in over 11,500 proceedings annually conducted before the Mental Health Review Tribunal, of which over 1,500 involve community treatment orders, usually applications for orders. Our submission draws on our experience, as well as the Criminal Law Division of Legal Aid and the Coronial Inquest Unit of Legal Aid. We acknowledge the committee has heard from many people with lived experience of mental illness. We value the opportunity to hear directly from them regarding their experiences of community mental health care in New South Wales. We also acknowledge the expertise and commitment of those who provide care and treatment to our clients, including members of New South Wales Health, carers, family and friends of clients. And we appreciate the productive working relationship we have with the Mental Health Review Tribunal. Our primary concerns that are highlighted in our submissions are, firstly, the paucity of evidence regarding the use and efficacy of community treatment orders as a means of providing the least restrictive form of care capable of providing safe and effective care. That may be addressed through funding a multidisciplinary independent project to determine those issues. We also propose a number of statutory amendments ensuring the principle of least restrictive care is adhered. Secondly, we are concerned that often community treatment orders are used as a means of ensuring people are provided care and treatment, or the appropriate level of care and treatment, and if a CTO was not made, the person would not receive that care or treatment or the level of care and treatment that they would otherwise receive. Thirdly, we note limitations in the provision of community mental health care in regional areas of New South Wales. Fourthly, we note the need for the community transition team in Justice Health to receive greater funding and be able to service all correctional centres in New South Wales. And finally, the need for PACER to operate in all police area commands in New South Wales. If there are any questions that the committee would like to ask, perhaps I will tend towards issues that perhaps involve community treatment orders and legal aid policy, and Callum would probably be most suited to the balance of questions in relation to those other issues. But of course we will be in a position to assist the committee together if needed. Thanks.
Thank you. Thank you very much, and thank you to all four of you for taking the time to prepare quite detailed written submissions as well as being here to speak to those submissions today. My first question is to Legal Aid, because you touched on it in your opening statement, that you had some suggestions around amendments that could be made to ensure that CTOs are actually used as least restrictive means. Could you perhaps speak to what those amendments could be in a bit more detail?
In a broader sense, could I just touch on, in a more broader sense, that the legislation was brought in essentially, from our understanding, as a mechanism to allow people to enter the community in a controlled manner, as an alternative to being in a hospital environment under coercive powers there. Therefore, at that time, there doesn't seem to have been a great deal of research or thought in relation to whether that was an effective mechanism. There wasn't studies done to see whether that was an effective alternative to remaining in hospital and what the results would be. What was the purpose? Okay. Would you like to add to?
Yes, look, I think
specific?
One matter we raise in our submission is potentially providing in the Act that the tribunal shouldn't have regard to whether or not a patient's going to receive a better level of service under a community treatment order than if they're not on a community treatment order. Of course, our belief is that community mental health services should be funded adequately to provide services to people in the community, depending on the nature of their illness and their willingness to engage, and it shouldn't require a coercive order to ensure that people receive the assistance that they need. So that's probably a primary point we make. In addition, in our submission we address the fact that in other jurisdictions that have perhaps lower rates of community treatment order use, they often have different criteria to New South Wales, and that's why we're talking about potentially, or suggesting that the New South Wales government fund a multidisciplinary project where we can look at what those other jurisdictions have in place. One suggestion being that it could be a serious harm test built into whether or not a community treatment order is or isn't made. So at present, if you're in the community and there's an application for a community treatment order, there's no requirement for the tribunal to be satisfied that you pose a risk of serious harm to others. Whereas if you're in an inpatient setting and you go before the tribunal at your very first appearance at what's called a mental health inquiry, for a community treatment order to be made at that point of the process, there is a serious harm test built in. Whereas most community treatment orders are actually made when people are in the community on an almost rolling basis for many people. Most of them run for 6 months at a time, but very often it's 6 months, without really turning their minds to the efficacy or the need for the order.
Thank you. That's helpful. And I suppose while we're on the topic of community treatment orders, I'd invite Justice Action if you wanted to add anything. I know you're working directly with people with lived experience of having been on a community treatment order.
Yes, absolutely. Look, the proposal for the withdrawal of the Chief Psychiatrist's communique is extremely important. It, in fact, doesn't quantify any of the risks. It avoids the issue of serious risk entirely, and that is very worrisome. In fact, if you look at the if causing emotional harm, causing financial difficulties, a whole range of things like that could be included as a guide to the clinicians to apply for a community treatment order. That's contrary to the law. In fact, we've put before the committee what the law says. Actually, we've examined quite carefully what the basis for community treatment order should be according to the cases that come before the court. It's a risk to life, a risk of being raped, or a risk of causing psychological harm to the point of causing psychosis. Yet the clinician's direction from the chief psychiatrist's direction is actually misdirects it, and it gives the encouragement to clinicians to impose or ask for a community treatment order. And the issue about whether or not serious risk should be considered, the first community treatment order requires the question of serious risk, which I just referred to a moment ago. Continuing ones don't have the same demand, but they still have the need to consider the least restrictive care, and that's a really significant thing. Because if you look at what the medication is, medication always continues always as part of a community treatment order. the authority is given back to the treating team, the psychiatrist, to do whatever treatment is according to the Act. I think it's 85 of the Act, can decide whatever medication is to be administered, and that's the decision of the not of the tribunal but of the treating team. So the power is then to medicate people, and that always is carried out. So and then what we've encouraged us to talk carefully to legal aid about is to look carefully at the damage that is statistically is proven to receive the medication. That over a longer period, for crisis intervention may well be some particular role, but over a longer period, longitudinal studies indicate that it is 6 times less likely that a person who's on medication will maintain their functionality as a person who doesn't have the medication. And apart from the side effects are enormous. Now, what we propose is instead of the medication, the forced medication, which follows the community treatment order, that what we would expect from legal aid is that they offer things like, for example, peer mentoring, which is actually working with the person and not having a coercive interaction with them. So that's what we propose, and we've actually put that to legal aid, that they should see that as being an alternative way of dealing with an application for a CTO.
And my second question, I think, might be for Ms. Mellon, because you hinted in your opening statement that she might want to speak to the ways that we can improve crisis or emergency responses to people in a mental health emergency.
Yeah, so our position is that the PACER model should not be adopted in New South Wales, and we've taken an evidence-based approach to our suggestions here. And in particular, the Victorian Mental Illness Council has recently released a resource titled Police Apprehension as a Response to Mental Distress, where they state fairly unequivocally that wherever possible, police should not be part of a mental health response because of a variety of factors, such as police intervention being shown to make people feel criminalised, stigmatised and intimidated, which the research is fairly clear on in this area. And then this research on police intervention is supplemented by various case studies throughout the years. For instance, we focused on the case of Claire Nowland, who was the 95-year-old who was fatally injured in an aged care facility during a mental health crisis. So those form the basis of the reason that we don't believe that PACER should be rolled out. And we'd also like to note that PACER has received criticism from mental health experts and the New South Wales Police Association themselves. For instance, the Mental Health Minister, Rose Jackson, has stated that PACER is not up to the task, and that the way that we respond to acute mental health crises in New South Wales needs to change. The Police Association has also called for alternatives to PACER on a variety of bases, but essentially that it is not the best option for anyone involved in these mental health incidents. So we ultimately believe that a model similar to that of Cahoots that's currently implemented in Eugene in the US should be implemented in New South Wales, because it showed vast efficacy on a variety of factors. It has reduced the workload of police by diverting the vast majority of mental health calls to Cahoots. The service users have described positive experiences throughout the process. They've also displayed extreme cost effectiveness in reducing the cost to the City of Eugene and the Eugene Police Department. It's been in operation for over 30 years, so it was implemented in 1989. So the research is extensive on this program, and that's part of the reason why we suggest it, because it has been around for so long and it has shown this efficacy throughout the time that it's been in operation. And we also call for the implementation of peer workers during mental health crises, which could be implemented in collaboration with or within a program such as Cahoots.
Thank you. Ms. Bell?
Thank you so much for your evidence and for appearing here today. I might just continue on with yourself, Ms. Mellon, if you like, and this line of questioning. And I wondered if you could comment more on what the current experience is like with the PACER model and why, for example, a model like Cahoots would be different.
Yes, definitely. So I think from our research, the experience with PACER is that the police are still attending to the mental health crises, and the consumers of the PACER model have stated that police intervention during these crises increases intimidation, and the presence of the uniformed officers in the police car inherently stigmatises them and causes them to feel negatively of the whole experience. So the presence of the crisis worker or the medic, whilst it's been beneficial, is hindered by the presence of the police officer in cooperation, which is why we believe that the Cahoots model is better, because it's a model of non-police intervention, and it addresses those concerns that the individuals experiencing mental health crises have expressed.
Thank you. My next question is, I suppose, more directed to the legal aid of the hearing. You mentioned in your opening statement about statutory amendments, I think, which my colleague touched on earlier. I just wondered if I could invite you to expand on that further, and whether or not the statutory amendments that you are suggesting or that you're seeing that need to be made are just in relation to CTOs, or whether there is a broader need for anything else.
So what Callum mentioned in relation to the test of risk of serious harm, there's an imbalance when a person goes before the, as Callum said, goes before the tribunal on the first occasion, and that is a mental health inquiry. Is around about 800 odd CTOs are made at a mental health inquiry. There's that test that needs to be satisfied in relation to risk of serious harm, but 6,500 odd CTOs are made in New South Wales each year. That test doesn't apply to the balance of those people who go before the tribunal. So it would seem interesting that there's reasons why that occurs, but it doesn't seem to be an equitable application of legislation that test applies at one stage and it doesn't apply at the other stage.
What are those reasons? When you say there's reasons why that occurs, what are those reasons?
So historically, the reasons why there's a mental health inquiry is to determine that the person has been brought before the tribunal in a proper way. The system's been complied with, the admission process and so forth, and that has to be, that the tribunal has to be satisfied that that person has been a mentally ill person as defined under the Mental Health Act. Once that's been satisfied, the person is then, if they continue to be detained at a mental health inquiry under an order, that then if they go back before the tribunal in relation to further orders to be detained, that's a review process. Okay, so at each of those other hearings, it's just reviewing whether they are there properly. It's not that they've been presented in accordance with the Act. The Supreme Court investigated that in a decision some years ago, in the decision of Harry. It's also the test to actually be subject to a community treatment order at the moment under Section 53 of the Act seemed to be quite low, and I think it would benefit the community if the test involved that the person, if they aren't subject to that coercive order, they would pose a risk of serious harm to either themselves or others. And the courts have investigated what that means, risk of serious harm, and it's quite well known. There is a bit of a problem in some respects in relation to when these concepts, risk of serious harm not being defined in the Act, and we think that's correct, there is comments on it in some decisions, but because it involves such a subjective measure, because the risk of serious harm to one person, such as their reputation, a person's reputation is dependent on their circumstances and who they are. So we're in some respects we're seeking that the bar be increased to some degree as a protective measure.
Can I just respond? Sorry.
I was just going to add that the studies, as I mentioned, of the jurisdictions that have lower rates of community treatment orders, that they generally had a test that required there to be a specific, significant or substantial risk of serious harm, as well as there needing to be evidence of a therapeutic relationship if the order was made. So coercive orders, generally speaking, the literature shows undermine the therapeutic relationship between a clinician and a patient, and if CTOs are being made in circumstances where that relationship is being undermined, then one must ask whether or not it's a good idea to proceed with a coercive order as opposed to perhaps trying to use non-coercive measures.
I suppose what I'm trying to get at in my head is that whether it is an issue with the Act as it's currently drafted, or if it's the interpretation or how it's being applied.
So there'd be two ways of amending the Act potentially, but I guess this is probably part of what we consider should be done as a full sort of research project on the efficacy of CTOs. So one is you could ensure that serious harm be added as a test for all prior to the making of any community treatment order, but also the tribunal be satisfied that there be a therapeutic benefit in that clinician and patient relationship. Having said that, to a certain degree, the tribunal can take that into consideration at the moment, because what we're referring to is that the tribunal need to be satisfied of certain criteria prior to making a CTO, but that only engages their discretion to make a CTO. So even where the tribunal's satisfied of those matters, you could technically argue that they should exercise their discretion not to make the order on the basis that it's going to damage a therapeutic relationship, which is not in anybody's interests.
Can I just respond to just a couple of things I'd like to pick up? I just noticed that Todd was referring to a reputational damage. That's not, of course, that's within the chief psychiatrist's communique. It's definitely not mentioned at all in any case around serious risk of serious harm. So I just think that's really important, because you get caught up in the language of, in fact, the chief psychiatrist's communique, which is contrary to what the law has been laid down. And also to talk in terms of it being unsure about what these terms mean, what serious risk of harm actually means, is not true, because the cases have come before the Supreme Court and has been determined as risk of life or death, risk of rape, or risk of and causing psychological damage to the extent of it causing psychosis. That's what serious harm is defined according to the case. Just one more thing too, on the question of, and I think this really is an important issue, is if there's an intended to, if an order is made, it always means that the person receives medication. It always does. To say other than that's quite incorrect. And so therefore it does require an examination of medication itself. Now, we actually have been very carefully into the use of medication. There's quite a clear document which we have examining what the benefit, what the result of that medication is. It's damaging in the long term. In the short term, it may have some benefit. In the long term, it's not. Now, our concern is this, that at the moment there is no data collection of chemical restraint. The term chemical restraint has been very carefully defined by the Commonwealth and by the states, and the chemical restraint does not include the term treatment. So if a psychologist says this is part of my treatment, then it doesn't become part of the data collection. And we've examined that very carefully, and we've given that to the committee as part of our paper on chemical restraint. And what we're asking for is that be properly examined, and the term chemical restraint include any coercive use of treatment that the person doesn't want, and so it's affecting their behaviour. And we're looking carefully at the definition now, and therefore it must be seen as chemical restraint, and therefore what we're asking is that be included in the data collection. So then, at the very least, that means that people are aware of when medication is forced on them, and then of course the whole question about whether medication is a good thing or not arises.
My question, if I could just change track slightly to Mr. Davis and Mr. Hare, your submission particularly on page 22, if we just take page 22 please. Which is dealing with your thoughts and comments around the PACER program. The recommendation speaks for itself, but my question is, with respect to the PACER program as it currently has and operates in New South Wales, noting that there are other jurisdictions, I think Victoria for example, and maybe others, that have, and maybe South Australia as well, I'm just not sure, and a like type of program. Is there any suggestions that you have about refinements of PACER in New South Wales? In other words, what's been operating, how that can be refined further? Or in fact, there are some, dare I say, more than minor tweaks that you think would improve it. Interested to know your thoughts.
Thanks.
Obviously a lot of experience of obviously dealing with the program.
Yes, look, I'm not no expert in what's happening in other jurisdictions, but what I would say is one limitation that we are aware of is the fact that PACER isn't able to respond to incidents that I think are deemed high-risk incidents or incidents that involve the use of a weapon. We think that that's something that should be looked at and reviewed to see whether or not the reasons why that limitation exists, because quite clearly if someone's experiencing a mental health episode, mental health clinicians are trained to respond to those high-risk scenarios, and in fact they do day in, day out in civil mental health facilities around the state. So that's probably one thing that we would say regarding the current model. Naturally, of course, it's only operating in, I think, 13 out of 45 police area commands. That's why we made the recommendation that it should be rolled out statewide. Having said all this, we're aware of Minister Jackson's comments, I think in estimates late last year, that all of this is subject to review, and I guess Legal Aid would love to be consulted in relation to that when the time comes. But I think the primary thing we'd say about the current model is simply just around the funding and around the not being able to engage the PACER model when there is a high risk incident.
You may not have the level of detail about how PACER works from an operational point of view, but if you do, this is the question: that if a phone call is made from, let's take a hypothetical example, someone in a block of flats, that there's someone living next door around them that does have what people commonly understand or assume is a mental health condition of some description, and things get pretty rowdy. This is a hypothetical question. Things are getting thrown around, it's noisy. The person picks up the phone and rings somewhere to indicate there's a disturbance that they're aware of or believe is taking place. Do you know where that goes? Because, I mean, what I've always wondered, and perhaps it's more directed to the police force, that if the 000 is rung, how then does it work through the system to activate the decision, and who makes that decision about whether or not that's a PACER style event, if I could sort of use that phrase, or incident, that would then invoke the whole PACER operation?
Unfortunately, I can't answer.
No, that's okay.
There may be some people appearing this afternoon who will be
that's fine.
better informed than I. Yeah.
That's what I... Yep.
Thanks. Mrs. Connor?
Thank you very much for being here. I wonder, Ms. Mellon, if I could take you back to Cahoots, and thank you for the information about Cahoots and STAR. It's very interesting. Are there any other cities in Oregon other than Eugene which have adopted the Cahoots model?
To my knowledge, there aren't, but there was there was a bill that in Congress for similar programs to be initiated throughout the United States. But as far as I'm concerned, Cahoots, as it stands, is only in
So there's
Eugene.
there's nowhere else we can look at whether it works or not other than one city in Oregon?
in Congress or something in the US, is that in reference?
There's a similar program in Denver, I believe, the STAR program. Is that still running, or did that finish?
Also, to my knowledge, the STAR program is still running.
Okay.
It was launched in 2020.
Is,
so that's a
is there anywhere that you're aware of where this type of program has been rolled across something as big as the state of New South Wales as opposed to 2 individual cities in 2 different states?
No, it appears to be a fairly locally implemented program, because there's the high level of collaboration between the police force and the medic teams, and I know that they did have issues with staffing the medics and whatnot, and that was a barrier to implementing it in a larger area than just Eugene, which forms the basis for our suggestion of peer workers also being involved.
And do you have any comments about the difficulty of rolling out something like this in a non-metropolitan area?
I'll pass over to Brett if that's okay. He has more expertise in the rural and regional space.
Yes, look, my understanding, in fact, there was some federal support for that as well. I thought actually there was something a bit
United
wider.
States federal support?
We had some document, I thought that was, if you like, we could send that to
Look, that'd be interesting, because the examples we've got are 2 examples in 2 cities in 2 different states, and of course we're looking at a statewide response. So,
absolutely.
Yeah, no, thank you. I wonder if I could just ask a couple of questions to legal aid, and I'm very interested in the material at paragraph 4 or section 4 of your submission, and I wonder if you could perhaps, you point to the situation in release from Bloomfield, you point to the situation in Broken Hill where there's no permanent psychiatrist and the closest Justice Health nurse is 700 kilometres away. What is this perhaps an example of the real difficulties we're seeing because psychiatric services are under-resourced in the regions?
I think that's broadly correct. I guess just to start with, to refer to Bloomfield Hospital, we regularly deal with what's called the Macquarie unit, which is a specialist forensic mental health unit at Bloomfield Hospital, and broadly they do a very, very good job at ensuring the reintegration of forensic patients into the community in a considered manner. Our concern is that, and the community mental health teams there also do a great job at managing those patients when they're in the community, but our concerns are around the fact that they're so under-resourced that there have been instances where we've had patients who have said, I've been sort of discouraged from settling in this area upon my release, which is quite unfortunate because the process to being released involves getting a sort of gradual and substantial amount of leave, integrating yourself in the local community, and then you're forced to be uprooted.
If I could just stop you there for a minute. So the extent to which you're aware, and you may not be, what happens to those people who can't stay in the orange area because the mental health support isn't available for them? Where do they go?
Well, I guess they work with their treating teams around what might be another area of New South Wales where they would like to reside, and they'll fall under the community mental health team that manages that particular area. Probably the advantage of remaining in Orange, the other thing is it's a specialist forensic psychiatrists who actually work in the community team there, which isn't the case in every single community mental health service around the country, around the state rather.
Yeah. And if there's a Justice Health nurse in Dubbo, does that affect communities other than Broken Hill? Because there would be a number of local courts in between Dubbo and Broken Hill, I think.
That's correct. I'll have to take that on notice. I don't have an answer to that question before me. Thank you.
Okay, thank you. And could you explain a little bit more about the issue of locum psychiatrists and no permanent psychiatric support in Broken Hill in relation to how that affects prisoners and people on bail getting adequate treatment?
So that was reference to the fact that obviously when a magistrate diverts someone to the local hospital to be assessed, if that psychiatrist perhaps doesn't have a knowledge of that person's history, of course they have the clinical records, but if they don't have a knowledge of that particular individual coming before them, then it may impact on their particular assessment around their mental state and whether or not they are or aren't what's referred to as a mentally ill person within the definition of the Act. Perhaps there's questions over whether or not the person might have a drug-induced psychosis versus an underlying mental illness, underlying diagnosis of a psychotic illness, for example.
Yeah, no, thank you. And I'm very interested in your comments about navigation, which has been a big issue that we've been exploring, and your support for the community transition team. Are you aware of if there are any barriers or reasons why it can't be rolled out more broadly across the Justice Network?
No, not really. Obviously, primarily funding. I guess one barrier may be the fact that Justice Health doesn't have a presence in every prison in New South Wales because the privatised prisons, which, as I understand, are coming back into public hands at various points over the next few years. Obviously, Justice Health doesn't have a presence there, so they're limited in what they can do. But as for why they can't or they don't have a presence in other Justice Health prisons around the state, I assume it's just a funding issue. Having said that, they do support people to return to wherever they wish to reside around the state, but they only support those inmates from Silverwater Women's Correctional Centre and MRRC, the Metropolitan Reception and Remand Centre, and also parts of Long Bay Correctional Complex.
Okay, thank you very much.
Can I just respond to that issue of the community transition teams? There's two points I'd like to make there. One is we're concerned that at the moment there's linking the use of medication to the person who is being released, and we want to make sure that there isn't a requirement that the person submits to medication in order to hold their housing and get the other sorts of support like education services and things like that. So we're concerned about that.
Could you just explain that a bit? Because if there's been a medical assessment that medication is required, why would there be release without the medication?
Well, the person upon release wants to remain out, and if it's required that they have to accept the treatment order and submit to whatever is required by the health department and still retain their housing, we think that's a bad thing. They think the person should be able to...
Sorry, are you suggesting there's incorrect diagnoses being made as part of the treatment order?
No, we're concerned that there's we were involved in a consultation with the Kirby Institute about maybe 3 years ago, where there's a whole question about the optimal treatment of prisoners upon their release. And this became a really significant issue about the requirement that people, a very large number, we were told 2,000 people, psychotic ex-prisoners were being released each year. That seems an amazing figure. But we were concerned that expansion of those mentally ill people was an attempt to reduce the recidivism rate by dulling them down and making sure they receive medication.
So you're arguing that people are being wrongly medicated?
Yes, being medicated and being medicated. And
do you have any evidence of the fact they're being wrongly medicated?
Do I have any evidence of the
fact that they're being wrongly medicated?
We have, we had, as I say, we had this significant consultation about 3 years ago where that was definitely an attempt to reduce recidivism by, in fact...
So you have evidence that New South Wales Health is forcing people to take medication not for their own benefit but to avoid recidivism?
Oh, absolutely. That was the whole basis of the consultation. Okay. Very happy to show you the documents that is the basis for that consultation. It was very significant, only a short time, run by the 3 years ago, run by the Kirby Institute. And the other thing I'd just like to, and we also think that the support given by those community transition teams shouldn't just only be for people who have mental health problems. It should be also for everyone. So there's a real, to accept that you have, you're mad, a spinner in prison, makes you a person of little worth and according to the culture of prisons. So that's a shame if people have to be reduced in order to get that sort of support when they're released. The other thing I'd like to raise, just in response to the question of outlying areas. Now we're really keen that e-health should be available widely and also including inside prisons, but also out in the community. So having access to a psychiatrist by e-health we have found is a very useful thing. And also an issue that we think is really important is to maintain their telecommunication rights. So at the time if they are picked up by the police and by the ambulance, that they should also carry with them their phone and as a matter of right and be able to maintain contact with their families while they're away. So we have championed the Nairobi Declaration for Telecommunication and Human Rights, detainee telecommunication rights, which is just to support that as a right, and we would like the committee to support that idea that there continues to be a human right of communication, even if a person is seen as being mentally ill, that should be retained as one way of maintaining connection with the family and support outside of the hospital support.
Thank you.
That brings us to the end of the time for this session. The Secretariat will be in touch about any questions on notice. Thank you again to all four of you for the time you've taken to be here today and share your expertise. We really appreciate it.
Thank you.
Thank you.
joining us today. I wonder if you could each, starting from my left, for the record, provide your name and your position, and then take either the oath or the affirmation.
Cara Varian, CEO at New South Wales Council of Social Services. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth.
Andrea Angeles, Policy Lead at the New South Wales Council for Social Service. I swear that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth. So help me God.
Thank you. Did you, either of you or both of you, wish to start with an opening statement?
Thank you, Deputy Chair. I'd like to start by acknowledging the traditional custodians and the lands on which we meet today, the Gadigal people, and pay my respects to their elders past and present. The New South Wales Council of Social Services thanks the committee for the opportunity to provide evidence today. And as you've just heard, my name's Cara Varian, I'm the CEO. We're the peak body for non-government organisations in the health and community services sector in New South Wales, and we work with about 400 members to progress social justice and shape positive change towards a New South Wales free from poverty and inequality. Since our submission to this inquiry, NCOS has released 2 additional reports that we think are relevant to your terms of reference. The first report is called Beyond Roads and Bridges, which focuses on social infrastructure in Western Sydney, southwest Sydney, and it highlights the unmet need both today and the expected unmet need in the future. We chose to focus on southwest Sydney because it's a high growth area, as most everyone on the committee knows, but also because there is a high concentration of people who are experiencing socioeconomic disadvantage. We can see that, so the report was commissioned by NCOS and produced by Impact Economics and Policy, and it shows an immense amount of unmet need in the community-based mental health support area. On a per capita basis, the New South Wales Government spends the second lowest of all states and territories on community mental health services. And while the New South Wales Government is currently spending about $155 million per year on community health support in southwest Sydney alone, our research estimates that there's between 31 and 59% of need is unmet at the moment. And we expect that need to grow, and the government will need to almost triple its current investment to be able to meet all of that need by 2041. The second report that we have released is called An Exploration of the Experience of Virtual Care in New South Wales, and our findings were generally positive. We found that it was important for choice to be part of the patient care, but when choice was provided, virtual care can bolster and improve patient outcomes and the overall quality of care. But not everyone has access to virtual care, and our most vulnerable and disadvantaged community members are disproportionately impacted. We need to, as a society and the New South Wales Government, need to prioritise equity of access for those most excluded and invest in the community sector's capability and capacity to improve access and use of virtual care. Finally, I'd like to highlight the submission provided by the Mental Health Coordinating Council. They are an NCOS member and a peak body for the community managed mental health organisations in New South Wales. As outlined in our submission, we support 3 of their recommendations that relate broadly to social service sector needs. Recommendation 5, which is to provide adequate indexation that responds to the inflationary impact of salaries and service delivery. Recommendation 9, which is to invest in wellbeing support for all mental health care workers. And recommendation 19, to provide community managed mental health organisations with 5-year contracts so that they can offer secure employment and improve sustainability. Joining me today is Andrea Angeles, one of our policy experts at NCOS. She insisted with the submission of the inquiry that we put through to the submission that we put through to the inquiry and the development of the virtual research care. I thank the committee again for the opportunity to be here today, and I look forward to answering your questions.
Thank you very much. Thank you so much for taking the time to prepare your submission as well as appearing today. Mrs. Carter did open this session, so you should go first with questions.
Thank you. Thank you both for being here today. I was very interested in your comments in relation to telehealth and issues around access, which aren't often highlighted. I wondered if you could perhaps just explain some of the access issues which some people in our community might face using telehealth.
Thank you. We did the research based on, I guess, the big change that we saw during the COVID period and how communities responded to that. The access to telehealth in regional and remote communities was particularly valued, but there was a concern that access to telehealth options would hide the other needs that regional and remote communities might find, such as being able to have physical appointments with GPs or local specialists. But in conjunction with those physical in-person appointments, it was a really valuable experience for people, particularly in rural and regional Australia, New South Wales, but also carers found it really helpful, and casual workers, so that they had a bit more control over how they spent their time and they could work around their other commitments. There is also significant access issues for those members of our community that are not technology literate, or don't have access to reliable internet or a device. And for those people that are working or living in an area that is particularly crowded, it can be really hard to get good care through a virtual appointment if there's no privacy for them to have those conversations. So that there were some of the issues that we found, but overall there was a lot of support for virtual care.
Yeah, thank you.
Cara, if I could add on to that, sorry. It's just from our findings, we found that virtual care relies heavily on access to high quality digital infrastructure, and it's often people who are socially isolated or digitally excluded that are most at risk of not being able to access virtual care, as well as those on low income households. They simply can't afford digital technology or even access to data. So that's also something that we found in our research as well.
Okay, thank you. And just one more question, if I may. I note your support for recommendation 9 in relation to wellbeing support for mental health care workers, and talks about vicarious trauma education. Do you think that vicarious trauma education is enough, or do those workers actually need, given their daily workplace, do they need support for vicarious trauma counselling?
When we provided support for that recommendation, I think it was more global, I guess, than just the education. We provided the example of vicarious trauma education, rather than that being the only thing that we think is necessary. Certainly over the COVID period and since COVID, we have seen, members are telling us, that demand has grown, and because their funding has not really changed significantly or not enough to meet that demand, they're under a lot more pressure. And so that risk of burnout and the lack of support is really being felt by those frontline workers and the specialist healthcare providers.
Okay, thank you very much. Thank you.
I had a couple of questions just seeking to clarify the recommendation around indexation. So you noted in your submission that the contracts funded by the DCJ and the ministerially approved grants had a 5.75% indexation rate, but that many grants related to relevant organisations haven't had that level of indexation. So I just wanted to clarify which departments we're specifically talking about that haven't yet applied that indexation.
We can see that the government has made a great commitment for that particular area, but there hasn't been indexation across any of the other community services sector. So in terms of departments, we're looking at I think DCJ, which we're going through a commissioning process at the moment. but other departments, I'd have to come back to you.
Yeah, very happy for you to take it on notice. Thank you.
I can also acknowledge that late last year, I believe, New South Wales Health did approve indexation rate of 5.75 for ministerially approved grants, as well as other New South Wales Health funded organisations as well, applicable for 23-24.
Thank you. Ms. Siddle?
Thanks, Chair. Thank you to you both for appearing today. I just had a question, I suppose, at the start, and I apologise that I haven't had the time to look at your most recently provided reports. The answer may be in there. But you stated that there was 31 to 59% of unmet need. That's a really broad figure, and you know, if it's only 31%, then that's one thing, but if it's 59%, then that's quite something else. Could you explain why there's such a big variance there, and you know, whether there is, you know, anything more you could shed light on in terms of that figure?
So the report that you're talking about is our Beyond Roads and Bridges social infrastructure. Yeah. So basically that figure comes from the researchers who have done the economic analysis, and I guess what that really would represent is the fact that we're getting different pieces of information from different providers in southwest Sydney, and the two figures represent the upper band and the upper area and the lower band of unmet needs. So if we're being conservative, and we can kind of definitely say that we're not meeting 31% of need right now, but looking at what we expect to see in the future, it's potentially up to 59%. So I guess no one can see into the future, and so that's the range of unmet need that we're expecting to see over the next, up until 2041, so next 25 years.
Did you have anything to add to? No? Okay. Colin, any questions?
Yes, so thank you very much for coming along, and thank you for your submission. Witnesses to this inquiry, in fact even some today, have commented about the fragmented nature of mental health services, and have posited that that's in and of itself a challenge for people trying to source what is the best service for them to consider. I'm just wondering whether you have any thoughts about that in fact the navigation, I mean, it seems to be hard enough when you've got someone who is working in the area to help navigate a person, a client or a patient, let alone the ones with the unmet need that you've sort of spoken about so well about. And I asked another witness on another occasion about the sourcing of information. Is there a repository of information that can be gone to which can help people source or navigate through what appears to be a labyrinth of information to access the mental health information that they may need? So I'm just wondering if you would agree with the statement that's true, number one, and number two, it acts as somewhat of a challenge for the whole system and really does need to be addressed at a very fundamental level.
I think one of the, I guess the power of NCOS is our ability to join those dots across different parts of the social services sector. So I say that from that kind of overall, say what I'm about to say from that overall perspective. We are often seeing that the different service providers struggle to be able to connect, and certainly we've heard from our members that in the mental health space there can be a disconnect between inpatient and outpatient service delivery. There can be a disconnect between public health provided mental health services versus community health services, and also what's happening in GP in a GP environment versus what's happening in a community health mental health space. So I think what you're suggesting with the disconnect between the different segments of the mental health sphere is certainly what we're also hearing from our members. Exactly how difficult the labyrinth is, or whether there's a repository of information, we don't have visibility of that as from an NCOS perspective.
It was put by witnesses earlier today that, at least in their assessment, either the major factor or certainly a contributing factor is that mental health stands separate from, this was essentially paraphrasing them, separate from the mainstream health system. It's there, but it's separate, and doesn't operate along the same lines. It has a greater inherent complexity about it, and that also is a contributory factor to the. But it just seems to me that, and I don't have the answer, just how one gets on top of. I mean, for example, how does the New South Wales government, if you just take this example, and if it was agreed that this would be a worthwhile task in and of itself, or a project in and of itself, how does it create some repository of information, which is, of course, the other challenge, being kept updated on an ongoing and continuous basis, because obviously services come, services go, people come, people go, or is that just literally a fantastic hope? It could never be done. The best you can hope to do is try and keep things up to date as best you can in the local level, and it will sort of trickle down and people get to hear about it.
I think there's probably two parts of the question that I'd want to address, and one of them is about that co-location, so that the access. So if you've got physical health services and mental health services co-located, it obviously makes it vastly easier for people to access physically. And I think that's very important for our rural and remote community members, but also for people that are socioeconomically disadvantaged, being able to navigate the public transport system, and also, of course, members with disability, so community members with disability. So that physical co-location, I think, is very beneficial from a patient care perspective. And again, our members have told us that that co-location also helps to build trust with the people that are receiving mental health care, because they're going back to the same places and seeing similar people. The issue of managing data and being able to provide a repository that everyone can access at the same time.
Or information. I mean, I guess in simple terms, we're talking about a sort of a very comprehensive, thorough but updated directory of what might be available.
I can't think of a more helpful thing to include on our to-do list, but exactly how to achieve that, I'm not sure. But obviously, the going back to first principles, information is power,
of course,
and being able to provide our clinical service providers with information to service their patients would be a fantastic start.
Thank you very much.
One last question from me. You've also noted the MHCC recommendation around 5-year contracts, and we've heard that from a number of different witnesses to this inquiry, but I suppose with your broader perspective across the whole social services sector and not just direct mental health service provision, I suppose what's the impact of the funding cycles that are shorter than 5 years?
I think we've all been a recruiter at one time in our lives, and just the recruitment process alone takes a long time. And if we're not providing our service providers with certainty, then they can't provide their staff with certainty. And when they're not well paid and they don't have certainty, that means that it's not an incredibly attractive workplace, and those staff will then move on. And we do hear regularly that people are having trouble recruiting staff and keeping staff, and then the staff that are there have burnout. And I think the other part of it is that operational and corporate strength and resilience is often not invested in if there's not a long-term game to be able to play. So if you're constantly going through a process of applying for and waiting to hear whether you're going to get a grant, instead of being able to plan for staff development or investing in the infrastructure of technology, or even leases, being able to take on a longer lease and therefore being able to get a cheaper rate. All of those things mean that we're taking time and effort and thought away from service delivery and clinical practice.
Thank you. I don't have any further questions. Further questions from the committee?
Thank you very much. That was helpful.
Thank you so much again for sharing your time and expertise with us today.
Thank you so much.
Thank you. The Secretariat will be in touch if there's questions on notice. And for the information of... we have one more before afternoon tea. Excuse me. Our next witness is representing the Australian Association of Social Workers. Hello, can you hear me online? I'm just testing the sound.
Yes, I can hear you.
Great.
Can you hear me?
We can hear you. Can you hear us?
I can hear you.
Wonderful. Thank you so much, both of you, for giving the time and your experience to our inquiry today. My name is Amanda Conn. I'm the chair of the committee. Could you please both start by stating your name and position title for the record and taking either the oath or the affirmation?
Shall I go first? I'm Angela Scarf. I'm the Senior Policy Advisor for the Australian Association of Social Workers, and I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth.
And my name is Kate O'Brien. I'm an accredited mental health social worker, and I solemnly, sincerely and truthfully declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth.
Thank you very much. Would you like to start by making a short opening statement?
Good afternoon. Thank you, I would. The Australian Association of Social Workers is the professional body representing social workers throughout Australia. We set the standards for the education, practice and ethics of the social work profession. Social work is a tertiary qualified profession recognised internationally that pursues human health and well-being, social justice and human rights. To be qualified as a social worker, students must have completed either a 4-year Bachelor of Social Work or a 2-year Masters of Social Work qualifying degree. Social workers aim to enhance the quality of life of every member of society and empower them to reach their full potential. Social workers look at the whole person within their environment, considering all the biological, psychological, social and cultural factors. This means that we include their strengths and their resources, as well as their needs, and people's past experience of the system and that of their families and carers are included in a social worker's considerations. Social workers build a respectful and collaborative partnership with people through which they can together work out a response tailored to that person's situation. And by including all aspects of a person's circumstances, social workers are always striving for a response that's appropriate to people's culture, language, lifestyle, ability level, and gender identity. In terms of people with complex and intractable mental health needs, I just want to mention an important subgroup of members. These are accredited mental health social workers. They are members who satisfy a range of requirements in terms of their experience in clinical mental health, continuous professional development, professional supervision, and demonstrated competence. They're required to maintain their skills through continuous professional development and professional supervision, and we're really pleased to have Ms. O'Brien joining us today with that qualification. These members are recognised by Medicare as able to provide focused psychological strategies under better access, and they also are able to take on specialist clinical roles in health and mental health settings. For the purposes of this inquiry, our message is twofold. Firstly, we believe that community mental health services are terribly under-resourced, and this is preventing them from fulfilling their really important role in New South Wales. And secondly, we believe that social workers, and in particularly accredited mental health social workers, are an underused element of the mental health workforce. Because social workers can wrap a tailored and multifaceted response around people, social workers are critically important in helping people maintain their safety and the safety of their community and their family members, and really hold someone in a community setting while also attending to their clinical and therapeutic needs. And so we really believe that social workers could be playing a really important role in the community mental health system. Remembering what I've said about our holistic and affirming approach, this also makes social worker profession adaptable, like I said, to people of all ages, abilities and identities. So we commend our members to this inquiry. We're really pleased to be invited and to be able to talk to you, and we look forward to being part of the solution in improving mental health services in New South Wales.
Thank you very much. I've got a few questions, and then we'll move to questions for other members of the committee. First of all, to say thank you very much for taking the time to share your expertise with us today. We really appreciate it. My first question is just to explore in a bit more detail. You've said in your opening statement that you believe the social workforce in New South Wales is underutilised. I'd be interested to explore in a bit more detail what are the specific settings where more social workers should be deployed and they're currently not, or what would that actually mean in terms of recruitment?
Sure. Well, remembering that I said that if you're an accredited mental health social worker, you're able to provide exactly the same services as a clinical psychologist under better access. Now, lots of mental health services in New South Wales, when they are advertising a clinical and therapeutic role, they specify a clinical psychologist, whereas that is a role that could also be done by an accredited mental health social worker. Now, when social workers are employed in that service, it's because a social worker has successfully applied for and secured a position that was actually advertised as a generalist mental health worker or a generalist community worker, so that they might be working alongside people of other professions. And in that role, many of our members are not fully using all their social work skills because it's actually a generalist, kind of like an outreach role or a generalist support role. I'm wondering, Kate, if you want to give an example of actually having seen that in action and the difference that could have been made on either side of that distinction?
Yes, and just to add to your point, Angela, I suppose there's also opportunity for collaboration with accredited mental health social workers who are working in other practice settings, like, for example, within private practice settings, who, at the moment the system feels a little bit clunky, and I think often due to under-resourcing, there's not a lot of communication that happens between services. I've had examples of that where I've left messages, for workers, and they just haven't ever been returned. And I assume that that's actually, from my experience, been because of the fact that they have so many clients and not enough hours in the day ultimately to kind of get to everything that might be on their work schedule. So, I think that there's a lot of examples I can think of, and I'm very conscious to de-identify information that I'm providing today. But even just as an example, seeing someone as a whole person and seeing them within the context that they exist, is extremely important. And I think that's something unique to the social worker lens and approach to mental health, not simply pathologizing or seeing someone within a diagnosis, but also seeing them in the context. For example, working with someone who might be, waiting for a protection visa. They're not eligible for other services, and we can understand that actually that context around them is also going to be very stressful and significantly increase their mental health symptoms across that period of time. So I think in terms of understanding actually what's happening for a person, their cultural, their lived experiences, their gender, their ability, their socioeconomic status, all of these things are extremely important and inform and shape those social determinants of health.
And so in terms of how they could actually be better used in the system, what's happening is that because people like the people that Kate was just describing aren't getting help early on in their mental health, what happens is that they end up further down the system, either being picked up in the acute hospital setting in an emergency, or as we've heard earlier this afternoon, in inappropriate responses led by the police and things like that, which are terribly stressful for people, and then which actually make their condition worse because of what we've heard about the traumatising nature of that sort of forceful nature. So it's partly to do with the profession being able to work at the top of their scope, but it's also partly to do with the preventive and early intervention sections of the system being able to work to their capacity. And we believe that having social workers earlier on in the system would make the early bits of the system more effective.
Thank you. And just to follow that up, and I appreciate this one may need to be taken on notice, but have you got a sense of the numbers of social workers in New South Wales if there was a push to suddenly employ more?
Yes. So we looked at the Jobs and Skills Australia website, and I counted up because I had to do it by region. So I had a great geography lesson in New South Wales. Now, remembering that not all social workers have to join the AASW because we're a professional association. So Jobs and Skills Australia estimates that there are about 11,000 qualified social workers in New South Wales, and we have just under 4,000 members in New South Wales, and of them, 761 are accredited mental health social workers.
Okay, and of your members who are accredited mental health social workers who live in New South Wales, how many of them are employed directly in a mental health role?
Well, they're all employed in I shouldn't say all. A majority of them are employed doing mental health somewhere in the system. Some are in private practice and some are in the public system, and I haven't at my fingertips got that breakdown.
That's all right. I prefaced that with it being a difficult question to do off the top of your head, but I'm really interested because we know that for many other types of mental health professionals, there is a genuine shortage in New South Wales, that if we suddenly created extra psychiatrist positions overnight, for example, that they wouldn't be filled. So I'm really interested to understand what the numbers of people that we actually have to fill those roles if they were to be created.
And in our submission, we talked about the fact that we have surveyed our accredited mental health social workers to work out whether they have capacity. And we are finding out that our accredited mental health social workers who are in private practice do have some capacity, I can't speak for the accredited mental health social workers who are employed in the public or the community sector.
Okay, thank you. And my last question was just arising out of your written submission. You've mentioned that social workers are ideal to lead social prescribing programs, and I was just hoping you could expand on what you mean by social prescribing.
We're talking about several initiatives that are happening in Australia and overseas that are looking at, in the public sector, looking at a broader range of solutions to people who present with a mental health problem or need. And social prescribing refers to a whole lot of initiatives which connect people back into community level activities and facilities and programs that might not necessarily have been designed as mental health interventions. We can send you more information of actual examples and case studies if that would be helpful. But also, Kate, do you want to talk about some examples of programs like that you have seen?
Yeah, look, I suppose I probably can't speak to programs specifically as well as you can, Angela, but, I guess what I would like to just more sort of point out in relation to that is that I suppose traditionally a lot of mental health services have been within a medical model and in a hierarchical kind of setting, and a lot of the benefit of that is, of course, that it's got an interdisciplinary and a multidisciplinary approach to things. I suppose there's been a big focus on assessing, diagnosing, providing medications, and, making sure that people are sort of linked into their bare essentials, things like housing, Centrelink if needed, all of those sorts of things. And they're very important, but I think that they're really just a bare bones of foundation of what a human being actually needs, and in terms of thinking about recovery and what that actually might look like for people. So again, we're thinking about someone as a whole person and their sort of social world and what's around them. As an example, support groups of all different kinds, even educational groups. There's, a whole bunch of different things that's kind of going on. But, even thinking about social sports or things like that, I guess there's lots of different ways that we can kind of support individuals, and be looking after their mental health.
Thank you. Mrs. Connor?
Thank you very much for being available. And I understand that you may not have the answer to this, but since you indicated that you'd learned a lot about the geography of New South Wales, I wonder whether you had any sense of the spread of the mental health social workers throughout New South Wales, and to what extent there may be availability in the regions.
You won't be surprised that what I came across is a real concentration around Sydney and the big regional areas, and that there are areas that on the map look very large with very low numbers of social workers. And I know that the committee has been interested in telehealth and initiatives like that as well. And I was really interested to be listening to what NCOS was saying about that take telehealth with a grain of salt. It's not the panacea for everything. And that is also the experience of our members. We are a profession that actually has a heavier weighting towards regional and rural centres than some of the other medical professions, but we still find that the shortages in those locations, and we also, our members tell us that people in those locations would prefer face-to-face contact, and that in some uses, for example, counselling, doing it over Zoom feels second best. So yes, we know that the way to get services to vulnerable people in rural and remote communities is really serious, and it's a complicated problem.
And just a practical question, looking at the provision of outpatient mental health services, so not delivered through a hospital setting, and it appears, and I apologise if I don't understand properly, it appears that there are social workers in private practice. To what extent are Medicare refunds available, health fund rebates, any fee support available for accessing mental health social workers?
So there are, through Medicare and Better Access, what we hear from our members, and I think Kate can describe this better than I, is that that's a different set of needs from the people who need community-based and outpatient services.
So I think that there is some crossover. Unfortunately, as you would be aware, the federal government reduced after COVID the Medicare rebates to being appropriate only for 10 sessions per calendar year per person. Whereas during the COVID years, we had up to 20, and that means that the scope of practice within private practice is significantly being impacted there. In private practice, social workers also provide under some private health insurance, some like Victim Services, New South Wales, Work Cover. There's a number of different programs. However, the specialty of what community mental health provides is actually more acute presentation. So when people are acutely psychotic or suicidal, for example. So what that, I guess, entails is that workers are sometimes able to make home visits. They're able to provide a combination of a psychiatrist and a therapeutic and a casework kind of response to people, which is that sort of wraparound response. So people in the private practice sector could absolutely have capacity to be doing a bit more collaborative work in that sort of a sense. However, the need for the specifics of community mental health is unique in a sense in itself as well.
Okay. And my last question, we've explored the issue of navigation because it is a series of complex and interlocking and overlapping systems which, if you are robustly well, can be challenging to navigate, but if you are not, could be completely overwhelming. To what extent would social workers or mental health social workers be the right person to help people navigate their way through the system?
Yeah, so I will just jump in there, Angela. I hope that's okay. I would just sort of say that, look, I think a lot of people actually find themselves in community mental health by being referred by social workers who might have met them through another meeting point. Like, for example, people suffering from significant postnatal depression might be picked up through screening and then referred in. And also through emergency department, it is social workers who often provide that immediate response to people who are acute in the emergency department alongside, say, the mental health nurses and psychiatrists. So as an example, though, someone might be presenting because of domestic violence. A social worker comes in and makes a response, and they also might be noticing, though, that they're acutely suicidal and needing some specific wraparound intervention around all of that. So I think already social workers are kind of on the ground often with people and facilitating people into appropriate services and making those assessments. And similarly with, in private practice, I can speak for myself in that setting at the moment, having had experience in NGOs and government and community health in the past, clients, can sometimes, have flare-ups of different things going on. So psychosis as an example, and that, you might be working ongoingly, say, through the Better Access scheme, and someone actually is at a more pointy end and needing more support. So I guess what's useful about that as well is that we are trying to then, I guess, find ways to keep people out of hospital, because that's significantly expensive and often not in people's best interest unless absolutely necessary. And there may be circumstances where that, of course, is the case. But community mental health is kind of filling this bridge, I suppose, between an inpatient setting and just fully out in the community without more sort of specific kinds of supports in that way. So I think social workers are already there, and I think that, I guess it's more thinking about what role they can play in community mental health more specifically. Yeah.
Because I was listening this morning, and Mr. Campo was talking about navigation needs to be done by somebody who's informed about the system and somebody that the person trusts. And I think what Kate has illustrated beautifully is that rather than having a separate role called navigator, the people that Kate is talking about already are in a trusting relationship with a social worker who does know their way through the system and can help them do a warm referral to an aspect of the system that will look after them. It's what we were talking before about working out the individual tailored response for that person, taking into account all aspects of them, including, for example, a previous history of sexual assault and their particular cultural background. I always worry when I hear the term navigation because I think it's an unhelpful metaphor. Because I think if you think about the times when you need to navigate somewhere, it's because you know where you're going and you know that you have to get there avoiding certain wrong turns or traps or pitfalls. Whereas I think that's thinking about what a social worker does from the wrong end. And I think what Kate has shown really clearly is that we start from where the person is and build something around them rather than assume that there's one perfect slot for this person that they have to be put into and that you have to, and that navigation suggests that someone knows the end point for that person. Whereas I think, yes, go on, Kate.
I was also just going to jump in and say, I guess my other concern would be that what you're really talking about is a psychosocial assessment, which is the core business of social workers, Angela, exactly. And I think that a navigator is fine, but I guess there needs to be enough appropriate services there for when the person finds their way into a service. And actually, if there is not enough people to do that work, which there currently isn't, it's kind of not very helpful in and of itself. I agree that there are things that can be confusing about navigating the system. And I think if you're an individual thinking you might need that service, absolutely. The ways that people, in my experience, tend to come into community mental health is by referral through inpatient settings, emergency departments, and private practice or other services where social workers are already working, as I said. If you're an individual that are not currently involved with those services, I guess a lot of the time it could be through GPs, and that would be another route that tends to come in. So possibly it's also about educating people. I guess there's also a question of the scope of community mental health. If it's too narrow, if it's too broad, what does that actually need to look like? And I suppose because it's often has, in my experience, been focused on the most acute presentations, that also means that there is almost eligibility kinds of criteria that people need to meet to actually access that service as well. So I guess that might be another thing that the committee is exploring and thinking about.
So we're looking for scaffolders rather than navigators.
I like it.
Thank you.
Isabel.
Thanks, Chair. Thank you to you both for giving up time to be at this important inquiry. Could I ask you about social models in mental health care and whether they are adequately recognised and promoted currently?
That's a very good question. I'm a national person, and I deal with health, mental health, the NDIS, the aged care system, and I think that's an issue across all these systems. Like the words that Kate was just using was what we say the biopsychosocial. So we look at all aspects, and I personally would like to see a holistic way of looking at people, and that's sort of what we're getting at with the social prescribing. In terms of this inquiry, though, I think, Kate, you can probably be more specific and
yes. I think to answer your question very succinctly, though, no, I don't think that they are. I guess is the short answer. But I suppose in that sense, I know that on the ground there are a number of community mental health services that have done partnerships. I've also worked in sexual assault counselling roles where, education around that is appropriate for lots of people in terms of thinking about a trauma-informed way of operating and thinking about social models of care altogether. But unfortunately, I guess that's quite patchy and quite dependent on the actual specific local health district or the specific service. I would also just say that I think that, as I've said before, that community mental health is often within a medical model, which means that I guess that focus is not necessarily on those things. And I think that is something of value and something that social workers do bring.
Thank you. I might ask also whether the current federal schemes that are available, so the Medicare benefit schemes I'm sort of talking about, whether they support the delivery of therapeutic services by social workers, and whether they enable sort of public faith in a multidisciplinary team.
You can answer first, Angela, if you like. Yeah.
Well, it is interesting, isn't it? Because yes, they do fund some therapeutic services,
Limited,
but the multidisciplinary teams is still quite difficult, and that's to do with the specific regulations in Medicare. So, for example, even though a GP can refer someone out, can make a mental health plan with somebody they're seeing, and can refer them to have some work with an accredited mental health social worker, it's only, at the moment, it's only the GP or the psychiatrist who can actually convene a case conference around that person. So it might be that the social worker is one of several people that person is seeing, including a generalist social worker, a drug and alcohol counsellor, and a housing worker or a specialist health worker for a refugee. Now, any one of those people might think that it would be really helpful to have all of them having a discussion so that they're all on the same page. But the regulations for Medicare only let the GP or the psychiatrist convene that meeting. So that's something obviously beyond your scope, but it is something that the AASW is working on.
Yes.
In different forums. Yeah.
And just to add as well briefly that, of course, for referral to occur to an accredited mental health social worker, say in private practice, for those only 10, rebates, that actually needs to be referred by a GP or a psychiatrist in the first place. So I guess there is a level of collaboration, but it's often fairly fleeting and more of a referral pathway than actual collaborative care.
Yeah.
Compared to community mental health, which is actually a setting housing all
Yeah.
of these people together to work with the same clients.
Yeah. And can I just build on that? Because getting back to the question of rural and remote locations, if you have a community where there is only one GP or there's no GP, that's a real barrier to those people getting services under better access. So they are reliant on the community mental health system. And a lot of our members are dealing with, for example, in a country town where there's only one GP and there is violence in a family or a young person who wants to be sexually active, those people feel that they can't go to their GP because they know that the GP sees the other family members. So those people are really at the moment blocked from getting appropriate health care and mental health care. So again, the community sector is really important in providing healthcare for people with those specific needs.
Thank you.
Thank you. Just a quick one, yeah. Thanks. Thank you, Chair. Thank you very much for your submission and making yourself available today. Can I just go to page 3 of the submission, if you've got it in front of you? If not, I can read out what I wanted to refer to, and that's specifically the recommendations on page 3, about halfway down. So the recommendations are couched, if I could put it this way, to bring AMHSW, these are my terms, more into the fold of mental health engagement with the community. So the implication is, I think, that at the moment, as an organisation and the members of your organisation who are specialist, who are mental health social workers, that they are sitting a little bit apart from or next to mental health. And I'm just wondering why, I'm struggling to understand why there just hasn't been that almost, if you take, for example, Ms O'Brien's experience and work that she's doing, I would have thought that effectively you would be almost automatically just absorbed into the mental health workforce. So I'm just trying to work out why that hasn't happened almost in an organic fashion. And that's my first question. My second question is, has there been resistance to, if I could put it that way, and be as frank as you like, but has there been resistance to embracing mental health social workers as to, in effect, be included in the count, if I could use that sort of phrase, for the purposes of understanding what is the totality of our mental health workforce, particularly at that more elite level where there's obviously significant training that's been done?
Yeah, I think that part of the reason is that they haven't been advertised specifically for the role, and accredited mental health social workers, there's kind of no incentive, I suppose. There's no room for growth for a social worker in community mental health if they've only started in a fairly generalist kind of role to continue to grow their skills and experience within a service like that. And so I think to Angela's point earlier about, the advertisement and the incentive there, that would be important. And also just generally, I think that, I don't know that there's been active resistance, but I think that within a medical model, and the hierarchy that exists within there, that is slowly changing over time. But I do think that may also be a factor as well.
Because I just wonder, in terms of, this is just a suggestion, and maybe it's been tried without success, that is there no scope for, because obviously in terms of meeting your recommendations, I can see that there's some things the government can do or the state can do to help supporting it behind your recommendations. But I'm just wondering, is there more that you're capable of doing to, I guess, facilitate yourselves, or being done concurrently with the government, if the government sort of adopted this idea, to sort of proceed with this better integration, so you've got that standing within mental health treatment?
One complication of this is that the sector generally looks to the professions which are registered with AHPRA as the medical professions.
Yeah.
Now, as it happens, social workers are not registered with AHPRA.
Right.
We are the constituting body of the profession. Now, that's something that we're working very hard to change. But, for example, a shorthand for who are we going to employ will often be, well, we'll get the health regulated professions to work in our service. So that's that's one element of why, for example, what I was talking about a clinical psychologist being named.
Yeah.
When in fact an accredited mental health social worker could do the same work.
That was an interesting point. I have to say, I'm glad you in fact raised it. I didn't quite appreciate that. It's a very significant point you've raised. Just finally,
Last one.
Has there been any resistance by government, either at a state, territory or a Commonwealth level, to, I guess, sort of use the phrase, get on board with what you're trying to do as an organisational initiative to get that, dare I say, greater integration?
The sector is so varied and there are so many aspects of it. And, for example, Kate was talking also about the compensable schemes. A lot of our work as the ASW is to raise awareness of what social workers can do and how they could be used. I'm reluctant to generalise across the board about acceptance of social workers or otherwise. There are areas where people say, oh, that's fantastic, come and work here. And there are other areas of the sector that need a bit more, information and things like that.
Thank you very much, and thank you, Chair, for that.
Thank you. Thanks so much again. We're out of time for this session. We really appreciate your time and expertise and all of the work that you're doing every day. Thanks very much. And the Secretariat will be in touch if there's any questions on notice.
Thank you.
Thank you.
Thank you.
Thanks very much.
We'll now be very briefly breaking for afternoon tea. We'll be back at 3:30. Hello, welcome. Thanks very much for coming today. So could each person, starting from my left, please state your name and position title, and then take either the oath or the affirmation.
Thanks. Louise Ingall, the Manager of Strategy, Research and Engagement at Healthwise. I swear that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth, so help me God.
Hello, I'm Anne Galloway, Mental Health Manager, Healthwise, and I swear that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth, so help me God.
My name's Glenn Cotter. I'm based in Bega. I am a lived experience peer worker in suicide prevention, and I'm part of the executive and steering for the Bega Valley Eurobadella Suicide Prevention Collaborative. And I swear that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth. So help me God.
Thanks. Hello, I'm Rebecca Grasso, the Chair of the Western Sydney Health Alliance. I swear that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth, so help me God.
Thank you. Thanks so much. Also acknowledging that you're on a panel together because you represent a diversity of regions, that you've all travelled a reasonable distance to be here today, which we really appreciate. Would you like to start with an opening statement?
I would. Thank you. Good afternoon, Chair and Committee. Thank you for the opportunity to further contribute to this inquiry. Firstly, I'd like to acknowledge the traditional custodians of the lands and waterways we're meeting on today, the Gadigal people. I pay my respects to elders past, present and emerging. I am based in Tamworth, one of the rural and regional locations from which Healthwise provides services in Aboriginal health, allied health, mental health, primary healthcare nursing, and supports recovery from and preparedness for natural disasters. Healthwise supports care at every stage of life. This support addresses physical and mental health, including perinatal services. We are specialists in delivering outreach services. Across 2022-23, our team delivered over 15,000 mental health consultations. We focus on priority cohorts including First Nations people, newly arrived people, especially Yazidi people in the community of Armidale, and since 2019 we have partnered to deliver primary mental health access, so referral intake and allocation to mental health services in our region. In addition to these programs, we deliver community-based suicide prevention services on behalf of the New South Wales Government. Our written submission to this inquiry contain the reflections of our clinicians and lived experience workers. Healthwise operate as an interdisciplinary team that's composed of mental health social workers, mental health nurses, psychologists, mental health occupational therapists, and mental health lived experience workers. We refer to them as mental health clinicians as a group. We have been delivering this type of service for over 15 years, and we see this approach as an avenue to improve delivery of mental health services in rural and regional areas. We are on the ground and we have co-designed a model that is fit for our communities and it may be transferable. Our teams understand that interrelationships between mental health and other streams, including allied health and holistic care, and most importantly, the value of social connectedness. If an outcome of this inquiry was the capacity for mental health providers to deliver care which was inclusive of social prescribing and addressing the social determinants of health within their contracts, we believe that this would positively impact recovery in our communities. Dr. Cohen, when your invitation was put out to the community to participate in this inquiry, you referenced identifying the most effective way to apply the skills of a variety of healthcare workers in New South Wales. The current mental health funding environment favours large national providers and digital health solutions rather than place-based, experienced interdisciplinary teams like ours. Accessibility and delivery of mental health services in rural and regional Australia is impacted by funding cycles. In 2020, the Productivity Commission recommended funding cycles for community mental health services should be for a minimum of 5 years, with providers aware of funding decisions at least 6 months ahead of the end of this cycle. this is far from the current reality in 2024. The current reality impacts the experience of patients and carers accessing mental health services in New South Wales.
Thank you.
No, I don't have any. No, that was it. Sorry, your turn.
Oh, thank you. Firstly, I would like to thank very much for the opportunity to be here. Coming from regional areas, it's not often we actually get to be at these things, so I really am honoured to be here. I'm here on behalf of the Bega Valley Eurobodalla Suicide Prevention Collaborative. I sit on the Executive Steering Committee and was part of the original consultation group to put it together. The collaborative is a coming together of over 30 local organisations, community members and people with lived experience of suicide, which was formed in 2022 to take on a whole of community approach to preventing suicide in our region. As I said previously, I'm based in Bega. I'm a lived experience peer worker. I guess my qualification is that I have a lived experience of suicidality, or a living experience of suicidality, and I work as a peer worker offering face-to-face support for people straight out of a suicide attempt. I'm one of only 2 lived experience peer workers working with NGO organisation across the entire region. I'm the only one in the Bega Valley region and one in Eurobodalla. What we'd like to highlight for the committee today are the need to continue to shift our thinking about suicidality as only a mental health issue. It is not. And to look at some of the specific challenges for support in regional and rural areas for people and for the workforce. That's why the collaborative was put together, so that we could get together and work through these challenges. Suicidal behaviour is not only a mental health issue. A person's social and life circumstances are just as relevant to risk of suicide as mental health issues. Things like financial distress, loneliness, homelessness, discrimination and relationship breakdown are all factors that are part of a picture, which at times is just too overwhelming. These impacts where people might reach out for help, who they might connect with, are about thoughts of suicide and the supports they need, early intervention and greater community support at times of increased life challenges may reduce the numbers of people presenting in crisis situations, benefiting both individuals and the service system. Strong connection between mental health services, primary care, social and peer supports are another key part to the question. To achieve this reduction in stigma, we need quality training in suicide prevention and a strong role for peer workers across health and non-health services. This is essential. New South Wales Government, as a large employer in regional areas, has a key role to play. As an example, we strongly support the leadership shown through the adoption of the Safe Site Framework by New South Wales Health, and would like to see this continue to grow as a common framework across services beyond mental health and regardless of who funds it. Some of the challenges in rural and regional areas. Distance in rural and regional areas has a significant impact. Travel can be difficult for people in accessing services and their carers, and also impacts what it means to provide services and outreach. For part-time workers, which many of us are, the distance is involved in part on time spent with clients. We can't see the same number of people in a day. Contracts and KPIs need to take this into account. Our ability to attend training and development is constrained, and we often work as part of a distributed care team, including our own supervision. Telehealth options can help, but it cannot always be relied upon, and therefore cannot be the full answer. Internet outages, black spots and lack of access for some parts of the population are very real. Funding and delivery models that take account of rural and regional locations and allow time for meaningful lived experience engagement are needed to help address some of the challenges people face in trying to access appropriate supports and sustain our workforce. Unfortunately, because of a lack of other options, we also see high numbers of people showing up at emergency, which is not the right place for people experiencing suicidal distress. Alternatives such as safe havens, are welcome in drop-in space, and suicidal outreach teams are welcome but need to be expanded. The Suicide Prevention Collaborative formed in our region to help address these issues and support each other through the strengthening relationships and community commitment, working rather than in silos. The collaborative can be a vehicle for providing a community perspective that supports planning, integration, lived experience engagement, co-design and implementation of supports. Some of the key issues we'd like to discuss today is equity and access. Access to services in this region can be challenging due to factors such as distance, lack of transport options in some parts of the region, and cost. The collaborative strongly supports the Safe Haven initiative, but current level of funding provides access to these alternatives in Bega and surrounds, but cannot support the Eurobodalla, parts of which are up to 150 kilometres away. For example, lack of transport options such as public transport or taxis to get home is an unresolved issue that may prevent access to services such as the Bega Safe Haven. Navigation of services, and we've already heard a lot of that this morning today. Community feedback confirms that people find navigating the mental health service difficult with unclear eligibility requirements, wait lists and restrictions on referral pathways, making it hard to get services. Capacity and integration of services. There have been some positive developments in the region where services across different sectors have adopted a common framework and language using the SafeSide prevention model. SafeSide is still very much a medically based system. As a peer worker working face to face, to me it has its limitations. Work is currently underway with funding from the New South Wales PHN in the South East region to develop and implement a customised SafeSide program for local alcohol and other drug-related services. In primary care, the adoption of the intake assessment and the referral systems by general practices and community mental health should assist in a lot of better way of providing connected services for people. Digital integration and referrals with the public mental health system could further streamline this process, but are not always reliable. Issues in workforce in our area, some of the challenges identified by the peer work. Workforce or isolation, especially for the sole number of peer workers working on their own. As I said, outside of the PHN, in my region, I'm one of only 2 peer workers, and I work in a hub by myself. Extra time spent travelling and a significant number of roles being part-time, making connection and professional development difficult, as well as trying to spend more time face-to-face. Workforce allocation in regional areas also needs to be sufficient to cover the significant amount of travel and staff needed to undertake and support the clients into access training. A further challenge experienced in the region has been the recruiting staff and trying to get staff to come down. The cost and availability of housing to either buy or rent since the Black Summer bushfires and COVID is a factor. Over the Black Summer fire period, between the Bega Valley and the Eurobodalla, we lost 1,100 homes. So any rental availability that was there was gone immediately. It's just not there. We can't get people into the area. Digital and telehealth options can add to the picture, and evidence supports its safety and efficiency, including in suicide prevention. However, these services are not preferred by some parts of the community, and internet access can be an issue due to where people are located. I thank the committee for the chance to be heard today and look forward to some questions. Thank you.
Oh, thanks. So representing the Western Sydney Health Alliance, which is a combination of 8 local government areas, so 8 Western Parkland councils, the 2 primary health networks within the area, the 2 local health districts, and also Sector Connect, which is a peak community organisation. So the Health Alliance is a partnership across 3 levels of government, and we work collaboratively to create healthy communities across the Western Parkland city. We don't seek to duplicate or to compete. We seek to capitalise on the assets that we have across each of our agencies to fill gaps and capitalise on opportunities and be responsive where we know that there is need. We participate in research, we conduct programs, we provide education, particularly through councils, and we seek to influence planning decisions. So access to health and wellbeing services for individuals is one of our key outcomes, and we're committed to, regardless of a person's background, location or socioeconomic status, being able to have a positive impact. So it's no secret that the Western Parkland region is one of the fastest growing regions in the state, and achieving equity of access to mental health services is complex and is an ongoing challenge for our residents. So what we are advocating for the committee to consider and address are the existing deficits in funding and access to mental health services and future-proofing for our region, fair and equitable mental health service funding allocations and provisions, evidence-based resource allocations, and locally based mental health service and facilities that are adaptable to a growing population. Access to mental health services and health equity in New South Wales is not improving, and cross-sector collaboration to address this issue is critical to make a measurable impact. The per capita spend on mental health services in the Western Parkland City has been historically less than other areas, and there are significant variations in servicing ratios across health services in the region, indicating disparity in mental health and allied health services. With the unprecedented population growth occurring, it requires a beyond business as usual approach. And to improve the limited service availability, the distances that people travel and the healthcare workforce shortages, we're seeking to engage positively in that dialogue. Thank you.
Thank you. Thank you very much. I've got a few questions and we'll go to questions from other committee members as well. My first one is to all of you. You're all working very hard in areas where I know it can be difficult to recruit health professionals and mental health clinicians. Some of you have already spoken to some of the specific barriers to recruitment or retention in your opening statements, but I'm interested in what positive recommendations you might make in that space. What could the New South Wales government do to support you in your areas to recruit staff?
Hello, I'm happy to speak to that. Anne Galloway, mental health clinician, Healthwise. I think that one of our experiences that we would feel comfortable in sharing more information about is around a skill set based mental health team. We recognise and appreciate the requirements for APRA or AISW registration or membership, but it's also very much around not identifying specific positions, but identifying the skill sets required to match the needs of the particular program that people are working under. And I think that that's part of a workforce model within rural and regional and remote areas that in mental health, allows for the development of, a rural mental health clinician that provides multiple skills within the mental health services.
Okay, from my point as a on-the-ground peer worker, my team would normally be 2 peer workers and a clinician based in the Bega Valley. We had a peer worker and a clinician move on in September last year, and we have not been able to recruit anybody since then. So I'm working as a one out. For me, a lot of what we need to do outside of community mental health and outside of health, but in the private sector, is we need to be able to offer some security in employment. We heard a little while ago about the tenders and contracts. Our program, Next Steps, is up for renewal, we believe, at the end of June this year. We still have heard nothing about whether we have a job come July. We haven't heard if the tenders have gone out. We haven't heard anything. Yes, at government level, those tenders were supposed to be moved to 5 years. They certainly have not. I'm funded 2 days a week. We can't employ people if we can't offer them a livable role. We can't offer them 3 days a week, and maybe your contract is up in July. We don't know. So how the hell do we get staff? We can't bring them into a regional area. There's nowhere to live. We can't offer attractive employment. So out of that, we need to be tendered better. We need to be funded better in those tenders. I don't want to go back to that all the time, but it's bottom line. You know, we can't get people if we can't offer them job security. And we can't bring them into an area when they can't find housing.
I think that's consistent too with the challenges that we face in Western Sydney. I can understand that rural and remote have some of those challenges around housing, cost of living pressures, and also connection with family and friends too when it requires you to be making a decision around work. One of the challenges that we specifically have within Western Sydney, and I'm sure it's in regional areas too, is the GP shortage. And this is significantly affecting in people in many different ways. We know that people with chronic health issues and particularly chronic mental health issues are more likely to see and more likely to need contact with a GP. And the delay in people being able to connect particularly with a bulk bill GP is getting more difficult all the time. And the availability of GPs when it's not just normal business hours, as it's people don't always have their challenges when, or they're not always unwell when it's regular business hours. So that is a particular challenge, I think, that needs to be addressed, not just at a state level but at a federal level, and I'm looking forward to having some of those conversations too. One of our biggest challenges is actually the ageing profile of our GPs as well. So a very significant portion, 20% of our GPs are over 65, and the median age of GPs in Fairfield alone is 68. So that just goes to show that a lot of the people who are actually performing this very important, I call it community service, are doing it because they feel committed to it, not necessarily because I'm sure there are other things that people could be doing at age 65 to 68 as well, but people do, and people work in the sector because of that reason. I think one of our challenges is making sure that we are bringing people through the system as well, and making it a valued profession and community contribution that young people are enticed into for all of those good reasons.
Thank you. I had a specific question for Mr. Cotter, if I may, which was you mentioned the Safe Side Prevention Framework in your opening statement, and I was hoping you could expand on that in more detail.
For me, as a peer worker, I do a lot of my counselling or work with people in a very one-on-one, sit-down conversation. I'm personally not a fan of the Safe Side, but that's only my opinion. The Safe Side is based, to me, very much on the medical model, and it's very much aligned with our clinical and our social work staff, where they actually put together a formulation of working with people on their safety and their suicidality. It does require boxes to be ticked and specific people to fit into boxes. Not everybody fits into boxes in mental health, especially around suicidality, risk. It's very human, it's very fluid. And to me, for me, I would never have fitted into some of those Safe Side medical models. I wouldn't have qualified for some of the help that I needed. As such, I didn't go and get help when I was suicidal. I tried to do it myself. So I think, and again, it's only my opinion, that we need to get back to the community-driven, as our respected speakers previously were talking about, getting back to that community model where we all sit down together. We sit down in a room together with a clinician, with the support team that that person's working for, and we talk about what we need to do and what works for that individual person, rather than a clinician or a social worker or a psychologist tells that person what they need to do. We need to be able to sit with them and ask them, A, whether we've got it right, whether we understand what they need, and then talk about what we need to do and how that will help them. We need to go back to working, I don't know, hillbilly healthcare. We need to go back to sitting around a fire pit and talking about what the person wants, not tell them what they need, not tell them what has to happen for them. You know, we've got to, I'm sorry, I'm passionate about this, we've got to stop looking at statistics, we've got to stop looking at figures, we've got to stop looking at all of this stuff. We've got to go back to looking at humans in a really fragile and distressed state. And we've got to remember that every one of those statistics on that piece of paper is a life. And that's what we need to look at. If we can combine the two, please. You know, I'm passionate about the job I do. I really am. But I hate the fact that I've got it. Because I'm picking them up at the broken end. We need to do the work here. And get them before they fall through that gap. And to me, if we can get some more understanding of that, and I'll openly invite every single person in this room to come and sit in a car with me and drive up and down the coast and sit with somebody who can't get access to a service because they don't tick a box or can't get to where I am. Come and sit and spend a day on the actual front. We've got to get back to working with people. Thank you.
Thank you. I can certainly hear your passion in that answer. I had another question which feels like an uncomfortable jump from there, so with apologies. My question's from Ms Grasso. I was really excited to see in the introduction to the Western Sydney Health Alliance that you work across all three levels of government. I'm a former local government councillor. I was quite passionate about the role that local government can play in health and mental health. So I was hoping you could speak to either some of the work that the Alliance has done involving councils or potentially what those opportunities are for local government to be more involved.
Yeah, I can. And I think one of the very important pieces of the work that we did was really understanding the social determinants of health and how they related locally. And it gave us a piece of, it gave us insights into then how we apply that to decisions that we make. So there are a number of partnerships that we've established with the local health district as well within councils that are particularly around looking at embedding within planning how we can achieve better health outcomes. So that's a really significant piece of work. The relationships that we have range from undertaking research, delivering education programs. Another one that we have is around a toolkit for impact on climate, for example, on health. So that toolkit approach has actually been really quite useful in modelling it for other things as well. The PHNs as well provide a real wealth of information to us that we can then consider. Okay, so we're hearing about some of the challenges around GPs. We also understand the challenges with attracting other allied health workers to different areas. What is it the local government can do to improve the opportunities that people might see in locating? This is really linking back to that previous question around workforce as well. So we're actually doing a collaborative piece of work at the moment on a workforce strategy. And we're also including Regional Development Australia in that conversation. So I think it is a really good network group that comes together, but it is about making sure we're picking the things that we can't solve ourselves. So, yeah.
Thank you. Good. I'll go to other members of the committee for questions. Mrs Carr.
Okay. Thank you very much for all being here today, and especially for travelling distances to be here today. Very grateful. If I could go first to you, Mr Cotter, if I may. We've heard a lot about the idea of peer workers, and I note from the HealthWise submission that you raise the issue of peer workers as well, and perhaps some lack of clarity around exactly what the role of a peer worker is. I wonder, Mr Cotter, if you could sort of talk about whether there is clarity or how we could better provide structure and definition. And I wonder if the other thing you could address, I see that you work with suicide, and thank you very much for that work. That is very hard work, and I'm very grateful that you're involved in it. And that is a background that you can bring as a peer worker. Given the experience of mental health is so broad and so individual, to what extent, for example, could somebody who has lived experience of psychotic episodes be a good peer worker for somebody experiencing suicidality or the reverse? If you had some comments about that, I'd be grateful.
It's a really good question, and I'll do my best on that. The peer work movement is really quite new, and as such, I've been really fortunate. I've been working as a peer worker for 5.5 years in this role, and I've watched it transition over the years. When it first started, a lot of people really didn't understand what a peer worker did. And as a lived experience peer worker, be it from suicidality, be it from drug and alcohol, be it from trauma, you know, the concept of lived experience peer worker means that I don't have any pieces of paper on the wall. I know what it's like to be curled up in the fetal position on the end of the bed. As such, from that, I can take a phone call at 9 o'clock in the morning that just says to me, give me one good reason why I don't die today. And when you give them the answer that you're supposed to give them, they just tell you a wrong answer. And then you draw a breath and you sit there and you go, because I just don't want you to. And from that, the answer comes back as that's all I needed to hear, thank you. My experience as a lived experience peer worker means that I can sit and look at somebody in the eye and they don't necessarily have to explain to me what it is they're going through, because we've been there ourselves. And as I said, be that suicidality, be it either sexual abuse or domestic violence, a lot of it all folds together. It's a matter of just having trust with somebody. And my role is to sit beside the person and help them talk about what they want. There's still understanding coming with that. You know, we laugh sometimes, peer workers at the bottom of the food chain because we're not qualified. Then you go to social workers, caseworkers, whatever. I've recently had the pleasure of working with a social worker who became a peer worker and brought an amazing depth of knowledge with it. Personally, my opinion, I think everybody doing psychiatry or social studies should come down and spend time on the ground with the peer workers and actually be able to admit that they have a lived experience. And I'll be really honest, I was at Wollongong University 2 years ago talking to their Bachelor of Psychology students, and I asked them in a safe space who amongst the room, and we had about 30 people, and asked them who amongst the room had experience of suicidality. And about 12 of them put their hand up, and then I asked them who would be prepared to admit that when they were going for their qualifications. Not one person was, because it would be detrimental to their qualification. I want to know, I'd be happy to sit with the person I'm talking to knowing that they have a lived experience. And if we've still bring professionals in that are afraid to admit that they have a lived experience, we're running round in circles. You know, we've got to be able to put our hand up. We've got to change stigma. We've got to do it within the workforce. I'm a lived experience and I'm proud of it because I'm a survivor. Every day I struggle to get out of bed. I sat out here today wondering whether I had any right to walk into this room.
Very pleased you did.
But this is what we do. And we help people to understand that they're not alone, that they can get through it. And we can still be valuable.
Absolutely.
You know, we can bring our voice because we've been through it. We need a bit more recognition, you know, without getting political. Our pay rate's horrendous because we're not qualified. I get paid more an hour to go down and wash dishes at the pub. And I'm not holding somebody's life in my hand.
I think that points to some variability in how lived experience is utilised across the sector. Certainly our experience of our lived experience workforce has come from working closely with Roses in the Ocean, which is around aftercare after suicide, to develop a very specific position description before we actually embarked on our very first lived experience worker, which was probably 5-6 years ago. And having that role of integration within a team. So surveying our workforce, are they ready for lived experience? Do they understand what's happening and how this role will complement their work? And it's interesting because some of our research recently we did, 5 years later, where are we now? And certainly the acceptance of the workforce has changed quite significantly. Qualification-wise, I think as an NGO, we've been able to identify what we consider as our minimum qualification. Lived experience is part of what you bring to the role, but that's not what gets you the job. And so our expectations are around the contribution of lived experience being equally valued, because it is a very valuable experience to bring to the client and to the I hate to say it, the holistic care of clinician. Lived experience should work interoperably. And so I'm sorry your experience isn't like ours, but we have had the opportunity to really explore and embrace the lived experience workforce and really value it.
It is getting a lot better, and I sit as part of the Roses family as well. I'm part of the Lived Experience Advisory Panel with Suicide Prevention Australia. I also sit as a lived experience advisor with Living Works Australia, and part of lived experience panels with Roses in the Ocean. So we're all working, and it's pleasing to see that people like SPA and that are developing lived experience advisory panels. And I recently chaired the roundtable white paper on how we sustain the workforce for Suicide Prevention Australia. So we're learning more as we go, but there's still a lot more to go. I was fortunate, I was employed as a lived experience peer worker. But for me to go anywhere further than that, I have to qualify through, academic registration. I've got to get qualification. So I go nowhere until I get more medical qualifications.
Okay.
So we're getting there.
Thank you. Ms Galloway, Ms Ingle, you raised workforce issues, and I was very distressed to note in your submission, when your comments in relation to term of reference E, that you think rural services are actually getting worse rather than better, especially face-to-face services. And I wonder if you could maybe help us understand in what ways they're getting worse. Like, are there fewer psychiatrists, fewer psychologists? What's the situation on the ground?
Certainly happy to speak to that, and this is a survey of our workforce and our committees and lived experience workforce on the ground. So I think it is probably speaks to the fact that with a diminishing workforce, probably an increase in locum GPs, if there is, if that's the right, I'm not sure a locum is, so there's intermittent GP access. So a lot of the resources that were previously available, have a relationship with your local GP, perhaps are not there anymore. There's also a response to what's been, apart from the socio-economic impact across rural Australia, we're also seeing the residual impact of disasters. And I think when we look at that psychological preparation, that's work that we need to address now, because it's on the horizon coming towards us at a great rate of knots. And I think it's also a testament to the fact that there has been a change in the complexity of people's presentations. People are, whether they're delaying or they're utilising, not recognising the fact that their symptoms and their well-being is deteriorating, often until they are presenting a much more complex, therefore it's a slower recovery, a more complicated recovery, and then access to the services that may be required are just not there.
But
So
it's getting worse, not better.
I would believe it is.
Okay.
Models of care that have been imposed in funding bodies don't necessarily match what the needs are of the community. Now that we've got a sessional-based model of primary health care, if you live in Glen Innes, then that NGO's got 100 sessions and has to share it across the town as to who gets services within the primary care. Don't take me literally, but that's what I mean. That sessional target means that NGOs have to constrict, and therefore full recovery is probably jeopardised.
Right. Okay, thank you. And my last question, and again it's quite a change of pace, is Ms Grasso. Thank you for a very comprehensive submission, and I note you're outlining the challenges facing the very rapidly growing area in Western Sydney, and you're looking at factors which can compromise mental health, being single, being unemployed or underemployed, increasing feelings of isolation and loneliness. And you also point to living in high density housing. And I wonder whether you've done any thinking or whether you have any concerns about the impact of the planning changes that have been flagged on, and what impact that might have on increasing mental health issues for people.
Yeah, it's very interesting because the growing household profile for Western Sydney is actually lone households, which is it's something that we need to address when we're thinking about housing provision, but not just about making shelter for people, but how is it that we actually create community and connection for those people. I think that's a real consideration. I also think that particularly for Western Sydney with migrant households, there is an expectation of multi-generational households, and that's something that needs to be captured through planning and design, through the planning controls, but also the way, again, that we think about building communities and building place around development. It's critically important to be considering these matters. I think that the one-size-fits-all approach to high-density housing, and I'm a little bit concerned about the concept of pattern book, because it is not necessarily taking into consideration all of those other environmental factors that relate. Proximity to transport is probably the main thing that's been considered, but that isn't the only factor. There needs to be truly local considerations given, particularly for health impacts when it comes to planning. And the partnerships that we do have with the local health district through population health to be doing some of that more localised research and planning, sharing that those insights across other councils has been very useful. And I hope that that's something that we can continue. Considering very deeply those social determinants of health, the same social determinants of health are also the same things that impact on mental health. And certainly the exacerbation of pressure on family households is extremely important, and the way that actually then impacts on people's ability to manage their social interaction and what they choose to spend their money on. It's on the essentials rather than on the things that actually give them joy and the things that enable them to connect with other people is of consideration too.
Right. Thank you. Thank you.
Mr. Donnelly.
Oh, thank you, Chair, and thank you all for coming along, and first of all for your submissions, which are all very good and helpful, but also coming along today and just providing us the opportunity to ask you some questions and probe a bit further. I'll just start, and if it's sort of just so that there's three organisations represented at the table, so I'll just, with Ms Galloway and Ms Ingle, consider you as one organisation, but you both can contribute, obviously, and Mr Conn, obviously, and Ms Grosso. If I asked you the question that, with respect to your respective bailiwicks, so we talk about New England Northwest, the beautiful Bega and Eurobodalla, and Western Sydney, and specifically the arc of the LGAs you cover, Ms Grosso. Is there anywhere that a person can go to find out what are the, open quotes, mental health, close quote, services available in this neck of the woods? That's my first question. Secondly, how would that person know that what they're looking at is comprehensive and would have faith, or could have faith in fact, and to the point where they'd be prepared to know that this has got a reputation of being a place where I could go to see that what I was looking at was accurate and up to date?
So I'm happy to start
Yes, please,
from the New England Northwest. So I think that there's a couple of directions there. One of them is the health pathways model, which has been rolled out within health for a number of years.
That's New South Wales Health.
That's
Yep.
New South Wales Health. The health pathways for our organisation has been problematic because of the changes in programs and the ability to say, well, okay, actually we don't do that program anymore, this NGO now does it. So keeping it up to date is problematic, but with our comms team have come to a solution, so we keep our website up to date and then link it through to Health Pathways. So that's community access as well as health professional access. There's also a program that we were previously running called Prima, which was is going to take on the role of intake and assessment, like Head to Health, and whereby we have access to who are the resources around that are funded by the Primary Healthcare Network. So undertake a mental health assessment and redirect that referral through to the most appropriate service available for that person, funded by the Primary Health Network. So that's a partial directory, because we need a working knowledge within our footprint, who's where, what have they got, you know, and it might be, yep, okay, we've got Headspace in Inverell, but hello, we don't have it in Weewar, you know, that kind of thing. So that is within our ability, but a referral's got to hit us before we get that information, you know, we can distribute that information. I think promotion of the Head to Health website is really what's coming through, and Health Direct. You know, I want to find a mental health service in Boggabri, where do I go to look? You know, you type it into Health Direct, they'll say there's none there, but they'll say there's one, you know, but we know that from Narrabri to there, that's a visiting service. So I guess a short answer from us is we innovate to be able to deliver the information.
And,
that's very helpful.
And from the point of view of a government who might be making changes and who commissions services, do you provide a comprehensive communications component in your contract to support people who work in mental health to do that? Because if you expect the providers to be educating their communities, not an unreasonable expectation, who's paying for that? And if your contract's ending, I don't think the communications person's staying in place to fully advise what's happening in the community. So if there's investments to be made at all levels of government into information, and I think a previous contributor today also mentioned that we need to be aware that when we're seeking this information, we're not sitting in a place of peace and quiet, we're in stress. We've got a family member in distress. It needs to be simple.
Thank you. Mr. Cotter.
As part of the collaborative's idea, and we were formed in May last year, we launched, and as we say, we have over 30 organisations in the collaborative and working with us. One of the main things we did, and it's simple old-fashioned, was we actually put together a wall chart or something that could go on the wall that showed all of the services in the area, that somebody could pick it up and look at it and see what services were available in that area, so they could go to help when they needed and what contact numbers were there. Unfortunately, again, contracts run out, people don't get services renewed. That is literally a full-time job, is to keep that up to date. We've got over 30 services at 30 organisations. A lot of those services look great on paper, but a lot of those services might have one staff member who may only work 3 days a week. So while it looks really good on paper and government can pick it up and go, wow, that area's got all of these services, staffing and accessibility to it, we can't always explain referral programs, we can't always explain how people can get to us. The only way somebody can get to me in my program is to come from ED or from community mental health. We don't have soft referral pathways to get them to us. It's still something we're trying to do. A lot of people don't know how to get help until they need it. You're not in a position to be able to sit down and take the time to read something. A family member's in distress or you're in distress.
Yeah.
You continually tell people to ring the 1-300 number. That takes time, and that's not always a situation, but that people can sit and do. I've had the really hard experience of having to ring the 1-300 number and try and do a escalation on my own son. And as somebody in the field, what I had to go through to do the escalation on him, anybody else would turn around, put the phone down and walk away.
Yep.
It's not a friendly service. It's not. You know, we're trying to get safe havens open. We hear safe havens the big way to go. They are. For Christ's sake, let's get them open. I sat on a co-design panel for our local one in 2021. It's still not open. Hopefully it's open.
Well, sorry, can you just elaborate on that? Which one are you referring to there?
The Bega Valley Safe Haven, which is part of community mental health and part of the Towards Zero program. Safe haven is where somebody in distress can go and sit.
Yes, no, I was just wanting the location. Yeah, no, thank you.
Bega Valley.
Yep.
When we did the co-design, we were working on one for Queanbeyan and one for Bega.
Right.
For some reason, the money was cut for Queanbeyan. They only decided to go to Bega.
Right.
It's still not open.
Right. Well, it's good to know.
We don't know what the delays, been a multiple delays through health, through council, through whatever. You know, we've now got a spot team open, which is great. They do amazing work.
Sorry, who was that again?
Spot, the regional spot team, which is suicide prevention outreach team.
Right.
They opened in 2022. They've been doing amazing work filling the gaps. But they're still not staffed adequately. There's not the funding there to staff them adequately through New South Wales Health. We're plugging gaps. We're not doing it properly. We're reactive is the problem. We're not proactive, we're reactive. When a problem comes up, we try and fill the gap. We don't look ahead. I don't know where that comes from. I'm just, you know, we laugh at times, and as I said, we call it hillbilly healthcare. We do what we do.
Sounds friendly.
Doesn't always fit our NGA's, you know,
I like
funding model.
Yeah.
And we consequently get slapped in the back of the head sometimes for doing things. But how we advise people of where they could go, I don't know, because in that level of distress, we can't get it out to them properly. And we can sit down and tell somebody that there's a service that they could go to, only to find out that they're losing their contract in 6 months. And it's a 3-month wait period to get into it. I don't know the answers. I really don't. I wish I did, and hopefully some of it will come out of some of these.
No, your evidence is very helpful. I mean, it's laying it on the table, which is very helpful.
I'm afraid I'm very, very much like that. If you ask a question, you got to get an answer.
No, well, yeah. No, they've been quite fine answers, so appreciate your evidence. So just moving across now to Western and Southwestern Sydney, just understanding the availability of services that are there. Is there a source or a point or a domain or hub that someone can go to find out information?
It's probably outside the scope of my knowledge.
That's okay.
So it's something I could take on notice.
No, thank you. Yes, because there's been evidence to this committee on more than one occasion that there's much out there, but this connectivity between the person in need at the point in time when they need it and making their way to, I guess, ideally by a straight line, because it's the shortest distance between 2 points, is not readily available, and often people do struggle to...
Without knowing what that information might be, or those services, or the networks to those services, certainly one of the biggest challenges is the digital equity issue in Western Sydney, and the first place that people would most likely do if it wasn't from a referral or from advice from someone directly would be to go to the internet, and digital equity is certainly a significant issue, digital literacy as well as digital access.
That's important evidence. Would you, if you can, elaborate on that, if you've got some broad detail, and then take the difference on notice if you want to give us some specific details, but it's a matter of some significance.
Yeah, it is. So it particularly became apparent during COVID.
Yeah.
And for a range of different reasons, and we talk about, you know, I think you mentioned earlier, Glenn, about telehealth and some of the challenges around reliable access through telehealth, connectivity. It's more than that. It's actually people having access to devices. It's people being able to have access to Wi-Fi or broadband connections. It's the challenge of lower socio-demographic households not having devices for all members within the household, and some of them either being taken to work or taken to school every day, and just access not being available. Certainly with an ageing population as well, confidence with being able to navigate is a particular challenge, and similarly with people with English as a second language, challenge with whether if the navigation exists, that there's actually language appropriate advice as well. So from a digital equity perspective for Western Sydney, it is a real issue. I could provide you with some data, but on notice.
Perhaps I'll just finish on this. All my colleagues just returned.
No,
Okay. So this is what you call a Dorothy Dix one, so you can sort of go for your life. So we're going to produce a report at the end of the inquiry, and grateful for your evidence and all those who participated through either their submissions or coming along and giving a hearing. If there was just one matter or one real issue that you would like the government to focus on, listen, let's be generous and say if there's two. So if you've got a priority of two for each group, and because you, through all your work and experience and thinking and engaging with others, you've identified as, amongst all the matters to be dealt with, really one that just sticks out as the number one or number two priority for this whole matter of what we're covering in this inquiry. What would you identify and say?
Yeah, I could give a non-clinical answer, and Anne could give a clinical answer. It's
That's
probably reflecting our background.
That would be nice. Yeah.
And Anne can talk about the way services might be delivered, but it comes back to funding and the 5-year contract. If you can be brave, listen to the advice for the Productivity Commission. The 5-year contract provides continuity of care for all our communities. It erases this need to update everything. You know, some of these issues we've touched on. People have a job for 5 years. People can get a mortgage and buy a house. They're there for 5 years. They're part of our community. So from that point of view, and within that, looking at where we were 5 years ago is different from where we are today. Have the capacity within the contracts to deliver the service that the community needs. If that includes social prescribing, have a contract that allows that to be included. And yes, it would. That's certainty from a non-clinical perspective, as delivering services to a community for better mental health outcomes. Access, continuity of care will be achieved with a longer contract period.
Thank you for that. Ms. Galloway.
Certainly one of the take-home messages that I'd like you to hear is about the rural primary mental health care workforce, and I think that the ability for workforce development, future-proofing our rural health workforce is a priority. In mental health, we have demonstrated the value of an interdisciplinary, skills-based workforce. I think there's opportunity to reconsider the models of education that we have for our health professionals. I feel there's probably an opportunity to challenge whether or not a university-based small on-site prac is the model that's going to work across the rural health workforce. I also think consideration for NGOs who take on student placement from Goodwill needs to be considered, and what does that student placement look like? We're not just fitting students in to make up hours and sit in the corner, to have a really genuine career pathway. The other thing around primary healthcare nursing and that nursing workforce that is vulnerable, and when you're looking at workforce career pathways for nursing, you know, you automatically think GP practice nurse, but there is a role in primary health care, certainly where we are looking at the integration of physical and mental health needs. And I think that in all of the mental health disciplines, and including lived experience, we can't underestimate the value of that social connection, that a clinical connection, and also that medical connection. So I don't know what you call that. It is a biopsychosocial model, but it's kind of taking it back to the grassroots.
Holistic, yeah. Thank you very much. Mr. Cotter.
2 points. First one, I just want to echo Louise's point the fact that if we want to sustain our workforce, we've got to keep them. We need to keep them. We need to fund the programs better. We need to make sure that we know we've got work. As I said, the last couple of years, every year I find out whether I've got a job at the end of June or not. I'm lucky. I've got a mortgage. I'm settled, but we can't get people in. We can't offer people attractive jobs. When we put tenders out, 5-year contracts, please. Also, too, for me, and this is a personal one, if we're going to offer tenders, especially in regional areas, I want to see that whoever applies for that tender can pick that tender up and run it from the first day they get it. I've watched local services lose programs to a national body that's won a tender because they just don't have anybody in that area. And it's taken them 15 months to put somebody on the ground there. So that service disappears overnight and isn't replaced. And then it's replaced by somebody 600k away on a phone. You know, if someone's going to tender for something, give it to the organisations that can run it, that are on the ground, not to an organisation that can pay a better tender writer. Sorry, it's passionate for me.
No,
because I've watched it happen. I've watched it happen with a service that provided direct bereavement support. That company lost the contract. It took us 15 months to put somebody on the ground since then. In the meantime, there was nobody there for those people. We picked it up privately because there was no organisations there. So we did it on our own time.
Thank you for that.
Support the workforce. Make it an attractive workforce. Offer them job security. Look at the tenders better. Look at the contracts better. Look at how they can provide it. You know, I'm sorry, telehealth in our region, a lot of us are on ADSL. 27th of December, due to problems in the exchange, our ADSL services went down. They were up and running on the 16th of January. That was 3 weeks where people in regional areas that are still on landline and ADSL had no access to internet, had no access to health. Telstra's response to that was, the exchange broke down, we had to get parts because it's old. All they wanted to do was push us all onto NBN and mobile coverage. People don't have it. You know, after the 2020 bushfires, we've got people still living in tents in areas where there's no access and no telehealth. So it's not the way. It is in some areas and it's great. A lot of people just want to sit down face to face with people and talk. We've got to make that part of the tender processes. We've got to make it part of the service delivery because you can't beat sitting down with somebody face to face.
Just conscious of time. Thank you very much, Mr. Collar. Ms. Grossadian.
At this level, I would say fair and equitable service funding allocations and provisions that are evidence-based. So when we say evidence-based, it's more than just statistics and data. It's actually considering all of those social determinants of health and how they apply in a very local context. And locally based services and facilities that are adaptable to a growing population, including making sure that we have culturally sensitive services.
Thank you very much.
Okay.
Thank you all.
Thank you. Thank you so much again for your time preparing submissions and travelling to come in today. The Secretary will be in touch with you if there's any questions on notice. Thank you.
Thank you.
Thank you.
Thank you very much, Ms Wilcox and Dr Flynn, who've appeared in front of this inquiry previously. So we only need to swear in Dr Wright today.
So I swear that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth, so help me God.
Thank you. We appreciate you reappearing at this stage of the inquiry, and I'm sure you've been following it closely. Did you want to make an opening statement today?
No, thank you, Chair.
Okay.
Thank you.
Thanks. I had a couple of questions myself for today. The first one's relating to the HASI and HASI Plus programs. You are probably aware that the committee undertook a site visit to a HASI Plus in Carlingford earlier this week.
Yes.
And I was really interested in the process by which people are allocated to those kinds of services. I was trying to get an understanding of the scale of demand or potential wait list. I got quite a complicated answer that the individual service doesn't actually keep a wait list, because if there isn't a place available, they're essentially bumped to another one that might have a place available. So I'm hoping you might be able to give us a sense of what the demand is statewide for that type of service and whether it's being met.
Yes.
You go ahead.
All right, thanks, Chair. So, yep, I was aware of the visit, and I think it's fair to say the facility are very grateful for the committee's interest in the facility and the consumers there. It is so HASI Plus, just to go to HASI Plus, is a statewide service, and so that means that intake can be discussed centrally, but demand, even though the baseline demand for these services is high, at times there can be gaps, and often that's, for example, if a consumer is identified in Sydney as appropriate, but the bed that's available is in Tamworth, and there's understandably a family or a personal discussion that may not be optimal. To come to the first part of your question around how people are assessed for community supported services, it's a spectrum from people who may have less formal supports in the community. There are NDIS participants in SIL. There are HASI and CLS, which are essentially the same program with different names. They're from different eras. And then there's HASI Plus, as you know, that is clinical plus wraparound NGO psychosocial support. And we want to add to that as a part of our ambition is the PCLI, supported living services, which in a sense is a more intense support than HASI Plus. That program hasn't yet commenced. The way that we work out, or the way that clinical teams work out who's appropriate, is often related to an assessment of someone's functional skills, their abilities, and hopefully their capacity to demonstrate to the team and to their carers and their family where they're at on a spectrum around things like self-care, cooking, ability to work, all the way through to medication, shopping, that sort of thing. So it's actually a fairly sophisticated assessment. It's done by different members of the team. So originally you'd be familiar with the model of, at least sort of when I started working in the system around 25 years ago, often that might have been a single social worker on a team who had a lot of expertise, but because the programs have developed, we've now got NDIS support officers in some LHDs. We've got PCLI staff who are not part of the build of the PCLI program, but go into hospitals and work out who's a person who'd be appropriate for NDIS or HASI or HASI Plus. And it's quite it's an advanced skill to make sure that you've got that assessment right, because I think it's profoundly disappointing, mostly to the consumer, but to those around them, if for some reason that assessment is wrong. It's often tried out, so we don't tend to put someone in a supported living position and say, end of story, can't come back to hospital. It's done in a graded way to make sure it's the right facility. But I guess I can understand why the local answer to that question is a little bit unclear. It's a statewide service.
Thank you. That was a really helpful information, but didn't quite answer my question, so I'll try and be really specific. Are there people in New South Wales who would like to be in a service like a HASI Plus, who are assessed as would benefit from being in a service like a HASI Plus, but who can't get a place?
At this stage, I mean, over different periods of time, the answer to that question would be yes. I understand. I'm not sure about HASI Plus. I think HASI itself may have some vacancies, but I'd have to come back to you with whether or not there's a numerical number of people who are waiting for a HASI Plus
Thank
position.
you. Happy for it to be taken on as I'm really just trying to get a sense of supply versus demand for these kinds of really wonderful intensive programs.
Yep.
Thank you.
No, that's fine.
Thank you. I wanted to ask about a recommendation we heard this morning from the Australasian College of Emergency Medicine. They were talking about the need to extend operational hours of psychiatry and mental health specialists that are able to do assessments in emergency departments. And I understand that we're talking about hospitals, so it's slightly adjacent to the scope of this inquiry, but it's relevant, but it's because it's to do with the wait times in EDs. I suppose what barriers would need to be addressed to be able to implement that recommendation?
I'm happy to take
Do you
it
want
all.
to do it?
I'm happy to have a first pass at that, Chair. Can I just be? I just want to just be specific. Exactly what the recommendation was. It about increased specialist clinical psychiatric supports in EDs?
Yeah, so they were talking about the significant wait time when the emergency department staff have recommended specialist assessment. So whether that's either the psych reg, the psychiatrist, or the clinical nurse specialist coming to ED to do the assessment, there are scenarios where that wait is extended because of those staff members not being available overnight or on weekends or being over capacity.
No, I'm very happy to answer that. And the first thing I would say, and it's a really important point, is that we agree that emergency departments ideally should be avoided. So I think that's that's not a minor point to make. I do want to say that's a commitment. I also think, however, that it is not necessarily a failure of care if an individual finds himself in an emergency department, because if someone is really unwell, that's a health emergency, and that's what an emergency department is for. Different people may wait for different lengths for services, but I am aware, as I'm sure you are as well, every graduate of a health profession in Australia who finds himself working in an emergency department does have skills around talking to people, de-escalation, listening. Every junior medical officer in Australia has been assessed on their ability to take a mental state examination. And so I'm just concerned the assumption might be that this person is not really, in a sense, in the care of the emergency department, but is simply waiting there for a mental health team to come along and assist the emergency department with their own patient. I very strongly feel that people with a mental health condition have equal right to the expertise of people in an emergency department, and that can start as soon as that person comes in the door, as it would if they had pneumonia or a broken leg.
I don't disagree with what you're saying, but this is in a context where we've heard from emergency physician specialists who have extraordinary skill in mental health as part of their generalist qualification. So if they've assessed someone, for example, as likely needing an inpatient admission, who then does need to be seen by the admitting psychiatrist or their registrar, the ASIM has identified this as an issue. So I'm interested to understanding practically what...
I would briefly answer that and might pass over to Murray, but my view is that it depends on demand, but we have tried very hard to supply in-person psychiatric staff in terms of clinical nurse specialists, psychiatry registrars, telehealth support across large patches of regional New South Wales where a consumer can have an assessment via video conference, and 24-hour on-call specialist psychiatric cover across the state in every facility. I do accept that at times there are extended waits. I just want to make the case that, similar for every other consumer in the ED, it's not simply a matter of waiting for another service. It's really important to see the two services as working together. I'm very sensitive to any narrative that says, we're waiting for something. It's actually it's an emergency department to assist, but there's no standardised time data that is kept around, statewide, but I think emergency departments definitely would have access, but it would vary depending on who's available and how busy the department is.
Do you want to add to that?
Yeah, so I might make a couple of additional comments. I think that Dr. Flynn's overall point, which is that mental health care in an emergency department is collaborative between all the parties, including the emergency staff. I think that what I've seen over a couple of decades is that as particularly our larger hospitals and emergency departments have become busier, and we've initially gone from an on-call after hours registrar presence to an extended hours registrar presence, and in some places a 24-hour registrar presence, and that's on the basis of the sorts of issues that ASIM is raising, and I think that there is a conversation within psychiatry about whether that should be followed by finding a way to create an extended hours presence of the more senior psychiatrists. It's enormously challenging because there are constraints, the biggest one of which is workforce. And so it's all very well to say we would like this, and even if we say we can afford it, but to find the workforce who are suitably qualified and willing to do that is a challenge. But I think it's a legitimate question to be raising, and I think that again, endorsing Dr. Flynn's comments, we are working very closely with our emergency department colleagues and have done for quite a long time to try and find collaborative solutions. It's not in the very old days. It used to be quite an adversarial relationship between mental health and emergency. That's not the case anymore, and we welcome their ideas and want to work constructively with them.
Thank you. Last question from me. I'm conscious of time. You are probably aware that the committee's demonstrated some interest in interstate responses to mental health emergencies, and particularly we had as a witness the representative of the South Australian Ambulance Service. I know they're not identical programs, but it bears a lot of similarity to the MHAT program that was trialled in a particular LHD. If I recall correctly, it was Western Sydney. Were there any particular reasons that wasn't continued or rolled out more broadly? As I understand it, there's been really positive feedback from people who access that service and also from the staff who worked in it.
Yeah, I don't know the evaluation of impact. But
I don't know about the evaluation of that either. I'm aware of that. I think it's Western Sydney. It does get very good feedback from consumers and staff. I think it's also accurate to say that the PACER program has a lot of very committed staff and has had some very good feedback from consumers. What I think our challenge is to work out what the right combination of responses may be. So PACER will be right for some places. MAT, I think, is really well received in its community, but the challenges may be supporting first responders with mental health expertise, be that clinicians, be that peer workers, in a way to do that is safe and that is meeting needs, particularly where there's geographic and workforce challenges in regional New South Wales. But I am aware of MAT as one particular program, but I would emphasise there are other similar programs, in particular PACER, that are also well received.
Thank you. Thank you all for being here. Dr. Flynn, if I could just pick up on something you said in response to a question from my colleague when you were talking about provision of psychiatric services, and you made a comment really directed at regional New South Wales where you were talking about availability of consultation via video conference. What is New South Wales Health attitude? Are there areas in regional New South Wales where consultation with specialists like psychiatrists are only available over video and face-to-face is not available on a regular basis to health consumers?
Thank you for the question. So the question I answered was about after-hours support in emergency departments.
The question remains, after hours, is support only, is face-to-face only available in limited hours? What is the mix for regional and rural hospitals, and people presenting?
Yes, okay. Look, I would say that it varies, and I might take, maybe if we took an in-hours picture first. So if we were to look across regional New South Wales, and if, for example, if we took community mental health clinics, it varies, but there are many services that have a face-to-face clinician. Doesn't necessarily need to be a psychiatrist, but often is. And I think we're all aware that sometimes that's on the basis of a non-resident.
I don't want to cut you off, Dr. Flynn. I'm just wondering,
okay.
in the interest of time, is that something you could take on notice and perhaps provide details of to us later? Given that it varies, as you've said?
It varies. To be honest, it would be, I'm not sure I'd necessarily, I'm very happy to take that on notice, but I guess it very much depends on the locality. There are places where it is delivered via telehealth. I'd need
So there are localities where it is only telehealth that's offered?
There would be.
And why is that? Why no face-to-face services offered for regional New South Wales?
I did not say that there were no face-to-face services offered for New South Wales.
If it's only telehealth, by definition, there is no face-to-face.
But I'm not talking about regional New South Wales. I think the question was about particular areas in New South Wales.
Well, which areas is it only telehealth then?
I would take that on notice, and can certainly get back to you around that. But
I'd be very grateful. Thank you.
Yep.
Thank you.
Thank you.
Another quick question, if I may. I notice on page 15 of your submission, you point to the New South Wales Family Focused Recovery Framework 2020-2025. Do you have any preliminary data on how well that's working and what change it's making in terms of inclusion of families in healthcare?
I would have to take the data question on notice. I certainly, if it assists a committee, would mention that the feedback we've had from consumers and staff, and in particular families, has been very good. But I would need to come back to you around the nature of an evaluation and the details of what was in that.
And is a review of that planned at the end of 2025?
I'd need to come back to you about that on notice.
Okay, thank you very much. And one last question, if it's possible for a quick answer, and I accept it may not be. I note the discussion on page 9 of your submission where you talk about presentations being triaged according to clinical acuity. New South Wales Mental Health Services focus on consumers with higher clinical acuity and complex clinical needs. Who focuses on people with lower clinical acuity to stop escalation to higher clinical acuity?
It's an excellent question. I'm happy to pass to my colleagues, but I'm happy to answer it. It is a joint responsibility of NGOs, primary care, some of the bilateral funded services that are sort of colloquially, and you'll be familiar with the language now, of the missing middle, and sometimes specialist services who happen to be available and have that person referred and have capacity and say, look, we might not be the right service, but we can certainly help you with the lower acuity work. It is, I guess, one of the themes, I think, of evidence that you've heard, and I think it's an accurate comment, is that it can be very confusing for community members with so many seemingly different options, trying to work out perhaps who to call or which service is appropriate, or even it's actually very difficult for an individual to know where their distress lies, because for them it's significant, whatever a clinical view around that might be. So I think, I hope I've answered that question, but I would say it's a joint responsibility between those
The question was
services.
who focuses on it, and what I heard is nobody but everybody, good luck.
I think that's probably, I don't think that's quite fair.
Yeah, can I just make an additional comment? I don't think that's accurate. I think that in an ideal world, it's initially an appropriately qualified primary health response, and primary health sits. We've got primary health networks who are responsible across the state and the country for delivering that range of services, and it is a shared responsibility. And as Dr. Flynn said, that if someone finds themselves with a low acuity condition in a specialist mental health service, they'll get an initial assessment and perhaps initial treatment. But it is about matching the person to the skill and the resource that's available. And so what we have in Australia is a matrix of Commonwealth and state funded private, public and NGO services, and I accept they are sometimes difficult to navigate, but the low acuity area of responsibility is largely with the primary health and NGO sector.
And Chair, through you, if I could just add to that, just in relation to our primary health network colleagues, the geographical remit of the PHNs, as we call them, in the main overlay directly with the local health districts, and there's joint regional plans done in mental health so that we connect the lower acuity and the pathway for care into the more higher acuity complex care that you expect a local health district to provide. And literally just this morning we met with Beyond Blue, talking about them strongly defining their role to be in that area of low acuity prevention and a partnership with Lifeline, because to both Dr. Wright and Dr. Flynn's point, it is a matrix. It's about a collection of all of us working in a particular area and who's best placed to do which part, but so it's clear and defined for consumers and not a confusing thing to navigate, which I acknowledge is sometimes the case. Just if I could just make a comment on the framework too while I've got the mic, if that's okay. I'll be very quick. It is a document that's lifespan is to 2025, and as Dr. Flynn rightly pointed out, we've had anecdotally good feedback. We will start a review process probably later this year or early in 2025 and collect the evaluation, the data, and refresh the framework, because its natural lifespan is till 2025. Thank you.
Thank you. Thank you. I'll go to the government if you've got questions. It's not budget estimates.
Look, I just wondered if you would be able to update the committee on anything else that's happening in this space. We visited some great initiatives locally, like a safe haven as part of our regional trip, and I just wonder if there's any updates to provide around safe havens more generally, if we've got any openings soon or anything like that.
You want to do that? Yeah.
Thank you. Yes, so look, we've got 19 operational safe havens. I think the issue might have come up today around the opening of Bega, and I've had advice that is actually scheduled for Monday, the 19th, which I think that's this Monday, isn't it, the 19th?
Yeah. Yes, that's right.
So, and for Wyong to open in April. So I think that's an important update. The other thing I'd offer about safe havens, and I think I honestly can't remember if it came up at this inquiry or at estimates, but there was a question around evaluation of that initiative. There is a evaluation drafted, and it's due in the second quarter of this year. And we, hope to be able to report back around that. Certainly, there are, there's feedback that people find the service very helpful, but there's also, certainly ways to make what at this stage is a sort of developing model of care even better.
Yeah, thank you.
Thank you.
Thank you. Thank you very much for making the time to come back and take our questions twice. I'm sure there'll be some questions on notice, so the Secretary will be in touch with those.
All right. Thank you, Chair.
Thank you, Chair. Thank you, Committee.
Thank you very much.
Yes, we do. Thank you very much to those in the gallery for your interest in our inquiry, and to anyone who's still watching online. That brings us to the end of the day.